Morning. How are you? Good.
Good morning. I just want to start off this morning by thanking Andrew and Chelsea for the tour yesterday. I think everyone got a lot out of that tour, so thank you very much. We're going to get started again. If we go to the next slide. Again, the same rules of engagement apply. Ask you if you have a question, just to turn your name card up on its side. Allow the chair to recognize you. Please state your name clearly so my note takers and the recordings, we can capture that as well. Later on today, we're going to have public comments. Public comments we're in the receive mode only. There's no exchange. We allow the public to share their concerns with us. We do not get no Q&A with them. So I just want to, for those new board members, I want you to understand that process. And we'll talk about some other BCOB processes here pretty soon. But right now, I want to turn it over to Rob Baglin, the chair. Rob?
Good morning, everyone. I thought yesterday's meeting was really informative and also really encouraging. I have to say, in the 3 years I've been on the board, I don't know that I've been able to feel as much progress as we felt yesterday on the campus and begin to see what the future looks like here. So for those of you who are new board members, I hope you get a lot of encouragement from it. One administrative note, we talked about the subcommittee structure, and I wanted to share with you a few thoughts that the Vice and I have discussed. Up until now, we've had 2 subcommittees, and they've mirrored the emphasis of the West LA Leasing Act. One, you remember, was advice and recommendations for the Secretary on land use and implementation of the master plan, and the other was a subcommittee on services and outcomes for veterans. And we think we've been well served by that subcommittee structure. Those subcommittees are where we begin formulating recommendations, where we do a lot of the work to research them and refine them before they get a full airing before the full committee and are put to a vote. We want to preserve those 2 subcommittees going forward. And so I'm going to ask that everyone, both existing and new board members, email the Vice and me after this meeting with your preference on what you want to serve on. So if you're an existing board member and you've served on one committee in the past, that doesn't mean you have to remain there. General Sutton and I are going to take a fresh look at how all the subcommittees are staffed. And if you want to serve as a chair of a subcommittee, mindful of the extra work and the obligations that has, please tell us that too. I served as chair of the master planning subcommittee for the last 2 years, and I have to tell you, it was incredibly rewarding. Hopefully this position will be as rewarding, but it was great to be able to actually work on the exact text of recommendations and really dive deep into the issues. And so for those of you who feel like you have the energy to do it, I'd really encourage you to consider it. The other thing I wanted to share with you, again, kind of came out of my discussions with General Sutton, is that for the time being, I'd like us to form a 3rd subcommittee, and that subcommittee will focus on the needs of women who have different or special needs as a result of either military sexual trauma or domestic violence. The housing needs of that population can be different in a way that's not always recognized by the traditional market definition of affordable housing. And that subcommittee would also look at questions around children on the campus. And so with respect to that subcommittee, I'd ask anyone who wants to also volunteer for that work to indicate that they're willing to serve on that subcommittee. So just to recap, I'd like everyone to pick between land use and services. And if they also have the time and the energy to volunteer for that 3rd subcommittee around military sexual trauma, domestic violence, and children. Okay? And I would suspect that by the next meeting of the board, which I think we're targeting for either April or May, we'll have that whole subcommittee structure up. Any questions? All right, and then the only other thing I wanted to share with you all is I passed out something this morning that has some highlighting because the question of leasing authorities came up yesterday. You remember we got a presentation from the Office of General Counsel And they explained that in 2016, this West LA Leasing Act was passed, giving the agency certain leasing authorities. And the first of those, 2B1, was what was called enhanced use leases. That's something for supportive housing. And then the second was 2B2. And those were described as service leases. And those are the leases that promote health and wellness, education, vocational training, peer activities, socialization, stuff like that. What I wanted you all to understand was that Congress gave the agency that service lease authority, 2B2, because of the results of the first master plan. So that's what this slide illustrates. So in other words, in 2016, that's on the left side, after a 1 or 2 year planning process that involved land use advisors, architects, a draft master plan was published. And in that draft master plan, they described a zone 4 of the campus. And zone 4 was the town center. And what you could do is you can look at this language and you can see that each of the activities that were described for the town center were a few months later described by the Congress in the West LA Leasing Act. So the master plan came out in June, and Congress passed the West LA Leasing Act in September. So I want you all to understand that that service lease authority was contemplated as the method by which to implement the town center. It sounds like legalese. Apologize. But I think as we talk today, the significance of this choice will become really apparent. Any questions? All right. So I think I now hand it over to the vice chair. Do you have anything, General Sutton? Meg County, good morning.
I don't have anything either. Looking forward to really engaging in some great discussion. We've got some great topics on the agenda today, so looking forward to it. Then I think John.
I'm going to keep the momentum going, so I'm just going to pass it to the right to my colleague, Dr. Harris.
We could do this all day. The only thing I wanted to say is I really appreciated on the tour yesterday, all the questions. It really felt like we could have stayed at each stop nearly the whole afternoon. This is a very intellectually curious and passionate group. And I wanted to encourage you all to take note of the questions you have and the areas you have questions in, because we can speak them actually for your board chairs, but we can frame the kind of presentations we give you in future meetings to answer those questions and really build out your understanding, both of past work done by this board, but also things like just understanding the veterans we're trying to serve better, the numbers, the demographics, things like that. That's all stuff we can do for you. So keep the questions coming.
Thank you, Rob. Keith, since you broke the mold, I'll do the same. So good morning, everybody, and I want to echo my thanks for the time and attention during the tour yesterday and throughout the day. I think it is really, really important to actually see with your own eyes and feel the sounds, the sights, the texture of what is happening here. It's one thing to look at it on a flat piece of paper and a map. It's another thing to actually see the environment that we're working on. Look forward to the discussion today, but just to pull the curtain a little bit back on what else is happening around our healthcare system today. This morning, our emergency operations teams are meeting. We've got a severe weather event here in Central and Southern California. So we have a very active and very strong emergency management program here. So we are in contact and coordination with county offices of emergency management. We are ensuring that our employees can get to work and veterans can get to their appointments. Our transportation networks that every single day bring veterans from San Luis Obispo and Bakersfield here to this hospital are able to operate, particularly with snow predicted on what we call the Grapevine, which is the mountain pass between here and the Central Valley today. So those are some of the things that are going on while our teams are also doing rounds on this campus to make sure storm drains are working, areas are clear of mud, construction sites are safe. So while we're all meeting here, there's a lot of activity going on in addition to healthcare we deliver, and sometime maybe a discussion and an information exchange about our emergency management work would be a worthwhile activity. So thank you all.
Actually, Eugene, I just thought of something, you know, when we took the tour yesterday, first of all, better yesterday than today, I couldn't help but be struck by the teamwork. And sadly, I just had a little chance to talk with you yesterday, but I don't see anything on our schedule about your one team concept. Could I see my time? Do you just give us a little snippet on how you all have built this team and this concept and just how proud you are of it?
Yes, I'm happy to. Is it better if I go over here or is it okay to sit? Okay. I have a mic, so, and I'm obviously just as tall sitting as I am standing. So my name is Sally Hammett. I'm the chief of the homeless programs here at VA Greater Los Angeles Healthcare System. And we did talk a lot about one team, and that comes from the spirit of recognizing that VA needs our partners in order to be successful in any operation. And so places across the country work very closely with their COCs, and there are a few medical centers that engage in this process. They don't call it one team, but they intentionally bring partners around the table, and particularly leaders around the table of a community, to ensure that we're leaning into each other's expertise and talent as we move to end veteran homelessness. And so John actually spearheaded one team here. John, what was that, about a year and a half ago, I'm thinking? And I was lucky enough to be asked to join the team a little bit into that. And our efforts really focused on creating a leadership forum where we can create policies and procedures to end veteran homelessness efficiently and effectively. And what we were finding, our COC is so big that we didn't have a mechanism in place to come around the table to do that. And so we developed a tri-chair structure. Jim Zenner is one of my co-chairs. Of course, we have VA at the table, and I represent as a chair. And we also have an SSVF program director from Salvation Army named Chris Gilrath. And every week, tomorrow at noon, if you ever want to pop in and see this meeting, we come together with anywhere from 60 to 85 leaders across our catchment area. And our main topic of discussion is how do we create policies and procedures to drive our efforts throughout this community. So we developed a data and performance group because we know, as we discussed yesterday, we all look at different systems. We all have different platforms that we enter information into. And so we need to be looking at that with a close lens to ensure that we know who in our community is experiencing homelessness, whether that's unsheltered or in transitional housing. We have a by name list refinement case conferencing group. Intentionally, we get together every week, depending on the service planning area or outlying area, and we look at that by name list. And we have chairs that are set up in each of these work groups. And again, intentionally, a non-VA individual along with a VA individual. So we can kind of create an opportunity where we learn from one another what our challenges and struggles are. I know I'm kind of in the camp that I can't be creating all the rules and expecting all my partners to follow those rules that I create. It doesn't make sense for all of us. And we have some other groups. We're developing an education group and a racial equity group. We also have an SSVF HUD-VASH collaboration group because we know we need to house people now. And if we then need to bring them back into case management services, we can do that. And we have a mechanism to do that throughout our catchment area. The last group, and it's no particular order, but access and triage. We don't want to close the doors to folks entering our system. We want to open the doors wider and make sure that we have several access points across our community so that if a veteran shows up, we know how to get them into emergency housing and we know how to get them into transitional housing now while we work toward a permanent plan for their journey on housing. We recognize that prevention is a real issue in our community, and we're finding that folks are really close to falling out of housing. So we need to wrap around those protective services through prevention opportunities to help them. So this one team group, again, we meet every Friday as a team, but we've also had some convenings. I think we've had 2 face-to-face convenings, one at Bob Hope Patriotic Hall, about 240 some individuals across our community, not just leaders, but the frontline staff doing the work, because we recognize that in order to do this right, they have to buy in and they have to contribute to our decision making. We also have quarterly meetings, so we meet virtually with regular cadence so that we can be sharing the efforts. I think our newest challenge that we're undertaking right now is ensuring that we're consistently reconciling our by name list. We feel really confident about our VA data because we have a number of sources that we can pull our data from. But we also know that our by name list is captured in HMIS and not everyone in our system uses it. So we've had to make some changes and lean into our partners to make sure that we're moving toward aggressively engaging in a coordinated way of bringing folks into housing. That's a snapshot, and hopefully that helps describe it, but I think the key here is the relationships, the partnerships, and recognizing that VA cannot do this alone.
Good morning, Sean, do you want to talk?
Sam Holmes. Sally, you mentioned that VA across the system coordinates with the COC. Can you touch a little bit about how the COC participates in those one-team meetings?
Sure. So we have actually one of our co-chairs from Data and Performance. Her name is Jen Escobar. She is the veteran representative for LASA. I will say, in my opinion, and Jim, I'd love to hear your thoughts here. I think we need more robust support from LASA, and I recognize there's been some challenges there and some strains to be able to do that. But we can't, our system is just too big to have one person as a point of contact. We do also have an export-import type system, particularly for HUD-VASH, and making sure that we can share information. But we don't have a good system in place for our databases to be able to talk to one another. It's just not possible. And so that takes manual effort and reconciliation of VA platforms and then connecting with LASA. I think ideal state would be for there to be a refresh of that by name list on a daily basis, because when we have people uploading information from various access points, we're not going to get a good sense of who's on our list unless that's done. Personally, I think every day. We're hoping that we can do a reconciliation every month, looking at VA data and looking at LASA data, but we're finding some barriers, and those barriers include perhaps an agency didn't check the veteran status on the key indicators. And so we have someone that's a veteran that could really benefit from our services, but unfortunately they're not being uploaded onto that list. So lots of reconciliation happening, lots of conversations, and we could use some more support from LASA to be a part of that.
When y'all are speaking, especially for the new members, can y'all define like LASA and LACDA and maybe explain the differences? Because I'm seeing a lot of like, what's LASA?
Yeah, so we have a lot of acronyms, and I apologize. I should have explained that. But so LASA is LA Housing Service Homeless Services Authority. Thank you. So Joint City County Commission. And it's the continuum of care. So when we say continuum of care, LASA is in that lead role.
This is Sarah Hunter. So they, just to kind of give a generic description of LASA, they are Los Angeles County's continuum of care, and they report to LASA every year or every other year on how many people in our county are experiencing homelessness, and then they get allocated money based on that. There's a few exceptions. Long Beach has their own community continuum of care, and then what is it? Pasadena and Glendale. So they're excluded, but most of LA falls under LASA. And so many years ago, the city and the county agreed to come together, and so it is a joint commission.
Thank you.
Is that helpful?
And LASA is a strong partner, and you'll hear more about master leasing later and how we're leaning into their support for that. Across the country, COCs have a board, and there's a person that sits on that board in the veteran seat. Our system's not set up quite like that, so one team is an effort to create that own veteran-specific working group of leaders and offshoot work groups to make sure that our system is working collaboratively.
Jim Zenner had a question?
No, just to add on to what Sally said. Yeah, I agree. There needs to be more robust participation from LASA. We have Jen, who's the overall systems coordinator, but we really need somebody from their outreach team to be on the call. We need somebody from their data team to be on the call. We have specializations that need to be on the call because they know their system and they can really speak to the needs that they see on their teams. And without that presence, Jen can't be all things to people. So it's really kind of, we're at a disadvantage not having somebody from each of those teams.
Sally, I wanted to follow up with a question about maybe have you explain to the group the evolution of our understanding of the veteran homeless population as it's moved from a point in time count and the inferences that relied upon to a by name list today, so that people understand how much movement we've seen on those two issues in the last 3 or 4 years. Can you give the group a sense of those aggregates?
Sure. So I think I'll have to pull it up, but the 2023 point in time count data showed us about, and help me if I'm wrong and somebody has this number, but I'm seeing the number like 3,800.
3948.
3948. Thank you, John.
Exactly.
And the importance of just knowing what that number is and actually understanding who those individuals are is kind of this transformation to a by name list, and really recognizing every single person in our system who is experiencing unsheltered or sheltered homelessness. And without that attachment of those names and understanding the programs that they're eligible for and who's connecting with them, what we often find is duplication of services. And so you have many organizations doing their best work and working with individuals, but not talking with one another and not having a systematic approach to coming together and determining housing intervention, outreach efforts. So transitioning to just seeing this big list of individuals and knowing these numbers to actually intentionally coming together by service planning area or outline area and meeting together as a group of VA and non-VA individuals and going through that list and ensuring that we're offering housing. We're not putting people on a list and waiting until somebody's ready. We're actively working with those individuals. And for those that are not ready to go into shelter or transitional housing, there's intensive and collaborative outreach efforts to try to engage those individuals because, as we talked about yesterday, it just takes one yes. And so we want to continue to have those conversations. And I think, Rob, it's been interesting to see that transformation. We're not completely where we need to be. We're still working through some challenges, and it's not intuitive to move to this type of system. And I'm looking at you because of your work in New York, and seeing that transformation is really exciting.
I may have missed it, but we have a count on the by name list.
So the last time we did a reconciliation, we were at 2,168 individuals. And we believe that that's a much closer number than the pit count number. Because, and I feel like I should turn it over to you, because Dr. Harris worked with a team of folks in VACO to be able to look at VA data and pull a variety of data points to get us to that reconciled list.
Before you do that, let me recognize John. I think John had a comment.
Yeah, so first, some late breaking news. LASA is looking at providing some support on the data side. So we hopefully will get some more information on that in the next week. I also thought in terms of level setting, does everybody know how LA is structured with the COCs, what spas are? So LA is very big, and most COCs get together and everybody gets around a table and talks about, for instance, in our by name list, who's being served. Because LA is so big, we have things called spas, which are sort of regions, where LA is broken up into 8 different spas. In each of those spas, there's essentially a separate by name list, although we do have one master list. Each of these spas works a separate case management meetings, which Sally set up. So that way the local providers who are sort of more in touch with the local community are meeting with appropriate staff, both within the VA and our partners. And each of those communities in each spa is doing what we're describing that typically happens in a single COC in those cities. So that spa structure is unique to LA, and I think it's important to understand that, to understand how we organize services to these homeless veterans.
All right, we'll go to Keith and then Patricia.
Okay, great. I think the question you're asking is existentially important to this work, because among other things, it is going to be the thing that determines, for instance, the final number of housing units we try to build on this campus, and getting more and more accurate, both current estimates and then projections based on that going forward. I did want to speak to the delta between the pit count and the by name list a little bit. So in case it wasn't clear in what was already said, the way the veteran pit count is done is, for any of you who've done the pit counts here before, the count, the tally, you don't even speak to the people you're counting. You're simply looking and clicking a button. Apart from that, LASA works with USC to do a months-long survey. And I'm sorry if I was actually in the middle of something. So sorry, Sarah, if you already said this part a moment ago. Okay. There's a month-long survey where they interview people in kind of a sampling procedure, and that's where they determine things like veteran status, other forms of demographics, et cetera. That sampling procedure is then used to essentially get proportions that are then applied to that larger tally. So the veteran point in time count is not there is not a known person for every one of those 3,900. That is an estimate based on proportions that come out of that survey. The by name list is real names, real known people. That doesn't mean the by name list is right and the pit count is wrong. There are so many ways that somebody might not be on the by name list. And Sally was referencing this, but in our reconciliation work where we took the by name list, the active, the one that the one team is working from, and merged and sort of reconciled that against VA data, there were hundreds of known homeless veterans in our system that were not on that by name list. So I just want to encourage caution. The answer is probably, like most things in life, somewhere in the middle of those two numbers. And we're doing a lot of work, and we need to do more, and we need more support from LASA to do some of this, to get that by name list as accurate and comprehensive as possible. But that's going to be an ongoing, really important question for all of us, of just how many of these veterans experiencing homelessness are there? How many do we expect going forward?
Okay, thank you. This is Patricia Wajuwaku. So two questions. I'm familiar with SPA, but I wanted to know, does the COC overlap in terms of the way that SPAs are broken up? Is that, and then that's one question. The second question is, with this transition to by name list, is there a way in which we're tracking the services that each one of these individuals that are kept, being identified by name, what they've been provided over time? Does that make sense? So what services? So for example, if they were in the CTRS, if they've got, some sort of house, that sort of thing. So that we can look back at individuals and know what they've actually been provided over time.
So a couple questions there. So first, spas are part under the COC, so they're not separate COCs, they're a part of the COC. And by the way, I wanted to give the accurate, it was 3878. One of the things we've done for the first time this year, Keith talked about the survey process, is we've joined USC in that survey process. So for the first time, we've had outreach workers, because we want to do more than just count people on the street. We want to get them off the street. So we're going out in these, describing as blitz events, to try to connect veterans, and we're actually using the survey process to get veterans off the street. While we're also doing that, we're also using squares to validate whether they're veterans, and we are finding sometimes people say they're veterans and they're not. So we're hoping we're going to get a more accurate hit count. I don't think the difference is going to be very much. We thought initially it would be higher, but it's going to be a small difference. But nonetheless, we're using this to try to validate the number so that we can get that hit and the BNL more accurate. On the BNL, yes, it's absolutely function. It's more than just collecting lists of names. We want to track services. We want to know that every veteran in that BNL has a plan to permanent housing, where they're at in that plan, whether they're being engaged successfully. So we really want to understand how they're tracking essentially through the process of permanent housing, and why it was so important for us to begin entering information in what's called the Homeless Management Information System. That's the HUD system that collects data nationwide, or the HUD mandated system. Previously, what's been a challenge, and this is a challenge for VAs across the country, is VA has its own system called HOMES, and everybody else uses HMIS. So to create an accurate by name list has been a real challenge. We've looked at all sorts of technical solutions which don't work to try to combine them. So we're just literally, and I think Sally spoke to this earlier, reassigning our staff. My secretary now is doing HMIS data entry, because we need to get an accurate by name list. We need to make sure that everybody, not just VA and not just our providers, are looking at the same sets of information. So when we get together and talk about veterans, we're talking about the same veterans. We all know who these veterans are. So getting us to enter into the by name list, this is a unique thing for VA. It is time intensive, but it's necessary for us to do what you just asked about, making sure that we know where the veteran is, where they are in the service, and what we need to do to engage them successfully.
Sarah Hunter, you have the last question before we move on.
Sorry, you opened up a can of worms. I have a lot to say here, but thank you, Keith, for you talked about that point in time is just an estimate. I want to emphasize that, and I totally agree that we're probably somewhere in between in terms of what you guys know. I would defer that you have a better sense of who are veterans than what's calculated the point in time count. RAND does its own efforts to enumerate people on the street. Unlike the LASA effort, we're only in Skid Row, Venice, and Hollywood, but we do this every month. We go out and count. So we have trends. We also do surveys. So if you have the resources to send your team out with us to verify people's veteran status, we would welcome you to come out with us. We do ask them, but I agree, self-report there's some error in there.
Where that helps.
I couldn't hear that, but.
We can give you access to squares for your staff.
Oh, that would be terrific. So when we did our study a few years back, we went out with the VA outreach team just to plan our study. At that time in 2018, there were only 5 VA outreach workers serving all of LA County and beyond, because you guys serve, as you said, San Luis Obispo, Ventura, whatnot. I don't know if that's changed, but what that means, I think that's important context, that you're really relying on LAHSA outreach workers and all the nonprofit outreach organizations to identify veterans and get them to services. I mean, with 5 people, there's just no way you can cover the whole county and beyond. So that's very important understanding and context. When we went out with that VA outreach team, at that time, they had no way of checking someone's status. The only thing they could offer people was a flyer, a handout, say, hey, come to the VA. You know, in contrast, I went down to Long Beach and they go out with 2 vans. So if someone's ready right then and there to receive services, they can put them in the van and get them to their outreach facility. So I hope there's been improvements. My guess there is improvements, but I just wanted to raise that and provide that context. Other important context about these service planning areas or spas in LA, because we're so big, almost every single one of them is operated by a different nonprofit provider who uses a different system, and they don't always, you know, talk to each other. Now, they're all supposed to use HMIS, but we also have a whole swath of providers that don't participate in HMIS. Those are oftentimes churches and other, you know, more small-time providers that are providing outreach that don't get government funding, so they have no requirement or reason to participate in HMIS. So our HMIS data is flawed, and just know that. The nonprofits that are operating in the spas, they use it, but their staff are really, you know, they go into this job to provide direct services, not to sit in front of a computer all day. Again, it's just important context about the HMI system and why I'm sort of, you know, I'm hesitant to rely on that to be our be-all, end-all numbers when you guys do a much better job of capturing veteran status. So anyways, I just wanted to inform the rest of you of some of those issues and concerns. Thank you.
Eugene, you're up.
Morning. Again, Eugene Skinner. Rob asked me to briefly cover some of the recent recommendations that have evolved out of the last 3 committee meetings. I'm going to do a high-level overview of those and trying to give you an idea, especially the new board members, the process we go through, the process of recommendations. Next slide. The first set are from the 19th BCOAB, which was held back in May 2023. I will tell you, Rob gave you a great binder that covers every recommendation this board has ever approved, the process, the results, the secretary's decisions, et cetera. So I think, Rob, thanks a lot for that, for putting that together for board members. But basically, the recommendations from the 19th BCOB pretty much covered asking the secretary to draft a letter to the CEO of LA Metro, expressing some of the concerns of this board, and the board, of course, reflecting the concerns of the community in that request. As you all may have received from me, a copy of that letter the secretary did dispatch to the CEO of Metro. The CEO of Metro has also returned a response to the secretary's letter. So again, you can see in your documents there or here those recommendations that the secretary concurred and took action. Next slide. The next meeting I'm going to cover real briefly, overview, is the 20th BCOAB. What you'll see basically from 2002-A and pretty much to the rest of the chart there are recommendations that basically the board members wanted to have access to information. This was tasked to the ACMO, Jeff's group here. You were briefed by him yesterday, requesting them to provide us a website space where we can store that information. Of course, I didn't have it, came back to VEO or to the DFO, and that gave us justification to go reach out and have this done. So basically, if we go to the next slide, what we have come up with, Maggie, can you click on that link for me? So we just started to build a website where we can store that information. So you as board members or even the community, because everything we do here is open to the community, that you can reach out and get that information as required. Just give Maggie a second, kind of had to do some tricks. But this is basically in construction. This website is being built as we speak. One of the things that we have to deal with, anything we put on this website has to go through the 508 compliance clearance, if you might. And once that gets cleared, we'll upload it. So as you can see that, we'll scroll down. This is what it's going to look like. Maggie, you can scroll down, please. It reflects our purpose of this BCOAB. Continue on down, please. Pretty much reflects our charter, what it says in our charter, what's West Los Angeles Leasing Act also says, which reflects our charter. There's a copy of the charter you can click on, or you can even access the 2022 master plan. Again, that's all here. And if you scroll down, we don't have to access that. This is where all the board documentation is going to be held. So if we pick on, let's say, our meeting in June 2023, if you need to see the notice of meeting, agenda, meeting minutes, it's all there. I asked her to click on the notice of meeting. You heard the Advisory Committee Management Office discuss the notice of meeting, the timelines. These are the actions that lead up to our meeting. We have to notify the public in the Federal Register that we're going to have a full committee meeting. This is our vehicle to do that. We notify them. Pretty much, I have to have this submitted 30 days prior. It has to be published 15 days prior to the meeting, to the public, so they'll know the WebEx links, the general topics we're going to cover in the meeting, and how the public can have access, both in a hybrid fashion, that being via WebEx or in person. It also identifies the time frame by which we will allot time for public comment. Again, that's on the front end of a meeting. That's good, Maggie. Thank you. We go back to recommendations. And so what I showed you in the 19th meeting, the 20th meeting, were recommendations that have gone through the process. When I say the process, they've been brought to the BCOAB. We've had a quorum, we voted on them, and then once we voted on them, they're approved at this board. The chair will provide a cover letter and submit those recommendations with all supporting documentation to me. Once I receive those documents, I will then determine who's the appropriate organization to task to develop a response on behalf of the secretary in response to those recommendations. I then will task that out via the VA's tasking network system and allow adequate suspense for the organization who's responsible to provide a response. For example, if I know the response is going to come from the Greater Los Angeles, the folks out here at GLA, I have to task their headquarters at VA, who will in turn task the VISN, where Dr. Bramer resides, who will then in turn task GLA. They'll have to develop a response, and they'll have to go back up through the same way it came down to get approvals. Once I have received all the responses, I then put it in the package, and I send it to the Advisory Committee Management Office, who then staffs it within VA leadership, VA headquarters, to Office of Congressional Legislative Liaison, Office of Public Information, OPIA, Office of General Counsel. All those folks have to concur. And once they concur, it goes to the exec sec, prepares a package, presents it to the secretary, will approve it, it comes back down, and we'll publish it with his decision, with the secretary's decision. That process, I'm given 120 days to complete that process. So that kind of gives you a timeline of how long it might take. It doesn't always take 120 days to process these recommendations. Next slide, please. So all the recommendations from our meeting at DC are recommendation 2101. Currently, where they are in the process, they have been sent to exec sec. So they're under review, and we're waiting on the secretary to approve. Yes, John? Can you explain what the exec sec is? The exec sec is executive secretary. They are the executive support for the secretary.
Manage all the correspondence.
The correspondence, okay. Manages correspondence in and out. So the certificates you received yesterday, they came out of the executive secretary. All right. As you can see, if you look at the book that Rob provided for you, but the first couple of recommendations here out of the last meeting are focused on the AMI issue that Dr. Harris spoke to yesterday. There's a couple of recommendations that were provided by the master plan subcommittee that speak to some property at Santa Monica. They want to find out some information with regards to leases and deeds and titles. And then the rest of them pretty much are about a job center here as part of the town center and looking at different job training for veterans here on campus. And the final one pretty much talks about student housing at some of the local colleges and partial release plan. And then one of the recommendations proposed an alternative partial release plan. These all the recommendations, again, are in the process right now at the executive secretary. Are there any questions? Jeff Moran.
Jeff Moraney. Just a point of order. Subcommittees draft recommendations, parent committees approve recommendations. You say that just so that nobody's confused with how these recommendations move from a committee to the secretary. Subcommittees also report to parent committee. They don't report to program offices, medical center directors, visions, or anything like that. They only report to the parent committee. Thank you for that opportunity.
And it's also worth adding that when we are talking about stuff on email as a subcommittee, we should always include the designated federal officers, Eugene Skinner and Chizito. That's an important measure of transparency for all the subcommittee work. Let me just add a couple of things to what Eugene was saying. We ordinarily expect, we know the executive secretariat's work is challenging and responds within 120 days. So the executive secretariat serves as a filter to take all the agency's advice, whether it's from the general counsel's office, the congressional and legislative affairs, whether it's program offices, and reconcile that advice for a decision memo to the secretary or deputy secretary. And so that's a complicated staffing process, and we have to be mindful that we're not always going to get that 120-day response. But there is one recommendation coming out of our last meeting in September, where we really emphasized the urgency of it. And I want to share it with you all and discuss it with you because it's urgent right now, and those of you who are new board members are jumping into a fast-moving river. So I want to show you what it's going to take to swim this. So if you go to tab 21 in that binder I provided you, you can see there's a recommendation 21-04. And the real key thing when you get to 2104 is on the third page of that, there's a graphic that's entitled Current Parcel Release Schedule Map. And then if you flip one more page over, there's an alternative parcel release schedule map. So the master planning subcommittee worked on this last fall, and what we did at the time was try to figure out where we are relative to the goal of 1,200 units. And could we meet that goal by concentrating residential redevelopment in the North Campus, north of Nimitz Avenue, and in a way that would preserve the town center area for use as a town center. In other words, not having residential development within the town center area. So I wanted you all to become familiar with this because it illustrates some of the concepts we discussed yesterday. So we went and visited 207. That's the building that we walked through yesterday. Remember when we came out, I pointed out there were a couple buildings to the right. So 257, for example, is the type of thing that will be turned over under the current parcel release schedule to the principal developer to develop for housing. But the building to the right, which was the same configuration, 257, is not. So when I made the suggestion that we ought to think as a board about whether or not all these ought to be the subject of redevelopment before we move further south, that's what that's meant to illustrate. And then if you turn to the alternative parcel release schedule map, I wanted you to see that what this does is this concentrates residential development either north of Nimitz Avenue or to the southeast corner, and it keeps that central corridor that was green and that was building 13 available for use as the town center. So that's, when you go back and look at the original master plan from 2016 and 2022, that's the area that's called for the town center. So I bring this to your attention because this spring, VA is facing a choice about whether or not to turn over the parking lot that would be used for building 404 to the principal developer. We think that's okay under this plan. We just don't think it should go any further south. Stephanie Cohen, looks like you want to make a point.
You said 404. 408. Sorry.
I'm sorry, 408.
Yeah, okay.
408. So if you see under this plan, the parking lot immediately north of building 13 would be turned over, and we're suggesting that 408 should not be. But that parking lot immediately north of building 13 should remain available for the town center concept. Mike Canfield?
Mike Canfield, thank you. So this is an area where maybe I can contribute at least some of my thoughts from experience. So I have developed communities for the last 25 years, and there's two types of communities we typically develop: subdivisions and master plan communities. Subdivisions are housing projects. You know, there folks live there, but not a lot of in terms of additional services, meeting spaces. There's usually an outside area that sort of serves those functions. What we really try to create whenever possible is a master plan community where we have a true mix of uses of a true community. And that involves both residential and the others. What are the others? Here, we have clearly a need for services. I believe those have been, those locations have been fairly well identified. And then there's the community function itself. Where do people gather? Where do they meet? Where do they have a cup of coffee? And so looking at the ULI study, it's clear to me that the folks who live out there already are recognizing some things. Some of the words that are being used are lonely, dilapidated, a medical center, not a home. It lacks a heart. There's a perception that there's a need for a common, maybe it's not a town center, but it's a commons. And the issue here is that, and every community I've ever done where we designate that community center, that commons, that's a little looser. There's an immediate need. We recognize the immediate need for efficient, effective production of housing. And it sounds like everything we saw yesterday, there's clearly momentum that's happening. The commons, the town center, is undefined. It's not clear what that is yet, but that doesn't mean it's not important. It's very important. It's just maybe not as urgent as the housing. But what should be urgent is recognizing that once you give that space up, you don't get it back. And so the pressure, again, is always take the low-hanging fruit. This is a nice, easy spot. Let's go there. Let's put houses there. And so as a developer, part of my job is to protect the master plan integrity. So that's going to serve a higher purpose for the production of a legacy of enduring pride for this community, also right out of the ULI report. This is a legacy. We're not building for just today. We have immediate needs now. We're building the housing. But this is also a community that's going to be serving these veterans and future veterans for another 130 years. You know, thank you for the family that dedicated this land and provided it to us that we still have today. It's been well stewarded. It's under our stewardship now. Let's make sure we're not taking an easy route, giving up land that we won't get back. Thank you.
I'm going to recognize Stephanie Cohen for the last question of the morning before we start with it.
I just have a comment. I just want to, Stephanie Cohen. I just have a comment. Rob, you did correct the 404, 408 mix up, but 404, I just want to, for the record, for people listening, 404 is under construction. It is an under construction parcel, so it's not one that is like planned in the future or potential. We're really talking about 408 right now. Thank you.
Yeah, and I'll just add real quickly that 404 is not only under construction, but it's the one that's prominent. In other words, it anchors the southeast corner of that residential development. And you come up the hill, 404 is really prominent. And so it does serve as a nice anchor, I think, to the end of that area. Okay, so we're on to our next presenter, Dr. Berger.
Well, good morning, folks. No, okay. All right, well, hi, my name is Jesse Burgard. I am a psychologist with the VA, and I work for the Suicide Prevention Program in VA Central Office. And I want to really thank you for inviting us to become part of your process or continue to contribute to this process. We do have the adage that everyone has a role to play in suicide prevention, and I hope through my talk today, I can connect you to some of our national strategy, the way we tend to think about this problem from a public health approach, and where there may be opportunities for strategic alignment with the work that you're doing, along with the work that we are promoting at the national level. My background, as I mentioned, I'm a psychologist. I've worked for the VA for 24 years, started in patient care, moved towards administrative work at the department level, regional level, and now working for the national office. I'm here representing Dr. Matt Miller. He is our executive director. He was just out here a couple weeks ago. I know working with Mr. Zimmer and some of the county work and state level work. He's very mission focused as anyone I work for, and regrets that he can't be here again to support this work. But know that our office is available to this process as you go forward on a consulting basis. Right, next slide. So our program is positioned within our central office, but we essentially support regional level work as well as facility level work here at a medical center like GLA. So my goal here is to try to level set some things. I know some of you are new to this board. You may be new to veteran suicide prevention. You may not have attended a lecture on it. So I'm going to try to walk the line there of giving some basic level setting of what is our approach, what is our national strategy, what are resources that are available to veterans, but also to the community and broad processes like this, while also trying to be focused enough to give some particular components of our work that you may want to be thinking about as you go forward. Next slide. So this first slide here talks about our annual report. And I'm going to touch on and really do a survey of a lot of different major components of our strategy and the scope of the problem of veteran suicide. But it's difficult to do justice in a short time. This report we publish, of course, on an annual basis. This current one is, I believe it's 88 pages this year. It really does go through our strategy, what we know essentially, and what are we doing about it. There is a link there. We have a landing page for the report itself that summarizes some of the major components of it. So encourage you, I know there was some assigned reading given yesterday, so if I can add that to your list, would suggest that you take a look at it to really give you the depth of the information that we have and the resources available. Next slide. So in terms of high-level data points with regard to this report, you can see here that the data is essentially, we have a 20-year data set at this point. It is always 2 years in arrears. So the 2023 report focuses on the year of 2021, kind of directing you to the second box there. 6,392 veteran suicide deaths in 2021. I don't report that to you as a statistic. That's 6,392 veterans, husbands, wives, sons, daughters. Speaks to the humanistic toll of suicide in our country, specific to veterans. We did see an unfortunate rise in the rate and count in the year 2021 with 114 additional from 2020. Had seen a decline in 2019 and 2020 after year-over-year increases for pretty much the remainder of that time. You can also see some other statistics here. The total count, of course, is where we focus. That's the human toll, as I mentioned. Statistically, can be more valuable to look at it from a rate perspective to ensure we're really looking at trends in the phenomenon. 33.9 per 100,000. So we also did see an increase in rate as well in the year 2021. I'm going to touch on a bit here on method, but you can see at the bottom that 72.2% of veteran deaths involved firearms. And I'm going to go over that as to why that is a very salient point and something that we keep as a major area of focus, particularly again within veteran population, because it is disproportionately higher than non-veterans. And the level of lethality of that means is a significant driver and contributor to that death rate. Next slide, please. So 2021, what was going on in 2021? Well, of course, this is the first year of measurement that COVID-19 fully spanned the period of time. And so when we think about suicide risk, one way we look at it is looking at risk factors and protective factors. Sometimes risk factors can be broken down further into drivers, which are more transient, right? So you can have something like a job loss, relationship loss, an illness, and more static risk factors, which could be age, gender, things like that. In 2021, we obviously, as a nation, and as a world, experienced a number of factors that we could count in the risk factor or driver category. Some are listed there to the left. We had losses. In terms of overall mortality rates, financial strain, housing instability, very relevant to this group, rises in anxiety, depression levels, substance use, family relationship strain, right? With all the pressures on our families in terms of childcare issues and trying to balance employment issues. And then we can also look at protective factors. What are things that perhaps waned or declined that can serve as that buffer and protective factors? So some listed there to the right in terms of more difficulty accessing healthcare resources, particularly mental health resources in person. Loss of social support, saw increases in firearm purchasing, and so more access there to lethal means. Next slide. So firearms, let's talk about that. This slide has a lot of data points. As mentioned, the frequency of use of firearms as the means is significantly higher among veterans, about by 20-some% higher compared to non-veterans. We see that trend increasing. So veterans have that disproportionate likelihood of using a firearm, and that trend is continuing to increase. Not surprisingly, general firearm ownership is higher among veterans, but also concerns about secure storage and how veterans may be due to familiarity, comfort around firearms being around, they may be less likely to secure them. Now, some people, when they start hearing about this, they begin to say, well, why does that really matter, right? If a gun is locked in a box versus not. If someone has a volition and a thought to end their life, what's the difference if they have to get a key and open the box? And one thing that we know about suicide attempts, not in all cases, but in the majority of cases, is that they are actually impulsive decisions. Yeah, not in all cases, but in many cases, they are impulsive decisions. And so we speak in suicide prevention around time and space. By putting time and space between a person and any lethal means, but particularly a firearm, is a protective factor when it comes to preventing suicide. That could also be true of pharmaceuticals as well. Right? You could say having large sums of lethal levels of pharmaceuticals available can also prevent that same. And so things like not holding large 90-day supplies of medication, at least not at arm's reach. Putting medication in blister packs is considered a way of slowing down. Again, that impulsive decision where someone may only consider an action for a few minutes, right? And so that extra 5 or 10 minutes can make the difference in terms of having a tragic outcome. Next slide. So if you want to look at our strategic approach in a slide, it would be this, that we recognize that suicide is a complex problem. That there's not one single cause, there's not a small number of single causes. It really is a multidimensional phenomenon, and as such, our approach has to be equally complex, equally broad-based to essentially mitigate all those variables and provide those protective factors that may be of greater importance to one veteran versus another. And so this broad approach. So in the lower right there, that everyone has a role to play in suicide prevention, that is one of the key tenets. And I think something for this group in particular to take in mind, that the decisions that you make here can, particularly when we think about upstream versus downstream, right? You're familiar with that term in public health. We can look at things if we want to prevent a bad outcome. We can do things right before it, right? So a veteran is in crisis, calling the crisis line, getting the veteran to the emergency department. That's something that we would call as downstream, right? It's, if you think of a metaphor of a waterfall, we want to prevent going down the waterfall. Well, that's stopping a person right as they're going over the waterfall. So we want that there, and that's a very important part. But we can also go way upstream, right? When you think about let's not get to the waterfall at all. What can we do upstream? And that's usually where we're talking about protective factors. But like Mr. Canfield was just talking about protecting space for community. Well, one of those upstream things is connectedness, is the term that we use. Building connectedness. How much an individual feels connected to their surroundings, to the fabric of their community, is considered an evidence-informed prevention strategy. So those are some of the lenses that I think, I hope to have you think about as you do this important work of how do we design this community in a way that really inculcates as many protective opportunities for protective factors to happen, right? It's not the space, but it's what happens in that space that veterans are able to stay connected with one another. So that's that everyone has a role to play, and that's part of number 2 there, that public health approach. So that suicide prevention is, yes, it is inpatient hospitalization, it is a crisis line, and those types of things, but it is also a community-based approach. So community and clinical is what makes up our public health approach. And then, of course, the number 1, I'm going in reverse order here, is that we hold that it is preventable. It's not inevitable. That what we do does matter to many individuals. Next slide. So in terms of that community-based approach, if you say, well, what does that mean beyond what I've said, or how do you operationalize that? On this slide, you see a number of circles kind of overlapping in a Venn diagram. And you know, the summary of this is to say that when we think about it in community-based interventions, we really can look at it at the national level, at the state level, you know, all the way down to the community level. And VA supports and promotes a number of endeavors here at all of those different levels. One resource that I want to know about is every facility has a community engagement and partnership coordinator, or CEPCs, kind of back to the acronyms. Alex Robinson Norris is the CEPC for GLA, and her role kind of fits in that. You see that towards the left, bottom left there, the community engagement. The CEPCs are an individual that every medical center has. Their role is to support the Governor's Challenge related coalitions that come together. And the coalitions are community run. So these are not VA run. The VA doesn't set what that group is going to do, but what we do is set the frame. We have a dedicated staff, full-time staff, that is out of the medical center supporting the creation of these partnerships. LA County has 6 of them actively. Now they do work on things that we believe are evidence informed or evidence based. And so the key areas or areas that we promote the coalition to think about is the lethal means safety, as I've talked about. What kind of things can we do to create that time and space? Identification of veterans at risk. So it is an important piece to know when a veteran moves into risk. And we know that risk is dynamic. It can change moment by moment, day by day. So how do we create systems that are going to be more likely to recognize risk? And that can start at that broadest level of training everyone about what are the signs of suicide risk, right? And so that's where, as you build a community, you know, what type of opportunities are available for staff to be training all the veterans, having some kind of cadence where that training is occurring, that awareness building is occurring. In VA staff, we have a training called VA Save that every employee has to take every year through an electronic resource. But folks like CEPCs and particularly our suicide prevention coordinators, I'll talk about in a moment, also offer those trainings. All right, next slide. Now, in terms of the clinical focus, so the community, right, building these coalitions, they're community led and they're tailored to what are the local needs. Now, when we look at clinical-based interventions, these things we work on to be, in the way the opposite, more standardized. So what is VA's approach at this hospital, at any hospital, in terms of how we clinically approach suicide prevention? So on the clinical-based interventions that you see here, just highlighting a few, you may have heard about the REACH-VET program. The REACH-VET program is a statistical program that looks at risk factors that are available in the EHR, the electronic health record, and allows us to risk stratify veterans based on a number of variables that would probably be more than a clinician would be able to quickly ascertain, upon looking at the record. And we curate out the highest risk individuals, put that into a list to someone who is looking at those on a monthly basis. Are those veterans that seem to be at really elevated risk engaged in care? Are they getting support? So we kind of have that type of approach. And then our risk identification approach really looks at screening. And so every veteran is screened annually for suicide risk, every veteran, regardless of any factor. So think of this as your primary care doctor when you go in and they ask you certain questions. In VA, we're going to do that on an annual basis for all. And then we also have setting-specific requirements where we're going to ask more frequently when a veteran presents at a clinical area that would suggest higher risk, like an intake to a pain management program would be an example. Veterans coming into the emergency department are going to get screened by the nurse, right at the front of that process every time they come to the emergency room. Next slide. Many of you who are connected or have been connected with VA know about SPCs, Suicide Prevention Coordinators, another mandated position in terms of that standardization that every medical center and very large CBOC, community-based outpatient clinic, has an SPC assigned. I don't know the exact staffing number here in GLA, but I would suspect it's a full team. So many large medical centers can have 5, 6, 7 staff, upwards of 10, 11, depending on how many sites of care they have. And the SPCs really carry a significant load. Our program at the national level supports them quite a bit in terms of policies, procedures, training. They are really our champions of the overall program that we have, help support the facility and their leadership to be adherent with policies, regulations, but they also do their own specific activities that would be relevant to this project. So the SPC and team here would be available to engage the community. They go out and do community outreach. They go out and do those trainings that we talked about to raise awareness. They are clinicians, so they are all clinicians, and they also do clinical tasks, such as when a veteran calls the crisis line, and that veteran is offered, would you like a referral to your local VA? That's where that referral would go. The SPC then reaches out to that veteran, to close the loop after a crisis call. Next slide. In terms of actual treatment, so beyond kind of that initial engagement, crisis intervention, VA has launched in the last few years a very novel program that I'm proud to tell you about. So mental health care is the basis of general clinical management of suicide prevention. So we're talking psychiatric support, psychotherapy, case management. In recent years, there has been a number of psychotherapies that have emerged as holding promise and evidence that they work better or beyond just traditional mental health care. It doesn't replace any of the traditional mental health care, but it is a time-limited, kind of manualized approach. And the best way I could describe, you see the 4 different interventions or modalities there, is that it focuses specifically on suicide behavior. So when I was trained years ago, I'm working with a veteran who has depression. I'm treating the depression, and I'm kind of managing the suicide risk. I'm checking in, making sure the risk's okay, but I'm treating the depression. Depression was seen as the primary issue. If they're less depressed, the suicidality kind of takes care of itself. This is a different approach. This looks at it to say, we're going to focus on suicidal behavior and thoughts that you're having. That's it. And the sessions will focus solely on that. I was pleased to be able to get trained in CBT for SP, that first one. And it really was a big motivation for me pursuing the position I'm in now, because I realized how different it was, an advantage of what the treatment I had provided in the past. And our approach to get this treatment out to veterans as quickly as possible leveraged our telehubs. So these modalities are, a short number of years old in terms of the literature emerging as them being, having a particular promise. So, we faced the question, how do we get this out? No one would be trained in it. They're new modalities. How do we train and get these out coast to coast and Hawaii and Alaska and anywhere veterans, seek care quickly? And so what we elected to do was hire a cadre of therapists, new therapists on top of existing therapists and the traditional mental health, put them in our telehubs, which are virtual teams at each visit or regional level, and then provide this treatment via telehealth to all veterans at the medical center using that one team. And so that's our SP 2.0 telehealth suicide prevention program. If you're interested, I know there's some clinicians in this group. If you've never looked at our VA DoD clinical practice guidelines, we align those modalities to what the evidence shows. That document summarizes all of the evidence behind different interventions. This is available at all medical centers nationwide, and I'll have some stats here for homeless veterans at GLA. So next slide, I think that may be the next. Right, so you can see some statistics here, basically talking about where GLA falls in terms of veterans who would be eligible for this treatment. This treatment is not for every veteran who may have had a thought of suicide. Because it's so focused on preventing suicide behavior, we relegate it to where the evidence is, which is veterans who have either attempted in the past, so has already engaged in behavior to harm themselves, or has significantly put preparations in place. If they meet that criteria, they then fall into what we consider the denominator of veterans who may benefit. Of course, veterans have to agree to want to do this treatment, and you can see some of the statistics there. GLA has the third highest percentage in the nation of referring veterans. So of that denominator, 32% have been referred for treatment in there, and you can see some of the other statistics there. Now, you may be thinking, well, how does that work with the homeless veterans, right? This is done by video, but VA does have what we call a digital divide program. So if a veteran doesn't have a smartphone, doesn't have a cell phone, or an iPad, they are able to be furnished one through this program. All right, next slide, please. I'm going to go through these rather quickly. One of the asks was just to give an overview of our program in terms of the components of it. We do have a data and surveillance team. That annual report that I spoke of is one of many reports that we have an entire team, actually several teams, that work on trying to curate information and put it into actionable data. We do have the annual reports that's mentioned. There's also a suicide mortality dashboard, which is more focused on VHA data, but it allows us to really drill down into catchment areas, look at VA suicide as compared to non, or some of the data I will show here around homeless veterans, looking at specific subpopulations within VHA. Next slide. The Fox Grants Program is certainly something that you should be aware of if you were otherwise not. The Parker Gordon Fox Grant Program seeks to provide direct funding to community partners that support suicide prevention work. And they're not so much straight treatment providers in terms of actual clinicians doing evidence-based treatment, things like that I just mentioned, but they really are for community partners that are looking at a lot of those upstream things that they screen for suicide, they train, they provide outreach, they can provide social support, economic and social support that would be very akin to the work that you all are looking at here. I did look at our awardees last year. There was none in this particular county. In LA County. The notice for funding, however, is open right now and goes through April. And there's a website there that you can learn more about that program and the parameters for application. Next slide. Our RPE department puts out a number of what we call from science to practice sheets. I pulled a couple of them there on the slide. So we do have one on the heightened risk of suicide among veterans who have experienced homelessness, justice-involved veterans, et cetera. So we do publish these 1-2 pagers, gives you a quick rundown of what the literature says about any of these particular special populations. So that's available online if you just put that into a search engine. And this department also does a lot of our program evaluation. When I say we try to do something that's evidence-based, we are selective with the programs we endorse and put resources into. Of course, we are therefore then needing to look at what are the outcomes of the work that we're doing. And so we have a team that works on that. Next slide. Partnerships, training, innovation, these are all other components of our department, kind of small but mighty teams. Our partnership team, as it says on here, looks to establish and maintain strategic public-private partnerships. So if there's any entities where there's an interest in partnering with us, our team can meet with that entity and kind of talk about the different ways we approach that. We have a lot of lot of people, right, of course, that come out, and agencies that come out to support this issue, as I'm sure you do in homeless prevention as well. And some are informal partnerships, and occasionally we do form into more formal ones. So know that resource is available. Education and training and innovations. We run a lot of pilots. We fund from our office a number of pilots at the medical center that look at some of these, again, innovations or focus on particular special populations, cultural groups, women veterans, whatever it may be, veterans with particular clinical needs, and look at how do we tailor services to best support them. Next slide. Policy team, a lot of legislative work around suicide prevention that drives a lot of our directions, strategic directions in terms of laws that have been passed that authorize us to do new and novel things, such as the Fox Grants program. And then, of course, policies, procedures, all of that. There are a team of folks that can help, and partnering offices like the homeless program, where we come together to make sure that we're aligning and synergizing. Next slide. In terms of cooperation with suicide prevention and homeless programs, a couple bullet points here just to talk about some of the collaborative work we've done with regard to provision of training to make sure that folks that are focused on homeless, given that high risk that homelessness presents as an independent risk factor, we want to make sure that the VA staff that are engaging veterans are well trained in assessment of risk, what to do when they need to escalate services. Number of toolkits available at the, I assume these slides are available to you. I do have a reference section at the end. You can see a number of links to some of these products that you can review at your leisure. That's the same. Next slide. These are some trainings we have coming up in FY24 where our office is working with the homeless office. Compact Act, I do want to mention that, if you're not familiar, another legislative action that is significant with regard to accessing emergent suicide prevention care. But the Compact Act essentially made possible VA to pay for emergent suicide crisis care with, specific definitions about what that entails, but essentially what you would think of: a veteran going to an emergency room, a veteran's inpatient stay, and actually a number of days of supporting outpatient treatment as the crisis resolves for virtually all veterans, whether they come to the VA or not. There are a few exclusions if a veteran is barred from care and some discharge related, but it's a broad eligibility. And really the spirit behind the Compact Act is to remove one barrier of someone seeking help, right? Of a veteran saying, I can't afford it. The Compact Act allows for VA to use appropriated funds to pay for those crisis episodes of care. And that went active January of last year. And we remain very active in promoting that, making sure veterans are aware that that treatment is available. And so that's Compact Act Section 201 is what affords us the ability to do that. Next slide. All right, I'm going to close here with just a review of our national strategy, which is a 10-year strategy document. Not going to go too into the weeds on it, but I wanted to show you kind of our main four tenets and then talk some about a couple things as I sat in, and I was really fortunate to be able to come to the meeting yesterday to hear about this plan, the master plan that you all are supporting and steering, as to what parts of the strategy that we promote at the national level really marry up to the decisions that you may be making, or the recommendations, I should say, that you'll be making. So next slide, please. So another document you can add to your list, but our 10-year plan, when it came out in 2018, and it is, as it says, comprehensive document that really looks at all of the complexity of suicide prevention when we think of it at that community macro level, as well as gets very specific about supporting things like those treatments that I mentioned, right? That we move our healthcare to not only provide general services, but that we hone those services to specialize. So it really spans both, you know, the micro and the macro kind of endeavors and priorities. There are four main strategies: healthy and empowered veterans, families, and communities. And so if you think of these four strategies as broad, you know, and getting more focused, clinical and community prevention services, treatment and support, and surveillance and research. So I think those first two are really where a lot of the work that you're looking at doing, right, is how do we support a community that is as healthy as it can be? And when we think about suicide prevention, and I say healthy, I mean, we could think about it as all healthcare services, right? Because people in chronic pain, people who have chronic illnesses, those are risk factors, right? But we can also think about, well, what is the most focused health when it comes to suicide prevention? And as I spoke about, that connection, building that connection. Purpose is another big piece. So we know that if a person feels as though they lack purpose in however that's defined, we could define that almost as like a cognitive risk factor, right? If I think I lack purpose or I can't find purpose, or taking a step further, I'm a burden. So not only do I not have a purpose and I'm not contributing, but my existence actually is a detriment to others. That is another risk factor, another thought or cognitive related risk factor. So how do we create a community that prevents that or puts buttresses in place to say, I'm connected to this community. I have a place here. I have a role here. And, you know, how does that then translate to things that you're recommending? And so as I was, you know, listening to some of the things over the last couple of days, you can go to the next slide. Sorry, thanks. So the next slide talks about that first goal there that's in our plan. But, you know, what does that look like for you all? And so when you think about space, when you think about, we talked about that, right? How do you create those spaces for veterans to connect? How do you put you know, connections such that veterans have an opportunity to contribute to the community? How do you weave in an ability to feel as though, you know, as a veteran in that community, I matter, people are counting on me, I'm contributing in some way. And of course, the very existence of this project fits into that, right? I mean, economic supports is another big piece when we think of upstream of connecting veterans to the benefits that they've earned. And in this case, you know, this novel ability to come in and have this veteran campus and community. I heard peer networks would be another piece, right, there as well. So I'll end here. Yeah, you can kind of go through the remainder of the slides, just kind of roll out the different parts of the strategic plan. But those first two kind of really speak to how do you improve the overall culture. I heard it once said that, you know, sometimes trying to find someone who's at high risk for suicide is like a needle in a haystack, right? Because it is, despite our large number of veterans and the problem that it is, when you think of it across the population, it is a challenge. It's a small number at any given time of veterans that are at high risk. And so we do spend a lot of time of finding that needle and making sure we, you know, interface with it. But there's also the how do we make the whole stack healthier? And I think that's a lot of what you're doing here by building this community.
Thank you, Dr.
I'll stop there. Yep.
Very, very informative. Jim Zenner?
Yeah, Jim Zenner. I think we saw a really good example of work to increase protective factors as an LCSW that's worked in residential for a while. When we visited 207, Tess is here. The work that she is doing to bring residents together to build that sense of community, I think is important. And as we continue to build units on the campus, that's something that we should be looking for from our developers and our service providers. One thing that you didn't cover today, Jesse, is the rate of justice involved veteran deaths as well as homeless. And so we saw 33.9 as the overall, but justice involved this last year was 151 per 100,000, and homeless was 112.9. And one of the issues that I've seen is just really homeless and justice involved falls under a homeless program office. and suicide prevention is under OMHSP.
Right.
And so I think if we're really going to effectively address suicide in GLA, we need to see more collaboration from OMHSP and HPO to target our population here in LA. And lastly, we heard a lot of good feedback from residents. But one that I want to get your perspective on is some claim that their boredom is starting to set in. And I dabble a little bit in suicide, enough to be dangerous, but I'm not a suicidologist, but I would like to hear from you kind of how you would process that feedback, looking at it through the lens of suicide.
Right, right. I mean, I think it does come back to purpose, right? So it can be doing things that matter, right? I think that's probably like the top tier way we would say, and in those modalities that I mentioned that are really focused on that, there are usually sessions spent, focused on giving thought about what is your life purpose currently? And, sometimes we get very focused on, it was my job, or, I was very physically, kind of your point around boredom. My recreation was around using my body in sports or, something like that, or work. And now I have, health problems and I can't do that anymore. Now I'm not working. And, I think it's that ability to work with veterans to adjust, change. What does that now mean? What does recreation mean now that I don't have the same physical capability I have, or I have pain that keeps me from doing what I used to do? And loved hearing in this project that you have a partnership on recreation, right? And having, and I think, thinking about, as this group, thinking about, are those resources that are available going to be accessible to all veterans? How do you make those programs as rich as possible to allow for a number of activities that people can get into? And again, I think it's that facilitating that flexibility in life, right? Is that you have to adjust as life changes to stay active and interested in life.
And I'd like to hear from Meg Cabot.
Thank you. Just two things I wanted to highlight. I think when VA thinks about suicide prevention, and your point is well taken about some of the silos and the overlap between justice and homeless and how we fit all those things in. And I think over the past several years, there's been a real concerted effort to do just that, and a lot of overlap and a lot of cross training. For example, there's a really excellent training that family members of veterans can take to learn about suicide prevention and specifically family caregivers. I liken it kind of to the JFK story about he went down to NASA and he saw an individual in the sweeping up something in the hall, and he stopped and he said, what's your job, sir? And he said, my job is to put a man on the moon. And I think that's really the philosophy that is put out by VA leadership at all levels about the importance of suicide prevention, and that this is something that we all take very seriously, and it's a part of everyone's training and all that sort of thing. I do want to emphasize the Compact Act because I think you minimize the impact that's had a little bit. We actually just put out a press release. 50,000 veterans have used that, the ability to go to a local ER because they're in crisis and get that care paid for. And then this is a really good example of, we talked a lot yesterday in our tour about lowering the barriers. And this is the same exact concept around mental health. It's to lower the barriers. You can go to any ER and VA is going to pick up the bill. So, and there's you get to the ER, if you say I'm a veteran, there's a phone number to call and that gets paid for, as well as some follow-up care with the goal, hopefully, of getting that individual then enrolled in VA and really getting on a road to recovery and thriving. So just wanted to emphasize that program for those of you who work with veterans who may not have been as aware of that program as I'd like you to be. Thanks.
Sam Holmes.
Sam Holmes, and I'm really happy that Jim and Meg were able to do social work to speak for me to qualify. I think just how important taking, I think, this whole person approach to suicide is. But what also struck me is so many of both the causal factors, but also the protective factors that the good doctor spoke about in suicide prevention could also be thought of as homeless prevention, ways to address homelessness, ways to lower risk factors for justice involvement as well. And I wonder your fourth strategic bullet about research, given I think the unique setting in which we have veterans who have high risk factors for, those three things in particular, and access to benefits and an intentionality in how the benefits are being implemented in collaboration with VA. It strikes me as there might be an opportunity to dig a little bit deeper and partner more with your office, which it sounds like it can be potentially siloed in other spaces in VA, to be able to research how the veterans living on in the various projects on campus have access to some of these services might help us understand deeper, I think, some of these causal factors and some of these protective factors.
Right. I mean, you have a novel project here, right, of bringing together all these different upstream prevention and protective factors, right? And so does it create an opportunity to look at how the veterans over time who live here and are benefiting from all of these things, how does all that come together? And when you were also speaking just about that, I did want to highlight too that our Veteran Benefits Administration, VBA, the provider of service connection benefits and other benefits, we've had a number of recent, over the last few years, collaborations with them to look at, particularly during COVID, when we look at the veterans who may have debt to VA, or when you look at the disability system, how do we ensure that we look at risk of veterans and think about how those benefits are provided and financial impacts. So just wanted to highlight that.
Okay, so to keep the train moving on time, two final questions from Beth Sandor and then from the vice chair.
Thank you. Beth Sandor. I was curious about the hospital-based dashboards that you kind of mentioned in passing. I'm assuming for this medical center, there's a dashboard looking at monthly rates of suicide among the population that lives and receives services on this campus. Is that the case? Is someone charged with looking at that data every month and making sure that all the programs and amazing resources that exist are resulting in that number being driven down and bringing partners in when it's not, and doing that kind of continuous improvement work?
So, first part of that is absolutely yes. So there are dashboards will be very data driven, and part of that suicide prevention coordinator role, among others, is to receive that data, be tracking that data. We don't track rates of suicide at a monthly basis. So keep in mind that annual report is 2 years in arrears. Now, the annual report is looking at all veteran suicide, not just veterans that are engaged in care. So we do have more timely data for veterans in care, because when events happen, we have internal reporting and all of that. So there is more focused data, but it's not exactly as you described it, where each month someone is looking to say, this happened last month, this is the services they were getting, and let's put those together. But that research team that I mentioned, data and surveillance team, absolutely. I mean, those are things that we're looking at. That's how we do have that GLA data to say, here's veterans who may benefit from this. Let's look at the service, like what we call like a penetration rate or population coverage rate. So in essence, each hospital is looking at, of the veterans that we have, where are we looking at risk level? That Reach Vet program, that statistically is a monthly program that's being pushed out to a clinician every month to say, here's your highest risk veterans this month. And we are checking to see, are those high risk veterans accessing services? Of course, veterans can decline, right? So it's not that we can make that happen, but we can ensure that it's offered and available. So that's kind of what that looks like.
Great. Question from our vice chair, who's also an Army psychiatrist.
I am aware.
Ready.
I am aware.
Jesse, thanks so much for this briefing and for your important work. Quick question. My understanding is that several years ago, the VA implemented the use of the Columbia Protocol, which is a very simple 3-question set that's evidence-based and can help community members, not just clinicians, but anyone, assess who is at most risk
Right.
and needs immediate help. Can you tell me what the status of that is now? Because that might be something, if it's not already embedded in the work that we're doing here, that could be useful.
Right, absolutely. So that risk ID program that I told you about, that where every veteran every year gets asked, the Columbia is the front end of that. So as was mentioned, it's very brief. And so we ask all veterans using the Columbia about suicide risk. About 1% are positive. Okay, so by and large, and that's kind of back to that needle and haystack, most of the time when we ask a veteran that, 99% of the time it's no. But when it's yes, right, which serve millions of veterans, so it's yes, there is a volume of that. Then we do what we call a comprehensive suicide risk evaluation, which there is no real industry standard on the evaluation. So there's no evidence-based evaluation that this is the best. But we use all the components that have been found to be vital and that meet Joint Commission regulation or what have you. So that's our risk ID program. A clinician can always pull it off the shelf too, right? So, we do it annually, but if someone meets a veteran, they're seem like they're struggling, they've had a recent loss, any clinician can pull the Columbia up in the electronic health record and start it. And then, as I mentioned, we also do it more frequently. You walk into the emergency room, so a veteran living here walks into the GLA emergency department, they will get they'll get a screening question to kind of start when they intake in the ED every time.
And I would just add to that, Jesse, yes, it's a very small percentage, 1%
Right.
maximum risk, immediate
And that's
action. And
universal. Yeah.
But it's really important to understand the criticality of not only that 1%, but also for your community members, your clinicians, to have confidence in knowing that if that individual, in answering those very simple questions, is not at the highest level of risk, it's a better use of resources. It's a more accurate tracking and partnering, getting the veteran into the right level of care, because sometimes, and it's understandable, you're dealing with suicide and it kind of automatically triggers anxiety in a lot of folks. And it can be, before the Columbia Protocol, the risk was that anyone who acknowledged some suicidal ideation might be immediately referred to care when that's not always needed. So it's a really useful tool, I think, in so many ways. I'm so glad to hear how VA.
Yeah, no, thank you. And I like the way you said that, right? Is that part of that SAVE training I talked about is asking the question, right? Like you said, it's an anxiety producing question, right? To ask someone that if you don't work in mental health. So just asking the question is something we really promote. And then, as you said as well, even if positive, we then have a risk stratification tier where someone may, we realize this is you're elevated risk, right? You're not going in the hospital today, but now maybe we'll do a safety plan. That was one of those interventions.
Dr. Berger, thanks very much. I wanted to commend one final point to you, which is California's governor last October signed the CARE Act, which allows for intervention, pretty powerful intervention. And LA County, the court system opened up December 1. So I would encourage you to keep an eye on how that works. And I assume that untreated schizophrenia and other psychotic disorders are a risk factor, one of the real durable risk factors. I encourage you to take a look at it. Okay, so we're going to continue going through, and our next presenter will be the public housing authorities. Thanks again.
Does anyone need a moment to stretch a little bit? You good? You want to stretch up? There you go. There you go. You've been sitting for quite a while. All right. Good morning, everyone. We had the challenge of really introducing and talking about a real complex issue in 45 minutes or less, and now we're challenged to do it in under 30. So we're going to do our best.
Take the necessary time.
Okay. Thank you for that. I appreciate it. My name is Emilio Salas. I'm the Executive Director of Los Angeles County Development Authority. And thank you so much to esteemed members of this board and committee for inviting us to talk about a very important issue As a veteran myself, this is something that is very near and dear to my heart. Our goal today is to really try to have an honest and candid conversation about where we are with our VASH utilization, recognizing that we're not where we'd like to be, but we are certainly making great strides along with our partners. And it was great to see John, Robert, and Steve here, our partners at the VA, to address veteran homelessness. One of the things that is really eye-opening to me is as I've gone across the country and talking to my peers, the issue of VASH utilization is not something that's, or underutilization is not unique to Los Angeles County. It is a national issue. But there are a variety of reasons of why that is. For us here within the county itself, one of the things that I really want folks to appreciate and recognize is just the sheer scale of the issue and the complexity of the system in which we're operating in. One of the things that is unique to Los Angeles is that we are operating in an area that has 19 different housing authorities that operate within this county. You will be hearing from 2. Now, with the 2, we do represent over 70% of all of the vouchers and the lion's share of the VASH vouchers, but that just gives you a flavor of the variety and really the complexity where a veteran who is homeless, when they get a voucher, they're not recognizing or not caring really where it's coming from. They just want to be housed. And we have to try to align all of those policies to make it as simple as possible to navigate this system. In terms of scale also, we just completed here in Los Angeles County, the homeless count, right? That just happened last week. And we look at the numbers from last year, we're north of 70,000, in terms of the overall homeless count, and north of 4,000 for those that self-identify as veterans. So certainly the scale of that problem is really, really enormous. And although what I want you to walk away with also though at the end of the presentation, and although this is a very daunting issue, we here in LA County are not daunted by the problem. We certainly are making great strides to address that. I'm going to introduce Tracy Mann, who is my Chief of Operations, who will go through the utilization on the county's behalf, and afterwards Carlos Van Adder from our sister agency at the City of Los Angeles will do the same. So with that, Tracy.
Thank you, Emilio. Good morning, everyone, and it's a pleasure to be here to speak about Los Angeles County Development Authority's VASH voucher allocation. Could you go up a couple of slides, please? So first, I want to make sure everyone knows what VASH is. Is there anyone here who does not know what the VASH program is? Okay, good. So we can jump right in. Next slide, please. Okay, one hand. All right, so in a nutshell, the VASH program is the Veterans Assistance for Supportive Housing. So this is a targeted allocation directly from HUD given to housing authorities that comes with vouchers and funding specifically for homeless veterans and their families to secure housing. So the housing authorities have opportunities to apply for these vouchers. Other times, HUD just awards these VASH allocations to the various housing authorities. So I'll go through these slides and you'll see how our allocations have increased over the years and where our utilization has landed in each of the progressive years. Okay, next slide. Okay, so this is a point in time from a couple of weeks ago to show where we are with our VASH allocation. In total, we have 3,442 VASH vouchers. And you'll see there's 2 different columns here. The first column is referenced as tenant-based. What that means is when a veteran receives a VASH voucher, that allows them the opportunity to go into the community, into the private rental market to locate the housing option of their choice. So this is a choice. They can rent a house, they can rent an apartment, they can rent a mobile home. It's ultimately where they would like to live. And again, this is within the Los Angeles County Development Authorities or LACDA's jurisdiction. However, we do have interagency agreements with some other housing authorities that expands the range of where these veterans can locate housing. So that's what tenant-based is. Whereas project-based is very specific, where the assistance is tied to specific units within specific buildings. And one example of that is Building 207 here on the VA campus, where we have some of our VASH vouchers that are project-based residing in that property, which did open last year. And I'll get into more on the project-based VASH allocation in the next slide. However, I just want to share with you where we are with our lease up. And you'll see in the chart, for the tenant base, we're at 52% utilized, which means that over half of our VASH tenant-based vouchers are currently unused. However, on project-based, we have a 92% utilization rate. But overall, we're using 56% of our overall VASH allocation. Next slide, please. So this particular slide is an overview of all of our project-based VASH buildings. As I referenced a few moments ago, the VA Building 207 is the top line where we are 98% leased. And the point we're making here, yes, big applause. The point here is that we have a much higher utilization with the project-based VASH program because the buildings are already set. The veterans have a choice to go into these units. Again, here, it's still a choice. Although they may be referred to the buildings, they can opt to say no for a variety of reasons. That may be the location of the building, amenities that may or may not be local to that site. And those are just a couple of examples. But overall, we have seen that we have much more success on the project-based side than the tenant-based, where currently we're at 92% utilized. I've heard questions asked before as to why can't we just project-base our entire VASH portfolio? Unfortunately, that's not an option. The federal government, by statute, limits housing authorities by the number of vouchers they can use for project-based. So the limit is 20% of our overall allocation, which is upwards for the LACDA, about 27,000. So 20% of that, with another 10% for special needs housing. So all told, we can only set aside 30% of our entire allocation for project-based, with a subset of that being specifically tied to VASH. Next slide, please. Okay, challenges towards utilization. Next slide. Okay, so we wanted to give you a little history lesson on the utilization of the VASH program for LACTA, dating back 11 years in 2012. During that time, our overall allocation was just 855. If you move over to 2023, and as I stated earlier, our overall allocation is 3,442. But what's particularly important is to see how we progressed in an upward fashion with the utilization rate, where in 2016, we reached 100%. We had an allocation of 1,754, and we got up to 1,752 leased, which was awesome. However, beyond that time, you can see that we've slowly gone down in our overall utilization. So part of that has to do with the growth of the program. So where, as I mentioned earlier, HUD does award VASH vouchers and allocations to housing authorities at different times of the year, during different years. So let's see, you can see the growth in 2014, we received 313. 350 in 2015, jumped to 2018, we received 600. That was the largest allocation awarded to a housing authority that year. We were very proud of that. And even as recent, during the pandemic, we received 500, and just last year, another 250. So we saw almost a 2,600 voucher increase for VASH. However, with utilization, you can see that, let me see, look at least calendar year, we were hovering around 1,700 between 2016 and 2022, but we did see an increase last year, which we were very grateful for. But the challenge with receiving more of the VASH vouchers is the capacity to be able to fill them. And that's another reason why our utilization has pretty much tread water for so many years. but I just wanted to point this out to you. And so I'll get into more of the details a little more about other reasons why our utilization rate has pretty much remained stagnant. Next slide, please. So Amelia, I want to cover this again. Okay.
I asked Tracy to insert this slide in here because one of the things I did want to point out is there was a time, even though the market is challenging, we did have a tremendous success with the emergency housing voucher program that really was a national program as a result of the American Rescue Plan. And we were able to fully lease up the entire allocation of vouchers that we received, which was a little south of 2,000 in an 18-month span. So it is possible to do that. But when we look at why that occurs and how that happens, one of the main strategies that we use within the housing industry is to overissue vouchers. When you're pulling from a pool of 70,000 individuals who are homeless, you are overissuing so that you can quickly lease up that allocation. So sometimes folks point to this and say, you were able to do this, why can't you do the same on BASH, right? With BASH, we are dealing with a much smaller subset. So we cannot do the same 3-to-1 issuance that we did with this particular allocation of vouchers. But that is a common strategy that folks use to make sure that vouchers are utilized immediately. Is you basically overbook the plane, right? You make sure you oversell the plane and you know that you are bound to get 100% utilization for that allocation. So this is just something we wanted to point to, that there are strategies that work even in a tight rental market. With this particular allocation, there are also wraparound services, very similar to what's available with BASH. But the stark difference is the pool by which you are pulling from is much, much larger on the emergency housing voucher side than it is on the BASH side.
Okay, next slide. Okay, so one of the challenges with regard to the utilization has to do with the number of referrals, as Amelia was alluding to. With DASH, we typically receive a 1-to-1 referral. However, we've seen, and history has shown with our other voucher programs and certificate programs, which is not relative to BASH, but when we receive one referral for one voucher, we know not that person won't always find a unit. So that's why we need more people in the pipeline to make sure that we reach our lease-up goals. So you can see here, this is a chart that reflects from 2018 to 2023, the number of referrals we've received on an annual basis, but the number of referrals we needed if we did a 1-to-1 match in order to reach full utilization of the BASH voucher program. So I'm not going to go into all the detail of the numbers here. You can see them, but the main point is that there is a shortfall of the number of referrals that we received. Uh-oh. Can we go to the next slide?
Who has the laptop?
It's up there. Is this one? Oh. Okay, thank you. Thank you. Okay, so another challenge with reaching utilization with BASH has to do with attrition. And this means the number of veterans who end up losing their assistance or just giving their assistance up. So the top 4 reasons for attrition between 2018 and 2023 was self-termination, number 1, meaning the veteran who had a voucher was in housing, just decided that they no longer wanted the assistance for whatever reason. Reason number 2, non-compliance with the annual reexamination. So every year, the housing authorities have to recertify the eligibility of the veterans, which requires the veteran to complete an annual reexamination packet. Oftentimes, we don't receive the packet back. We send it out, we notify the VA, hey, heads up, these veterans are due for their annual reexamination. However, we found that the reexamination packets have not come back for reasons such as the veteran left the unit, so they never received the mail. They decided they no longer wanted the assistance, so that was their way of self-terminating from the program. So this is another challenge that we're trying to get ahead of. But one strategy that we did employ was streamlining the annual reexamination packet. So anyone who has a fixed source of income does not have to complete that annual reexamination packet on an annual basis. So that would help keep the veterans housed for a much longer period of time, assuming that they are complying with the other requirements of the program. The third reason is deceased, which unfortunately there's nothing we can do about that, but that is the reality. And the challenge number 4 has to do with the expired voucher. So what happens is a veteran may want to leave their current unit and search for something different, maybe something better. The challenge here is oftentimes our clients will submit a notice to vacate, starting the process saying, okay, owner, we're going to stop making our payments as of this day. Veteran, here's a voucher. Now you need to go out and look for a unit. The veteran has not done their homework to see what the rental market looks like. Where are they going to go as their next unit? And so the voucher is in their hands upwards of a year, maybe longer, and they've not been able to secure a unit. So the expired voucher is a real challenge and is another reason why some of the veterans fall out of the program. And then you can also see the bottom chart here, the annual attrition compared to our annual lease up. So you'll see, starting in 2018, we had more veterans leave the program than we had new veterans coming onto the program. This happened 2018 and 2019, but we saw a shift in 2020 and continued on the positive road thereafter. So I'm not exactly sure what happened. We're just thankful that there was a shift in the number of veterans that were being removed from the program or self-terminating from the program, and we were able to get more veterans housed. Next slide, please. Okay, so our strategies and initiatives to increase our utilization. Next. So some points to highlight. Between 2018 and 2023, we found that it took veterans 4 months from the time they received their voucher in hand to secure a rental unit and for us to start making payments to the landlords, which is really great, given that the veterans are given a lot of time to find units. They've been able to find the units, secure them much quicker. We also worked with the VA to develop new programs, one being the assisted living program. So this is assistance extended to veterans to reside in VA-approved assisted living facilities. The challenge here is when a veteran receives a voucher, again, it's their choice. So while we have this as a strategy, the veteran must agree to live in this sort of situation, which at this time, we don't have any veterans residing in any assisted living facilities, but this is still an option available. Next, the other than honorable discharge. So a couple years ago, the HUD Secretary Fudge and Secretary McDonald got together and came up with a strategy to help increase the utilization of our VASH vouchers. So what housing authorities are able to do is set aside 15% of their VASH allocation for any veterans who are other than honorably discharged to qualify for VASH assistance. So we have an MOU in place with the county's Department of Health Services to receive referrals for any veterans who are other than honorably discharged. So we're hopeful to see more success in leasing up any veterans under the OTH program, but this is a work in progress. Next, we, the housing authorities of the county and the city of LA, were awarded these special waivers from HUD. They were unprecedented and the only ones nationwide, where we are able to accept a veteran's self-certification of their identification, their social security number, their income, determine them eligible, get them housed, and then within 60, 90 days, obtain the documentation from them. So this is a much more streamlined way to get veterans vouchered and housed. Also, the LACDA has what's called the Homeless Incentive Program. And what this is a host of incentives for landlords to get them to a yes. Yes, that they will rent their units to one of our voucher holders. So in a nutshell, some of the incentives that we offer is a bonus, a signing bonus. Once we contract with that owner to get the veteran housed, they'll receive a monetary incentive. We cover security deposits. If the veteran needs assistance with the application fee or utilities, if they have unpaid utility costs, or they just need help with the deposit, we have money for that. We also have funds for damage mitigation. So at the end of tenancy, if there are damages beyond normal wear and tear, above the amount of the security deposit that the owner received, we will pay up to $2,000 to that owner as a reimbursement to make them as whole as possible. That's just an example of some of the incentives that we offer. Next slide. Some of the, can you go back one more? Okay. Is that me? Did I touch it? Oh, okay. So let me see. Some of the other incentives or strategies. One is the where our voucher payment standards are. So we have, are you familiar with voucher payment standards, fair market rents? Okay. So at the LACDA, we have historically had higher payment standards for the VASH program versus the payment standards for the regular housing choice voucher or Section 8 program. So that has been one way to get landlords on board with renting to a VASH client. Another strategy we employed is a team of what's called housing advisors. These are a team of staff who have been tasked with going out to property owners, realtors, to see who has vacant units available and if they're willing to rent their units to one of our clients. And what we do is we get this list of these vacancies, compile them together and send them out on a daily basis to our community-based organizations. We send them to the VA. If clients ask for them, we'll send them over to them as well. But the team of housing advisors will also take our list of current voucher holders and call them, say, hey, we have this list of units that are available for rent. Let's see if any of these meet your needs or if you're interested in renting them. So that's another strategy that this housing advisor team does. And they also provide transportation services. So if there's a voucher holder who just doesn't have the means to go out and search for housing on their own, we will pick that voucher holder up and take them out to go see the unit, meet the owner, and see if they are interested in that unit. And we have, at times, taken one person out day after day after day until we find whatever unit they desire, get them matched up, and then get them housed. We also have interagency agreements, and this is something I mentioned earlier, with other housing authorities within the county. So although we are the county housing authority, we only do business within the unincorporated areas of Los Angeles County and upwards of 70 cities. And these are cities that do not have their own housing authorities. Now, for the cities that do have their housing authorities, that's where these interagency agreements come into play, because we now have the ability to refer our veterans to find housing in those other jurisdictions. So they're not limited to just the Los Angeles County Development Authority's jurisdiction. And one of the jurisdictions where the veterans can find housing includes Kern County. So if there are needs, housing needs or wants in that area, the veterans can find housing up there as well. And then in collaboration with our VA partners, when there are stand-down events happening here, we deploy our team of VASH coordinators to come on site to do on-the-spot eligibility determinations. And if the veteran is determined eligible, we issue them a voucher right then and there, and allowing them to go out and start immediately looking for housing. So I think that is about it for my presentation before I turn it over to Carlos Van Adder with the City Housing Authority.
Good morning, everybody. Thank you very much for the opportunity to be here to present our information on our partnership with the VA on the HUD-VASH program. As was mentioned, a lot of background information has already been given by the LACDA, so I'll be able to speed through some of it. But You know, we've been involved with the HUD-VASH program since the start, since 2008. HACLA, as an agency, we serve over 61,000 families. We're about the second or third largest PHA in the country. We go back and forth with Chicago. We received the largest allocation of HUD-VASH in the beginning, 840 vouchers. We've gone up over time. So if we can go to the first slide, we have a lot of numbers to present to you to show you where we are now, some of the key metrics of the program. And as we mentioned, or has been mentioned, there's a tenant-based component, there's a project-based component. On the tenant-based side, this is our picture of our utilization and allocation as of now, as of the moment. This is 2003, and in the big chart on the right, you see by month, we have the allocation that we've had from HUD. Started out at 3658. We've got a new allocation of used for tenant base up to 3763. So that's what we've had to use across the whole year. What we used across the whole year is in the third column, utilization. And in December, you will see we used 2,127. That's 57% of our allocation, which means we have 1636 to lease up in the HUD-VASH program. We have a ways to go. The two last columns are very important also. So we do our work through the referrals that the VA provides to us and all of the housing authorities. In the HUD-VASH program, the VA is responsible for identifying the veterans, preparing the referral packets to the housing authorities. Then we take it from there. We determine eligibility of the family, the veteran. We issue them a voucher on the tenant-based side, which is this one. Then tenants have, excuse me, up to 180 days to locate a unit. When they do, we do the contracting and we execute payment to the landlord on behalf of the tenant. So we need referrals to do our work with the housing authority. And you can see in the column, we have the number of referrals that we have received by month from the VA. And in the final column, we have attrition, the number of people who leave the program every month. And what's most important about this is you'll see the total number of referrals we received last year was 229, but we had 262 people leave the program. So we're not even staying in place. We're not getting as many referrals as we need to lease up vacancies in the program. And that number of referrals, 229, those are the referrals we get. Not everyone is successful in locating a unit, as has been mentioned, and we'll go over a little bit more in a minute. So that averages out to 19 referrals a month that we have received, or 4 referrals a week. Now, since the beginning of time in the HUD-VASH program, since 2008, we have been requesting 25 referrals a week to fully utilize the allocation. So you can see we are far short of what we need to fully utilize the allocation. The little box over here on the left, that's just the activity of what we have going on right now in the moment in January 2024. We have 19 applications in process from the VA. 77 veterans are in process of looking for and locating a unit. And 15 have actually located a unit, and we're working at contracting them in those units. You can go to the next slide, please. So this is our project-based utilization. And as was mentioned, there are several project-based voucher buildings that we have around the city. We have 3 on the campus here, building 205, 208, 209. Those have a relatively high allocation, or I'm sorry, utilization rate over 90%. So we thank you for that. They're beautiful new buildings. We had the opening of 2 of them earlier this year, or last year now. And in the project-based voucher side of the house, our utilization is better. You'll see towards the bottom in December of last year, again, this is all of 2023. We have an allocation of 1127 HUD-VASH vouchers for PBV, and we used 867 of them, or 77%. So it's about a 20% increase over the tenant base. Still not where we need to be. We'd like to be 90 to 100% utilization, as these are buildings that are ready to go, that people can move into. On the tenant-based side, we saw that a veteran and family gets up to 6 months to locate a unit. You have to go out in the community and find a unit with a private landlord. Here, the units are available and ready. So that we don't have full utilization on the project-based side is a sad situation that we all need to address. Again, we have the number of referrals on the project-based side. We've received 287 across the whole year, but we had 148 folks leave units on the project-based side in the year. And those are the averages per month. Okay, go to the next slide. So this is a slide on the historical referrals that we've received every year at HACLA, at the Housing Authority City of Los Angeles. In the very first year, in 2008, we received 96 referrals. Last year, we received 175. What we need per year is 1,300 or 25 a week. That's what we've been asking for. We only had 1 year, that's in 2015, highlighted in red, where we achieved that goal of 1,322 referrals. And that year and the one right before, and maybe I think the year right after, that's when the VA contracted with at least 12 different service providers in the community and made referrals to the housing authorities. That's where we saw our greatest success, when there were partners with the with the VA gathering referrals to send to the housing authorities. So that's a really key and telling bit of information. Best success when the VA's gotten support from other partners in the community. Okay, next slide, please. So then we have the annual attrition rate. The attrition rate is when people leave the program for whatever reason. There's a variety of reasons. And this goes back to 2012. So our attrition rate in the program was 10.33% in 2012. In 2023, it's up a little bit to 12.72%. So of our total allocation and actually like utilization of the HUD-VASH program, that percentage of people leave the program every year. And at the bottom line is, how does that compare to our regular housing choice voucher program of just other low-income seniors, disabled, and families? In that regular program where we have 50,000 folks, the attrition rate is 4.5%. So you can see in the HUD-VASH program, it's more than double the attrition rate of our regular program. So that's a problem or an issue for all of us too. We have an issue getting people in brand new. We have an issue keeping people housed over time. So next slide, please. So this is an actual breakdown of the reasons why people leave the program with us, the attrition rate. You saw it on the LACDA side as well. This has all of our different reasons that people leave the program. And this is on the tenant-based side. Again, the top 3 reasons, and they mirror what LACDA mentioned. Number 1 reason people leave the program is skip. They just walk away, disappear from the unit. The problem that VA case managers have, we have in our tenant-based program and the HUD-VASH program. Second reason is tenant non-compliance with the annual review. We do have a requirement that all tenants need to comply with updating their income annually. In this case, we have 23% of, or 59 folks in 2023 that didn't do that. And then the third top reason is, unfortunately, deceased. So this is on our tenant-based side. We have an average, monthly average of 22 folks leaving the program last year. Next slide is the attrition rate on the project-based side. Again, the same top 3 reasons. In order, tenant non-compliance with annual review, deceased, and skip. Same 3 top 3 reasons. All right, next slide, please. So these are the strategies and the initiatives that we've taken to increase utilization, a number of the same ones that we've heard from the LACDA. So I've been talking all along that we've been asking all along that the VA provide us with 25 referrals per week. Actually now, looking at the numbers and the total unused allocation that we have, we need 41 referrals per week. So if we were receiving an average of 4 a week, and we weren't making 25, it's going to be a stretch to get to 41. But that's what we need to fully utilize all the allocations in HUD Bash. Now you see at the top line there, it says HUD Bash success rate 61%. What does that mean? The success rate is how many people are successful in using a voucher on the tenant-based side when they get one. So if we pass out 10 vouchers, 6 people are successful in finding the unit. That, it's 60% in our overall program, 61% in HUD Bash, so a tiny bit better. But that's still a crime. 40% of the people who get a voucher in our community can't find a unit with a landlord. So this goes back to what we've been talking about. This is a difficult market in LA for people to find units. Rents are high, vacancies are low. But one of the main reasons or ways that we combat that on the HACLA side is we have high voucher payment standards. And what I want to turn your attention to, if we can go to the next slide for a moment. So we have our regular voucher payment standard, which is the highest that it's ever been. And if you look at the bottom of the slide under tier number 3, you'll see voucher payment standard, all zip codes. That's at 120% of the FMR. That's what our voucher payment standard is across the city. And if you look on the 1-bedroom column, it's 2407. I wanted to show you our exact numbers so you can get an idea. 2407 is a very decent rental amount in the city of Los Angeles right now. It doesn't cover all zip codes, but it's the highest one we've ever had. And on top of that, at HACLA, we are utilizing what are called small area FMRs. And in that program, which we started at the start of last year, 2023, we have 3 different tiers of 70 different zip codes in the city and some county areas. These are the higher opportunity areas in the city and county of Los Angeles. And in those areas, we offer higher rental amounts. If you go to the tier 3 level, and the tier 3 level includes all of the zip codes around the West LA VA Medical Center. We have the highest small area FMR there. You'll see for a 1-bedroom, it's 3216. For some of our staff, it's kind of obscene. They can't afford apartments themselves at 3216, but we are offering that amount for HUD Bash veterans and anyone on our program who is lucky enough, fortunate enough to find a unit in these zip codes. So you'll see on tier number 1, we can go up to 2460 for a 1-bedroom, and on tier number 2, we can go up to 2760. So these higher rental amounts have been excuse me, very helpful for us in helping any of our voucher holders, but particularly veterans, to locate units in better neighborhoods. Okay, if we can go back to the last slide again. Yeah. Okay, so along the lines of what was mentioned on the LACDA side, we do have landlord incentives also. We have a holding fee where we will pay a landlord up to the fair market rent to hold a unit for a veteran until they can get into the unit. We have security deposit assistance, that's 2 times the contract rent. We have a damage mitigation fund if the tenant vacates the unit having caused more damages than the security deposit. We have utility arrear payments, and we also pay for furniture on a tenant-based side if the tenant doesn't have furniture, which they normally don't, as they are home. In HUD Bash, we also have a unit dedicated to contracting folks onto the program quickly, expediting that process. We also have specific staff that just work with the tenants long-term over time with the participants doing the ongoing contract maintenance functions like the annual reviews that we talked about. We also participate in the VA stand-down events and any of events that we can partner with the VA to help contract and house veterans as quickly as possible. And we also conduct, independent of this, outreach events to landlords to get more landlords to participate with us on the program. We do that in cooperation and collaboration with the LACDA. We try to do that at least quarterly in different parts of the city and county to encourage and recruit landlords to want to rent to our families. As Tracy also mentioned, both HACLA and LACDA applied to HUD for self-certification waivers. They were approved. They are still to date the only ones in the country that we have gotten those waivers, and that allows people on our homeless programs, including HUD Bash, to self-certify as to income, social security number, date of birth, also disability. So this really helps speed up the process. And then once a veteran is housed, within 90 days of that, we have to get the documentation. We have interagency agreements, as was mentioned, which doubles the size of the area where the veterans can look for a unit. So along with the County Housing Authority, the other big jurisdictions are Long Beach, Pasadena, Santa Monica. Veterans can locate units in those areas with us too. We're also participating in the Other Than Honorable Discharge Program, as Tracy mentioned. And we also have regular ongoing communication with the VA case managers whenever we're going to take an adverse action against any of the veterans. So when we have a veteran who's not complying with their annual review, that process, the case manager gets a copy of the letter that says you're at risk of being terminated from the program, so that we can all work to save the contract and not have the vacancy, the termination take place. Okay, so those are some of the things we're doing, and I just want to mention too that we've been working with the VA here at the West LA campus since the beginning of the program, since 2008. We have a very good relationship with them. We want to thank them for all the work they've been doing on behalf of the veterans and with us. So with that, I guess I'll open it up to questions.
Thank you very much. I really appreciate the information. And I also know all the board appreciates the candor of acknowledging that we can do better, and we, I think, in fact, have to do better. We're going to hear from John Kuhn now, but I have two quick questions for the two housing authorities. And they're going to be very brief, and then we're going to turn it over to John. The first question for each of you is, what is your utilization percentage on regular Section 8 housing projects? So set aside HUD Bash. I want to hear that benchmark. And the second is, you've told us that project-based vouchers can only be 20% of the overall portfolio. I took that to be your answer, not 20% of the HUD Bash portfolio. And if that's the case, I'd like to know how material the HUD Bash project-based vouchers are to that 20%. I'd like to know what the breakdown is.
Okay, so to your first question, what our utilization rate at LACTA is for our regular Section 8 program, we're currently hovering around 88 to 89% utilization, and that's largely due to the costs to subsidize units for our current families. So HUD funds us about 100% based on the number of units that we have leased at those rents. We're currently pacing about 106% of our budget authority in paying out housing subsidies. So the higher the amount that we pay an owner or owners out there for our voucher holders, the fewer families we're able to assist. So that's your first question. So relative to the project-based BASH allocation and how many of those, or how relatively speaking, how many of those vouchers could be used toward project basing, it's a little tough to really definitively say. I can let you know that this year we are slated to have 250 new project-based BASH voucher units come online for LACTA, with others coming online next year. However, it's important to note that we, at the LACDA, will reach our PBV cap by the end of next year. So we're allocating as many BASH vouchers as we can to the PBV projects, but we are limited in scope. I'll turn it over to Carlos.
And along the same lines that Tracy mentioned regarding utilization in the overall Housing Choice Voucher Program, there are the two metrics. There's unit versus budget. And unit, we're in the same place. We're about 89 to 90% utilized on the units. But since the contracts are so much more expensive, we're at about 93, 94% utilization of the dollars. And our goal this year is to get to 100%, but we utilize all of the dollars we receive for the program. On the project-based side, we are pretty much at our cap at HACLA. We have close to 4,000 units on our project-based voucher program, all programs, including HUD-VASH. Last year, one thing I didn't mention, and this kind of goes to just being able to lease up folks. Yes, this is a difficult rental market, as we've said, but we can and do lease up new contracts. Last year at HACLA, we housed over 6,200 new families on the program through the tenant-based and the project-based programs. 2,500 on the project-based side, the balance on tenant-based. So even though it's difficult in the market, even though only 60% of our folks can locate a unit, we housed 3,500 or more in the tenant-based side. And so as far as project basing on tenant-based, on HUD-VASH, we have allocated all of the units we could for HUD-VASH for that program and also for the regular program. We're expecting to do 3,000 more units, brand new buildings in the HUD-VASH program, not HUD-VASH, but in the PBV program this year.
Okay, I'm going to ask John Kuhn to now present.
Now, hello, there we go. All right, so I think as pretty clearly demonstrated, we have a problem, right? And this is not the right slide. I think we could go back or different, back, forward. All right, there we go. We have a problem. The problem is voucher utilization. So beyond knowing that we're not using all of our vouchers, it would be helpful to understand what it means, diagnose the problem. The same way, like, right, if you're sick, it's not enough just to know you're sick. We want to know how to get better. So the system that the voucher utilization we're seeing is a sign of a systemic disorder. And we can see some of those signs. So first, this is actually not the right slide. I don't know, is it forward or back one? There we go. No, you had it. There we go. LA Times recently reported that 48% of all the regular Section 8 vouchers are returned unused. 48%. And these are regular Section 8 vouchers. These are for people who are in poverty who need Section 8. We're working with a much more complicated population than HUD-VASH. There's a HUD released the study that if you look at just looking at quality data from PHAs that had it, in a 180-day window, only 61% were able to successfully use vouchers. The rest were returned. So this is a systemic issue. This is not just a HUD-VASH issue. This is not just a Los Angeles issue. This is a systemic issue. And you've heard hints of that in the difference between PBV utilization, which is much higher, and TBV, that's a tenant-based utilization, which is much lower. Why do we see that difference? Next slide. So here, no, I'm sorry, I raised the head. Sorry, back. So why does it happen? Well, first, discrimination. If I'm a landlord and I know I'm getting a voucher for a HUD-VASH client, I know that's probably going to be a person of color, maybe mentally ill, may have a criminal history. I don't want them. Now, discrimination is illegal. It's against Fair Housing Act, but it doesn't matter. Landlords find a way to exclude people with Section 8. So that's one of the reasons why a tenant-based voucher is much less likely to be used than a project-based voucher, which it has to be used for. The second reason is the housing market. Los Angeles is one of the most expensive housing markets in the country. California is the most expensive housing market in the country as a state. So we have landlords who can turn around, lease up and the market's very high, very quickly, without any hassle. And if they go through HUD-VASH, and we have to go through the Section 8 process, they have to wait. First, they have to qualify for the Section 8. They have to have the apartment inspected. They have to wait for all this time, their apartment's empty. They're not collecting any revenue. There's no money coming. So there's an economic incentive for a landlord not to take a tenant-based voucher. And then for our applicants, it's not easy, right? Not only do you have to pony up the money for application fees and fill out all these forms, and you just heard there are 19 different housing authorities. You know how many different housing applications there are for those 19 different housing authorities? 19. There's not the PHAs do not have one application. It's 19 applications. So every time one of our prospective tenants, one of our veterans, has to go to a different housing authority, it's a whole new application. And for a veteran who's mentally ill, has learned helplessness, feels frustrated, these barriers can seem overwhelming. So these are real issues. Next slide, please. And this is stuff that's well known, just the affordable housing crisis. This is not just, well, it's particularly bad in Los Angeles, but this is a nationwide problem. There is not enough affordable housing, particularly for folks with lower incomes. Next slide. All right, so that's a problem. That's a diagnosis. We have a systemic problem. This is not just send us more vouchers, Los Angeles, a dash. Yes, we don't want folks homeless. Our PHA partners don't want folks homeless. So what do we do to fix it? Now that we understand this is a systemic issue. First, we've done some work with the PHAs to try to lower barriers. A lot of these documentation barriers, the 19 applications, let's get rid of some of these barriers. So we've been meeting about this, and PHAs were good advocates along with HUD, and we were able to get these waivers. They haven't honestly moved the needle yet. We're hoping that they will, but that's one step. And we're going to, throw everything against the wall that we can to try to move the needle. So that was one thing. Next slide. This has moved the needle, and this is one team. And you've heard a little bit about it. And you saw, even though the utilization rate hasn't changed, part of that's because we get more vouchers. But the reality is we are placing more people in permanent housing. Our permanent housing placement rate last year is up 38% from the previous year. And most of those veterans, and then Sally can share the stats with you at some point, I hope, I know we have a hard stop soon, had stuck. We are able to get people back into housing. We are doing what's called intentional bridging. So for what we want to do with these tenant-based vouchers is use SSVF to get people in immediately. So that way we don't have to go through that process, be conscious of our landlord customer. They don't want that apartment open. Let's get them in right away with SSVF. Once they're housed, then we'll worry about HUD-VASH because they keep their housing eligible. And last slide. The latest thing we're working on, master leasing, is what I think is going to be the most important intervention. So the reason why landlords don't want to do it is I've described, but with a master lease, all of a sudden you have a third party. Let's just say it's Jim Zenner from the county going in and scooping up all the apartments in either one building or multiple buildings, and the landlord now has no marketing costs. They have guaranteed rent the minute that apartment opens up that they're renting. So no marketing costs, no vacancy rate. We then come in because the county has all these apartments for us on demand, background checks, we don't have to worry about the applications particularly. We can get them in, worry about it later. They will be tied to the HUD-VASH rent. And then all of a sudden, this thing that looked bad for the landlords looks really good. And we can use the tenant-based vouchers in a way that's even better than project-based because we don't have a third party doing interviews, screening. Veterans have more flexibility because wherever we can get the master lease works. So these are the opportunities we are pursuing to try to get that utilization up. And with that, because we're very tight on time, pass the rest out.
Sally Hammett for the record, and very briefly, I just want to thank our partners at LACDA and HACLA. They have been at the table each week during the meetings that I expressed to all of you, the one team meetings, and our partners that are coming with solutions. As a result of our work together, we've been able to explore action plans in our own teams. And actually, we have our HUD-VASH program manager and deputy program manager, Vanjie Liggins and Estelle Anna here to give some information if we have some time about that. But I wanted to share with you the progress that John talked about, that 38% increase for our calendar year 2023 goals to house veterans. We set a goal at 1,500 veterans to house. We housed 1,790 veterans in calendar year 23. So that was 119.3% of our goal, which is so exciting. And 489 more housing placements since calendar year 22. Our second goal, and this was raised in the importance of people falling out of housing. It's not lost on us that we really need to dig into efforts to ensure that our veterans are successful in sustaining their housing. So out of those 1,790 veterans that were housed, we had 81 veterans fall out of housing. That was 4.5% returns. So we met that goal of less than 5%, but we don't want anyone to return to homelessness. 79 out of the 81, so it's 97.5 veterans were put on a pathway to rehousing or rehoused. So there's two fallouts there. We know who those veterans are. One's on a lease with his ex-wife and child. There's some relationship issues there, and we're working hard to get that person in housing. Another one, we just noticed last week, missed medical appointments. So our outreach workers know who these two veterans are and are working hard with our partners to re-engage them into our system of housing. The last goal is the engagement of unsheltered veterans. So we set a goal to engage 1,888 veterans who are unsheltered. We met that goal and exceeded it at 2,184 veterans that we engaged that were unsheltered. So that's 115.7% of our goal. And we were successful because we partnered with VA police, city police, VPAN, all of those efforts outside of VA in conjunction with our operations to be able to be successful. So again, thank you to the housing authorities for coming to the table with us in one team and meeting with us every week. In fact, you heard about the racial equity group, and our partner Christina back here from LACDA has agreed to co-chair that group and be involved in ensuring that we're not placing barriers in veterans' way of getting housing.
All right, so let's hear from Jim Zenner, then from Nicole, and then Keith, and then Stephanie.
This is Jim Zenner. I'm gonna rapid fire these. So first, big thanks to Anna Rodriguez and Christina. You guys have been really on it with the one team. If you go back to the slide 2017 with the HACLA referrals, you'll see that the referrals started dropping off from 2015. Carlos mentioned that that's when we had like a bunch of HUD-VASH providers. But what was significant during 2017 was, and we heard this while the undersecretary was out here, is that that's when contract providers had to run all their clinicians through the credentialing process in the VA. And that's when it started really becoming difficult on our contract providers to hire clinicians up. And that's something that we've heard historically, is that staffing issues are some of the reasons why we have not been able to utilize vouchers as much as we need to. So I want to point that out. I also want to ask the housing authorities if there's been any guidance from HCD about the implementation of 1386 at this point, which is the Gabriel bill around the AMI, 30% AMI allowing the flexibility to 50, 60. Is there any guidance from HCD? Okay. And then is it tracked the number of veterans that are being disqualified by the housing authorities due to over income with service connection?
Yeah.
So just to repeat the 1386, neither housing authorities have heard any guidance from HCD on the 1386 implementation, and then the number of disqualified vets.
You know, we don't have, I don't know if this is working right, but we don't have that many veterans that are disqualified for being over income because, oh, there it goes. Because at the housing authorities, in both of our admin plans, we adjusted them to say that if a veteran is getting a VA pension and it puts them over 50% AMI, we can go up to the low income limit, which is 70%. A higher rate. So From the housing authority's perspective, we allow the tenants to be on the program. What becomes problematic is when these tenants want to go into project-based buildings, because on the PPV side, the developers still have those limitations through their tax credit and other regulations that they have. So we haven't, to my knowledge, terminated anyone for being excess income. Now, they may not get on the program from the start because they're excess income, but there have been very few of those because we go up to the low income limit on income.
And that's the same for the LACDA. We have not seen, I mean, we have not denied anyone for being over income.
All right, Nicole, you're up.
Hi. First, I want to commend you on all the work you're doing to increase utilization rate. I'm from New York City, and we did a lot of the same things, so stick with it. They will help. I have a couple of questions. One was around the contractor providers. It seems like that was a number of years ago, so I am curious if there's been any movement to make that easier to have contractor providers, if that did make such a big difference. And I'd be curious from the housing authorities, but also others in the room, about what else is being done to increase referrals, because it seems like that is the biggest issue. So I have a couple questions. Question number 2 is around housing advisors. In New York, we had a peer model where we had, outside of the VA and HUD, we had teams of from nonprofits and city government working really hand in hand with the badge holders to find them housing, really getting into where they wanted to live. And I'm wondering if with the attrition rate you're seeing, both with not recertifying and then just leaving, if it has something to do with them not being in the apartment they wanted to live in the first place. Or so that's something I'd love to hear more about, is the housing advisors program. And then I have a recommendation. Sorry, I've been hogging the airtime here. I have a lot to say. We also had the one thing I didn't hear that we did in New York that you're not doing, because again, like that was almost our whole game plan around housing, the housing authorities, was around aftercare. So the BASH case managers are, in my experience, are usually really good on the clinical side, but it helped to have, both with recruiting landlords and with tenants going through the recertification process and not falling out of the apartment, was to have somebody who just called to check in on, do they know how to do their research? Did they get their paperwork? And then telling the landlords that they had somebody to call if there was a problem. And they almost never called. There was almost never a problem, but just knowing that they had that hotline to call was helpful. So that's a lot.
Okay, what was your first question again?
The first question was about referrals. What's being done around the bringing back if anything, with the contracted providers to help out with referrals? And then to you and anybody else in the room, what else can be done around increasing referrals? Because that does seem like the biggest issue.
We would love to see the VA contract with the agencies again. That's pretty much on them to do that. And I know, and I've heard that they've been working towards that, because we are limited in the referrals that we can get for the HUD-VASH program. They must come from the VA or through our other than honorable program with the contracted agency, the Department of Health Services that we work with in that program.
And if I can just add, during my presentation, I spotlighted in 2016 where we had reached 100% utilization. That was also as a direct result of the contracted agencies being in place and working with the VA, not only with the referrals, but also providing the case management to engage that veteran on a regular basis to check in and see how they were doing and to make sure that they retain their housing.
Okay, Keith Harris.
Okay, I know we're pressed, so I have just a couple comments. Actually, none of these are questions. The first is, I wanted to talk about the 30% cap on PBVs. That is a real problem for the campus development. And a lot of the PBVs down the line have not, in fact, been awarded to projects yet. there've been discussions between the developers and LACDA. I was recently pulled into those, which I'm thankful for. The one thing I wanted to mention, Tracy knows this, but I wanted to share with others. There is a bit of a workaround possible if HUD does a dedicated allocation of project-based vouchers. Those the cap does not apply to those. The cap applies to essentially tenant-based vouchers that are converted to PBVs. And so that's one of the things I've actually started advocating with that headquarters on is might they be interested in doing a targeted allocation of PBVs, even if it's just restricted to the campus, for instance. The national office, homeless program office, is beginning to advocate for a national allocation. That's a bigger lift for obvious reasons. So I wanted to raise that. We need to figure that cap problem out in order to secure PBVs for the remainder of the master plan. Wanted to talk for a second about what I've always called the denominator problem here. I oversaw HUD-VASH nationally from 2012 till I started this role 2 years ago. Was involved in a lot of discussions about how to do voucher allocations. Early years in HUD-VASH heavily factored performance into the formula. You had to demonstrate you were using your vouchers in order to get more vouchers. Starting in around 2015, every year we would hear this might be the last year Congress allocates vouchers. So at that point, we thought it was way more important to make sure vouchers went to the places where need was greatest, even if they had not demonstrated the ability at that point to use them. So in Tracy's charts especially, you saw LA being flooded with new vouchers at a point where utilization rate was not that great even then. That was a targeted strategic decision, knowing we were going to blow up the denominator in some places. LA's not the only one, but it's one of them. Still need to figure out how to utilize the vouchers, but I did want to say there's some context there. We knew there was going to be struggle with utilization rates. The other thing, this notion of treading water is not only true here, it's true nationally. In FY22, there were over 15,000 lease-ups. There were over 16,000 move-outs. The nation as a whole ended up with a lower utilization rate than we started with. I think it's incredibly important to identify the portion of those that are unwanted and preventable and do everything we can to help those veterans stay in. It's more of the back end work. There's a lot of focus on referrals in these slides. Just as important to keep the veterans in housing once they're there. The last thing I wanted to say, you both mentioned the OTH program. That program predates legislative change. Congress changed eligibility for HUD-VASH. Those veterans that program was designed for are now eligible to receive not only the voucher, but case management directly from VA. I understand there've been challenges getting that program fully running. I recommend you revisit the need and the focus for that and make sure it's really the thing that is still needed.
Stephanie Cohen.
Thank you, Stephanie Cohen. Hi, nice to see the three of you. I will echo the great partnership work that Jim talked about with the three of these folks standing here. I don't think that any of us would be here having this conversation without them and the partnership that we got from Keith in those conversations starting a few years ago. So thank you, first of all, for that. We didn't talk a lot about PBVs and how we're projecting for the allocation on this campus. And I'm just wondering, I mean, my first question is, how are we projecting for the allocation on this campus? And if you could just explain to the group, a lot of folks are, I think, new to understanding the campus dynamic and the way that we work with the different housing authorities here. If you could explain at what point the voucher allocation does take place and how we know whether or not we're going to have the vouchers allocated along with the project funding and how it works through that process. And then obviously what you said about the cap is really important. But since there is a potential cap and an issue, how are we planning for that to get all of the units that we need as described in the master plan?
Very, very tough question, but important one. I'm glad you asked it. I really appreciate the comments you were making on the PBVs. It is something that I think the PBVs are a unique opportunity for us to really resolve the issue here locally, as you saw from the utilization. As it relates to the campus, we've been operating under a waiver from HUD so that they do not have to reapply through a competitive process to obtain those PBVs. So there is a requirement that you compete for those vouchers, right? But we have a waiver to use the original competition that awarded the developments to the developers and have been getting a waiver every year thereafter. However, at the same time, we are also putting out notice of funding availability countywide for developers in general to produce affordable housing, and it's up to the developers to determine the population. Now, we are incentivizing the unhoused, and we also say we have VASH vouchers available, but it's up to the developers to select those populations. So they are also drawing from that same cap of PDVs. And every year we are issuing new NOFAs and that we're getting inching closer to the cap. Meanwhile, we know there are still developments here down the line that are going to need those PDVs. And we are projecting that we will have reached that cap before those developments come online. So we are actively advocating for what was stated earlier to have a separate set-aside allocation, but also there is legislation to increase that cap to 50%. So we are actively advocating for that cap to be lifted with the understanding that it's discretionary, right? You don't have to go up to that 50%, but in jurisdictions such as ours, where we know that it is effective, that we can go up to that. We're getting a lot of pushback, believe it or not, from housing advocacy groups that believe that it takes away from the original intent of the voucher program. But here, what we're saying is if you can't use that voucher on the private market, what good is it? Let's have it so that there's units that are set aside so that there's, specifically for this population. So we're really fighting hard to get that cap increased and are hopeful, if not, that we could then lean on folks' desire to help veterans to then get a special set aside specifically for this campus, because that is something that I really think about as these developments are going to come online until 3, 4, 5 years down the line. And unless that changes, we will have to come up with a different strategy.
That's Sandor, please.
Hi, Beth Sandor. I just want to echo what John said about this isn't about LA. This is a national issue we're seeing in large cities we work with everywhere, underutilization of HUD-VASH. And I think the good news is, and a couple folks mentioned it, there are these golden years where we had really high rates of HUD-VASH utilization nationally, and we know it works. And I think it's just getting back to some of those things that have been mentioned here. I know we're seeing communities really struggle with the contracting piece as something we used to really do much better than I think we're doing now. So I just wanted to say, I think there are some peers kind of nationally that are doing really good work, including New York, where you see a 94% utilization rate of TBV in a very similar market. And so what can we learn from other large cities where we're seeing different outcomes? And I think you guys, the best practices you have up there are some of is what most people are doing, but what is different and how do we kind of dig into that in this context? I have 3 questions. One is how much do we think contracting is a barrier here to utilization? If tomorrow someone waved a magic wand and you got to 50% on that cap, how much do you think, what's your confidence rating that would expedite the utilization rate? Like what's the jump in utilization rate that you think you'd get off of that? And has there been talk of partnering with organizations like Brilliant Corners who are doing pooled housing resources as a mechanism to accelerate the utilization rate?
Well, I can probably speak to your second question about how quickly could we use new VASH PPV if we got it. Overall PPV, there are a lot of developers in the city, and I'm sure county also, that would love to get allocations of PPVs from the Housing Authority, but we're at our cap. We just issued probably one of our last NOFAs for regular PPVs, and we offered 290 vouchers, and all of them were snatched up in 5 projects. So there's no shortage of demand or projects out there that developers could build if we could have the cap raised, or even better, as Keith mentioned and Emilio also, a specific set aside for HUD-VASH PPV, which we've had in the past. Oh, contracting question, how difficult is it? The VA would probably have to speak on that.
Elizabeth Sanders, just to clarify, my question is how much is contracting a barrier to utilization? That's me. We're happy to answer that.
Hi, Estelle Anna, I'm the Deputy Program Manager for VASH. So to date, we actually do have 5 contract agencies partnered with us. That got awarded last year. We've issued 2,290 of our HUD VASH vouchers across those 5 contracts. But to Jim's point, all of those contractors do need to go through the credentialing process. So they also struggle with getting their staff onboarded in a timely manner. The way our contract is written, it does allow them to hire staff that looks a little different from our team. On our team, you know, we have nearly 300 FTE, 188 of those are master's level social workers. Those are the only clinical case managers we hire. On the contracting side, they have more flexibility in the type of staff they can have. They can have bachelor's levels with 5 years of experience. They can have various master's degrees in human and behavioral services. So it does allow more flexibility. But to that point, all of those staff that they do push forward have to go through the onboarding process. That can take several months, as do our staff. It takes us anywhere from 3 to 7 months to get our VA staff on board. But they are currently onboarding, so we are hopeful that they'll have more staff and we will see, you know, more referrals come out of our contracts. But, you know, we do have over 2,000 vouchers dedicated to our contracting team. So hopefully that answers the question. Estelle. Deputy Program Manager from HUD VASH.
And I'm Vanjie Liggins, serves Deputy Chief for HUD VASH. And that allocation that Estelle just spoke of is a higher amount than, even though we used to have more contracted agencies in the past, which Carlos referred to, we didn't have as many vouchers allocated out there as we do now. So we actually have maybe less contractors, but they're much larger. And so they have a larger percentage of the vouchers that are out there. So again, credentialing, it has been a problem for a long time. People are aware that it continues to be a problem, and we are looking into that. We have been, at one point, we were allocated our own credentialer in the homeless program. However, that credentialer is not panned out at this point either. So it is something that, again, people are aware of, we're working on, we're trying to get through that piece because it affects both sides of the house. So both sides of the house are kind of stagnant when it comes to increasing staff to be able to really utilize the referrals. Yes, we also have a housing navigation contract, right? The contracts that Estelle spoke of are just the case management contracts. We have a housing navigation contract. We just also secured a PBB contract so that we have had so many PBB developments, which are great, but we were unable to keep up with staffing them all on the VA side. So we have now allocated about 15, about half of our PBBs to contracts. They're stuck in credentialing. They're trying to get on board, and we do have some coming on fairly quickly. But about a year and a half ago, 2 years ago, we got the housing navigation contract. We had originally 3 different agencies to assist with navigation. As I think our housing authority spoke to, it's very difficult in LA, so a couple of them have just stopped their contract after the first year, decided not to pursue it. One of them we pulled after the first year as it just wasn't successful. But we have one contract that is really successful and doing well, along with us, the VA internally, having our own housing specialist and peer specialist to help. So we are trying to address housing navigation. Estelle and I personally have reached out to some larger landlords or developers that aren't necessarily going PBB, but want to use their apartments for tenant base. And so we are working to do some future lease ups with the veterans that we have had on our interest list that we are blitzing now to just get everybody into a voucher. You know, our concern is just, we don't want to go back to where we have everybody having vouchers, because that's kind of where I came in many years ago. We want those vouchers to be housed veterans. And so we want to make sure we're doing this thoughtfully, and we do have enough staff to wrap around everyone, which is what Sally spoke to in the one team. It really provides the services for the veteran.
All right, well, I want you all to know this was great, and I am not a pushover when it comes to timekeeping. If the questions decline in quality, we will stop on time, but if the questions increase in quality, we will keep going to get the job done. Having said that, I'm going to ask one final question, hopefully. Sealed to be the judge. So, you know, one of the things we have to do as a board is we have to make recommendations to the VA and to its leadership on what's the right size of the campus. What's the right size of total number of units? The original MOU said to the principal developer, at least 900 units. The master plan now talks about 1,200 units, and we have to make this decision about, is 1,200 units still the right number, or do we move or suggest a higher number? So one of the things we have to balance is voucher utilization and how much that can be improved. And then one of the other things is, of course, Proposition HHH. So for those of you who are not Angelinos, about 8 years ago, we passed a $1.2 billion proposition to build affordable housing. And at the time, the city identified a substantial portion of that to be veteran specific. And so I don't know if you're prepared to give us an update on where we stand on that today, or it should be the subject of a future presentation. But I'd like to get a sense as to kind of how far the city is on that development of veteran housing using those HHH funds.
Yes, so the Triple H bond measure, 1.2 billion, was a city measure, and LHD, the LA Housing Department, has been responsible for funding the capital side of the developments. All of that money has been put out to the developers. On the HUD-VASH side and the regular PBV side, we are coming up on using up all of that money and attributing our HUD-VASH vouchers to the full allocation that's come about from that bond measure. So last year, our PBV program, we did about 2,500 new units. This year, we're doing, it's going to be over 3,000 units, and that will soak up all of the money that was used or earmarked from Triple H. The percentage that is HUD-VASH, I don't have a good number at this moment at what percent of the overall PBV was HUD-VASH. We have it on our slide. It's close to 1,000 units. But my sense is we have fully utilized that 1.2 billion on the PBV side, regular, and also HUD-VASH.
Okay, thank you very much. I want you all to know that you basically have a standing invitation to present to this committee every year. I think we need to hear from you every year at a minimum.
Can I say something just to your first point in terms of the right size, in terms of the number of units on this campus? I really, this to me is a really important issue here. When you look at our project-based voucher developments throughout the county, it absolutely has a different feel in reference to the camaraderie that exists when you get a veteran community together. It's something that's really unique and I think is really inspiring. And when I think about the possibilities on this campus, if there were 1,200 units today that were available, with our allocation of vouchers, I know that our utilization would just skyrocket. So I certainly am a champion of anything that can be done to get to that number or increase that number. This is an amazing campus, an amazing area that is highly desirable by our veteran community. So I think in terms of right sizing it, 1,200, if you can do more, let's do more.
So I'm going to make a request that we take a shorter lunch hour, and if at all possible, come back in 30 minutes and start 15 minutes early, because I think that this afternoon session is going to be informative too. So we're not going to be deliberating, so all we need is we just need enough people to resume. I ask everyone to try to fit lunch in 30 minutes. Good afternoon, Brett. The floor is yours.
Thank you. Good afternoon, everyone. I was going to say good morning, but I got bumped to after lunch, so it is now afternoon. My name is Brett Sims. I'm the Executive Director of the Office of Asset Enterprise Management, or OAEM, if you hear that term. I work in the Office of Management at the VA Central Office here. My predominant role in the West LA engagement is the EUL program, which falls under me and management of that program. If you want to go to the next slide, there were actually some very specific questions that the board wanted me to talk about today. If you go to one more slide, you'll see those 4 questions. These relate to essentially the arrangement that VA has with the principal developer, and specifically within the MOU and the EUL that was signed with them. So I will do my best to answer specifically the questions, but I think as everyone knows here, this is part of a much bigger conversation on the entire North Campus and how the town center, the community plan, all of that comes to fruition. So I will add some additional context as we go through this that hopefully will be informative. I also know that there will likely be a lot of questions when I get to the end, so I will keep my slides brief, hit the key points, and then certainly open it up for questions at the end to go from there. Before we get into this, I do want, Rob, you had mentioned at the very beginning of this, the recommendation related to 408. You will see that in the principal developer presentation later this afternoon. The timeline for 408 is slid to the right. Not getting in front of the secretary's response to the actual recommendation, but just realistically, the timeline is no longer the spring of 24 for us to make the decision on that. It is pushed into 25, and you'll see that update when the PD does that. It's still in pre-development, so we're still working in that piece of the world there, but it is something that maybe doesn't have quite the urgency it did originally. Okay. So I've got one slide on each of these, and I'll talk through it, and then we'll get to the end and open it for questions. So next slide, please. So the first one has to do with what are the agreed targets for construction of permanent supportive housing. So within the principal developer EUL, we have an agreement to make at least 900 units available. First question you might ask is, why is that not 1,200 units? Well, the answer is the principal developer is not developing all of the housing on campus. There are two other development teams that are working on or have already delivered housing. The Shangri-La Step Up is building 205, 8, and 9, and Core Companies is working on MacArthur Field. Combined, those will deliver 300 units of housing that when you add the 900 units of housing we're asking the PD team to deliver, you get to the 1,200. It is, and I highlighted it there, at least 900. So to the question that was raised to the housing authorities here, is 1,200 the right number? This does give us the ability, and we do have more parcels available to develop more than 1,200 units, and that would go under the PD EUL above that 900 that is there. Okay. There is a parcel release schedule, which is a document that we do make publicly available. It is updated on a quarterly basis. The actual enhanced use lease did have a draft parcel release schedule, but things do change between financing considerations. GLA operations are still in some of those buildings. So as things change, we do want to be transparent with that. So we do publish that parcel release schedule on a regular basis, and it's available on the GLA website. We're due to release an updated one here in the very near future, so you'll get the most recent update at that point. Okay. Okay, you want to go to the next slide? So what are the commitments that VA has made as part of that principal developer EUL? And realistically, there's a couple, and the biggest one is our assets. So land and buildings that are made available to the PD team for redevelopment purposes to convert into the housing and the supportive services that are necessary there. We also have the ability to do capital contributions. Capital contribution is something that the EUL statute allows VA to contribute money from our minor construction account to an enhanced use lease developer to help offset the cost for specific things that need to be offset. Example would be historic buildings or buildings in poor condition. If there's a lot of abatement that's needed, that's not necessarily something that they typically get financed through low income housing tax credits or other financing sources. VA has the ability to directly contribute money for a capital contribution to these individual projects. And we've done that on several of the projects here at West LA. The largest one was actually the trunk line work that we did. So going up Bonsall Avenue, bringing in a whole bunch of dry utilities to support the North Campus was about a $13 million endeavor that VA contributed directly to the enhanced use lease with the PD team for them to be able to do that work to support the North Campus. So that is another piece. What isn't finite in the enhanced use lease is how much money. That is a TBD as we go through each of the parcels to be released. That amount is determined of what that cost could be and whether VA has the ability to contribute for that particular parcel. And then we have a commitment agreement that we agree exactly how much and for what purposes we would contribute that money to the PD team for development on that parcel. Okay. So those are the two core pieces. Now it is worth noting in the chart on the right, This is what you would see in the parcel release schedule. There's actually 20 parcels that we had identified that could be available for housing purposes. To get to the 900 units, we only need to use about 14 of those parcels. So there are additional parcels that we've already identified as potential use for housing that would take us above that 900 unit. You might hear us refer to those as below the line right now, so not necessarily committed to delivering those housing units, but the parcels are available, and that is another piece that VA is committed to as part of the PDEUL. I think that's about it on this question. So if you get to the next slide. So this question has to do with the memorandum of understanding, or MOU. Did VA state that the principal developer would be responsible for executing town center development? Short answer here is that the MOU did require the PD team to plan for and do due diligence for a community. It did not use the term town center, but it did imply that we were asking the PD team to look at the community as a whole and not just the individual housing units to get to the 900 that we're talking about there. Okay, so that's an important distinction here. The MOU was not legally binding at the time. So ultimately, the next question you asked was the EUL. So the EUL would supersede anything that was done in the MOU originally, but the MOU was our first opportunity to ask the PD team to take the broader view of how does the housing that we're asking you to deliver fit within the broader community that everyone wanted to deliver here. So the term that we heard earlier today, I think, was connectiveness. How does that factor in? We did not want the PD team to say, I can put 50 units here, 50 here, 50 here, and I've met my requirement. How does it all tie together? So we did ask them at the first point of the MOU to have that vision of the community and not just the individual housing units, okay? But again, it doesn't ask them to execute a town center. So just to be clear, that is not what the MOU said. It looked at the due diligence for the community plan in and of itself, okay? And if you go to the next one, similar question, but specifically about the enhanced use lease that was, so the MOU is outdated at this point. The enhanced use lease is what replaced it. You still will not see a direct reference to executing a town center. Okay, that does not exist within the PDEUL. What does exist within the PDEUL is the requirement for the supportive services to go along with the housing. So what we're requiring the PD team to deliver is not housing. It's permanent supportive housing. So there are services that go along with that we are asking them to deliver specifically, but we've also asked them to continue with that view of the community and help coordinate those services across the community. Not execute, not necessarily deliver all of those services, but help us with the plan to ensure it all touches each other correctly and doesn't end up being 12 or 14 different housing buildings with nothing to go along with that, okay? So this is a trickier question when you really get down to it, because it starts with what is the town center? So the town center is not necessarily a thing that you would ask someone to execute. It's a concept, it's a location, it's a central point within the campus. But what exactly goes into making that a town center is TBD. You know, we talked about some of this yesterday. A hotel, could it not fit? We don't necessarily know the answer to that question. I think there's some logical supportive services that go with most housing developments that we would say, of course that will be there. But there's still a lot of work to do to get to the point of what are all of those things that need to be in that town center concept to make the community work. Some of those things will fall to the PD team because it's a supportive service for the housing directly. It is something directly tied to the residents of the North Campus that they would deliver as part of one of the EULs on the North Campus. There will also clearly be things that are not part of the supportive services that fall outside of that. Simplest example, the coffee shop. Coffee shop is not a supportive service for the housing directly. The PD team, we've asked them to say logically, where does that fit? Where is there space within buildings and within the network of roads and pedestrian paths? Where is it likely that a coffee shop would be the most advantageous? We did not ask them to do the coffee shop. VA actually has a great canteen service that can deliver coffee shops and other things like that, or VA could choose to bring in a third party via the service lease component separately So we're not asking the PD team to do the coffee shop, but we are asking them to plan for it as they look at all of the buildings and the housing to be developed on the North Campus. So a nuance, but very important when the question is about who we ask to execute. Most of those types of things, we've not asked anyone to execute at this point. We're still in that fact finding to figure out exactly what services should be provided, what the veterans want, what they need on the North Campus. But there's clearly a subset of that that we already know that is part of the supportive housing that would be developed that the PD team is working on and will build into the units. Most of the units that are in place, for example, have a food pantry, okay? That's not a residential unit. It is something that's built into the building to support the residents that are there. That's a supportive service. We don't have to do a service lease for that. It's directly tied to the housing. But there are other things that we've heard in this forum and from veteran input before that will not fall easily within that supportive service. And that's where those service leases come in. But where do you put those services? We have to have a plan. We have to have space. We have to have a concept of where that goes. So we have asked the PD team to carve out spaces in different locations for those services. And Building 300 will come up here pretty soon. That's a good example of one. Building 300 was proposed with about 15,000 square feet of supportive service space. So it's definitely not all housing. It's bringing in a lot of those services. As we work through the development of Building 300, the question is what then are those services? Specifically, what are the services there? And then who would actually execute on those? Would it be part of the EUL with the PD team? Would it come back to VA to do if it was a coffee shop or something like that? Or would it be carved out to be a service lease for another purpose that is there? And we will address those things sort of building by building to figure out what exactly goes there. But we're starting with the concept to create that flexible service space in multiple buildings across the North Campus so that it is available when we do get to the point where we're making those decisions on those specific services. Okay. So with that said, those were the specific questions. I think I've answered the specific questions, and I know that will generate lots more questions. So let's just go ahead and get into that.
Thanks, Brett. Thanks for being so direct and responsive to the questions asked. I'm going to start with just a real clear procedural question because I want the board members, especially the new board members, to have an understanding of terms of art. So a master plan is something that was done in 2016 and 2022, and VA as an agency authored that master plan, correct?
Correct.
And when you talk about a community plan, that's something that's called for from the principal developer, and it's a way in which they describe a community atmosphere they want to create for the veterans that they'll be housing in permanent supportive housing. Isn't that right?
Correct.
Okay, so big picture, while we want the principal developer's input on the arrangement of housing, the responsibility of determining where the zones are and what happens in each of those zones is something that resides with the agency, right?
Yes, I think that's fair.
Okay. So I want everyone to have in mind that while the principal developer can make recommendations about how buildings ought to be used, the master planning function that informs their use is something that has to be decided by the agency with input from us. Okay, because it's her birthday, Stephanie, it's the next question. Isn't that dedication? She's here on her birthday.
I am. Stephanie Cohen. I have a whole page written of questions, so I will go until you tell me to stop. Is that fair for now?
Let's do 5 questions.
Okay. Okay, so my first question is about the parcel release schedule. When is the Q1 parcel release schedule going to be released?
I would say within the next week, 2 weeks tops.
Okay, and I just want to confirm that at the beginning, the first question you answered, or before you started answering questions, you said that building 408 is pushed to a later timeline, and you said 2025. Do you know when in 2025?
I would say spring. I don't know exactly which month we're projecting, but spring of 25.
Okay, and what do you anticipate is going to happen between now and 2025 that is informing that decision to move the parcel? And I ask that because obviously we had a recommendation from the last meeting around the buildings below Nimitz. And I would like to understand what the process will be on the VA end to assess the options that we have for the town center, whether it is the 2016 plan, the 2022 plan, the ULI plan. Where are we going to land before 2025? Is this going to be worked out through a strategic process before additional parcels are released, whether it's in May of this year or 2025 or Q1 of Q2 of 2025?
So directly, there isn't a link between your recommendation and what happened with it. Indirectly, the ULI study certainly had an impact on it, and ULI brought up a lot of very good components. What I will point out is what is proposed in Master Plan 2022 is a mixed-use development approach to the town center. What I will say is the ULI study fully supports that. They directly call out using mixed use to develop that, to integrate it. So that was one of the things we were waiting for, was that input from a previous recommendation from ULI of, do we need to change the paradigm overall? The question about north or south of Nimitz actually goes more to the question of how many total units do we think we're going to need, and the question about the southeast portion of the homeless, potentially at-risk college components. So those are all pieces that we'll be working through that will help drive what would or could not change between now and 2025 when we would release that schedule. So that was some of the drivers, but those are also some of the inputs into what we need to go through to figure out the timing and the buildings to be released going forward.
Thank you. And is this board going to receive a presentation on what the decision looks like around that strategic planning before contracts are issued with a developer?
Well, so I would say, yes, you certainly can have a presentation on it. The contracts themselves, if it's going to be housing, would already be part of the PDEUL. All of the other components that would be service leases would be done a little bit differently and separately for actually delivering on those services wherever those might be. So yes, I think you would, but those would be the only contracts issued as a result of those decisions. If we move parcels around, it doesn't change the PDEUL. It just changed the parcel release schedule itself.
Okay, and I think at the last meeting you were asked if Building 408 was confirmed to be developed by the principal development team, and I don't think there was an answer, so I just want to follow up on that. Can you confirm that the principal development team is selected for Building 408?
I can confirm that, yes.
Okay, thank you. I read one more.
Just because it's your
Okay. Okay, I'm not even gonna ask another question. I'm just gonna make a comment about the process, because I think that we've talked a lot about the difference between the 2016 master planning process and the 2022 master planning process, and just understanding what the collaboration and input from stakeholders and veterans really looked like for those two processes. It almost seems like in these discussions, as we move forward, we're now in 2024, that the 2016 master plan has sort of just been, like, you guys just scrapped it and put a strike through it. It's really important. I'm not a veteran, but I am on this board because I was part of that process, and there were tons of veterans who were there and part of the process. You can't just forget about what happened in 2016 when establishing how to reconcile the differences between the 2016 town center concept, the 2022 town center concept, and the ULI study. Did you understand why the ULI study was done? And it's important. So I want to make sure that we just don't forget the real stakeholder involved process that happened in 2016 and how important it is to this campus moving forward. Thank you.
Yeah, let me just emphasize the point she just made for some of our new board members. This board asked for a third party, the Urban Land Institute, to study the viability of a town center, because we thought that in the move from the 2016 master plan to the 2022 master plan, the agency had diluted the vision of the town center. And we also had some concern that that was a function of the agency ceding too much of its master planning responsibility to the principal developer. and agreeing to the notion that if the principal developer had a community plan for housing, that was the same as or sufficient to constitute a master plan. So I, for one, am very disappointed at the idea that we have to turn over building 408 at this point. And you know I've had a long-running concern about turning over building 13. About a year ago, when we were briefed on the new version of the enhanced use lease, I specifically asked whoever the briefer was, it may have been you, Brett, but it may have been someone else. Does the framework established by the EUL compel the agency to turn over to the principal developer buildings that are identified in the EUL? In other words, does the EUL framework amount to a right of first refusal so that now the principal developer knows this is his or her to do with before anyone else gets it? And I was told in public session, if I recall correctly, no, it does not. That the agency, even though it may have identified these parcels in the EUL agreement, is free to decide that it's not going to turn them over. So with that as a sermon, I would just say, I would really encourage the agency to think about using its power under the EUL to pull back the parcels that have been identified for the principal developer that are in the town center area as originally defined, and hold those for the time being, because otherwise we're giving those up for 99 years. Okay, Jim Zenner.
Do a lot of talking.
That's Sandor. I'm going to ask a question that may not be for you. And so I'm open to being told, I'm brand new to the board, so I'm open to being told this isn't the right forum for this question, and I can hold it for whoever can answer it at some point. Just a little bit about my background. The first 10 years of my career were spent working for a developer of permanent supportive housing. And we developed some of the largest supportive housing in the country, 652 units in one building, 416 units in one building. I ran the 416 unit building for 5 years. As I'm getting to know the site and what's planned, the concentration of 1,200 units of permanent supportive housing for very vulnerable people in one area is I think, unprecedented nationally. And the examples that do exist are not great, when you look at high concentrations. And so I know we're talking a lot about mixed use, which I think is really, really important for this to feel like a community. But what have the conversations been about mixed income, and especially on the North Campus, not this segregation of certain populations in certain areas and those things not being integrated? So again, this might not be you might not be the right person, but I just feel curious about if that's been in the history of the development of deciding where the projects are going to go, if we've been also speaking about mixed income. I do understand that 1,200 units are focused on a formerly homeless population, but I guess I'm asking, going beyond that, has there been talk about how you'd integrate mixed income into the site as well?
It's a great question, and I can only answer part of that. So part of the EUL requirement does focus on homeless and at-risk for West LA. So the EUL program outside of West LA does have some broader parameters to it. I think you heard Kristen mention that yesterday. The PACT Act expanded our authority to do things beyond housing that would be just a benefit in general for veterans. So outside of West LA, there could be a different conversation, but here, it is very focused on the homeless and at-risk definition for veterans. So specifically other types of housing, we can do that, but in different venues. So there's the bridge home and all the different kinds of sort of more emergency housing. But if you're looking at something that is closer to market rate type housing, there isn't really a good venue to do that under the current authorities that we have here. So it hasn't been necessarily part of the conversation.
That's Sandra. One more just to build on that. Not talking about market, but low income, affordable.
So there's certainly different targets with the different buildings in the different parcels. So you'll hear from the PD team, there's one coming up, 210, that's going to have a section for women veterans. So within there, but it hasn't really been income focused. It's been more about senior, disabled, some family-based, some for women. It's been more about the different groupings of veterans that might need different types of housing needs, less about the income piece of it.
All right, we'll hear from Dylan. Jim Zenner.
Jim Center. I'm interested to hear about some of the limitations of service leases. So in the ULI report, I think what was mentioned was like a restaurant, hotel, things like that. So with the service lease, could the VA enter into an agreement specifically with an organization to provide those amenities on the campus?
So let me answer it directly. Yes, we could enter into an agreement with an entity to provide those services on the campus. Absolutely. The question really, I think, Jim, that you're asking this is, there's an enumerated list of things. How does that requirement fit within that enumerated list? So a restaurant is going to have the same question that the hotel does. How do you ensure it principally benefits veterans? Nutrition is one of the things as an enumerated thing on a service lease list. I could say a restaurant supports that, but how do you satisfy that principally benefits veteran requirement that also exists out there, not related to the service lease specifically, but to everything, all land use? How does it principally benefit veterans? You might be able to get to a yes on that if that restaurant was structured in a certain way. And I heard a lot of great conversation on the hotel. Maybe it's not a hotel. Maybe it's something that's more like what they have at some of the NTFs or some of the other, DoD locations that is specifically for service members. Maybe we do one specifically for veterans. That's not really a hotel per se. It's a different, you might be able to get there, but that's really the trick is whatever the use is you're proposing for that service lease, does it fit within the allowable uses of a service lease on this particular campus? Does that make sense?
Yeah, it does. And then I don't know if Stephanie asked this, I might have missed it, but can we get 1,200 units north of Nimitz built?
I don't believe so. I don't believe so. There could be, it would be close because there are 408 being one of them, Building 13 being one of them. So there are a number of those. And most of the ones that are currently quote unquote below the line are south of Nimitz. So we couldn't just flip. There's one building clearly that we could flip, I think it's 257, but I don't think that gives us enough density if we take out 408 and we take out 13 and some of the others that we've talked about.
And is it possible to, for the VA to solicit for a separate developer to look at town hall and other amenities on the campus?
So again, we could do service leases for those, but to Rob's point, ultimately VA's got to make a decision on what those services are, fully supporting that it's got to be driven by the stakeholders, the veterans, and there's been a lot of input, but whatever those services are, how we go about executing those, in most cases is going to be either a direct supportive service to the housing and it falls underneath the VUL and it's done by the PD, or it falls outside of it and it'll all be done by service lease, provided it fits within the definition.
Great, thank you. I think the important piece here is making sure that the stakeholder engagement's right for those type of facilities, because it's important to get the opinions of our fellow veterans that are on the campus, that live on the campus, but you're also going to want to have folks like myself and other veterans who are hiring managers coming up here onto the campus and using the campus, interacting with veterans and their families that are on the campus to really kind of integrate that piece. And if we fail in the stakeholder engagement on that, I think we might not get this right.
So Brett, I've got some questions that I'm gonna ask from a real layperson perspective, because that's what I have is a layperson perspective. Because I know that for you, it's one thing to have Congress give you a leasing authority, and it's a different thing to have Congress give you a funding authority. So I'm going to try to tease these issues out and ask you to share your thinking with the group. So I guess the first thing is, when Congress passes the West LA Leasing Act and it comes up with those service leasing authorities that mirror the original description of the town center, so the stuff we've talked about, nutrition, recreation, socialization. Congress says you can enter into these leases, but Congress didn't provide you a separate funding sources for those leases, did it?
Did not. I'll take it one step further. Under a service lease, VA actually has no ability to contribute to that service lease. 100% funded and operated by whoever you lease with. EUL, we can't. We can do that capital contribution. West LA Leasing Act didn't give us any money for that either, but it does give us the ability under EULs for permanent supportive housing to contribute. Service leases, we have no ability to contribute to that.
Yeah, so let's just say Corporation A. Let's just assume it's a private corporation. If it wanted to come in and operate a a restaurant on this property under a ground lease, under the service lease authority of the West LA Leasing Act. The challenge it would face is most conventional financing wouldn't want to serve a captive population that's limited to principally benefiting veterans, right? That while we think that's a desirable mission, most market-based lenders wouldn't agree to finance that construction, correct?
I would agree with that.
Okay. So what I want the board to appreciate is we've got a mismatch here. And it's not a mismatch that's the agency's fault. It's a mismatch. We just haven't told Congress we need these things married up. So that's the first example. I guess the second thing I was going to ask you is, we've talked a lot about Building 13, and there's some of us who regard it as one of the real architectural gems, and we'd like to put a lot of the civic identity of the campus in it. But I also know that you, based on that outline, say, hey, if we give it to the principal developer, they can put 24 units on the second floor. And by means of doing that, they can finance the rehabilitation of it. So because I think the agency's thinking has evolved on this issue, can you tell us currently how you think that you could split the use of Building 13?
So I think what we've been working with the PD team on is if we develop the 24 units of housing, there's a significant amount of service space that would be programmed in there. And the question then becomes is, what is that service space? Some of it, and I think what we had envisioned and the PD team would envision, is Building 13 would serve more of the community service space rather than the building service space. So you wouldn't necessarily, in other buildings, you might have a computer room and a food pantry and things like that in almost every building out there. Building 13 would have a lot more communal space that was designed to support the entire North Campus veteran population and beyond that, because that is one of the areas we talked about as having, coffee shop or restaurant or dining options. But it would also have a very large, like, conference room, for lack of a better term, a gathering area, a grand ballroom type scenario there that is not supportive to the housing. It is for the community. So it's a community amenity. How much of that space could be made available is sort of the question, but it's a significant amount. Building 13 would be predominantly service space rather than the individual residents.
And I want to make sure I understand, to take Building 13 as an example. Would the principal developer have the fee interest in the second floor and VA would hold the fee interest in the ground floor?
If it was those communal uses, like I'll just use the restaurant, and I'm not saying restaurant fits within the service lease definition, so my attorneys don't get upset. If you conceived a restaurant that met all of the requirements and you could enter into a service lease, when that building is leased to the principal developer, that square footage would be carved out. VA would retain responsibility and ownership of that space.
So the agency's thinking has evolved on this, I think, because I think when we asked this question about a year ago, the notion was we couldn't split buildings by floor and enter separate leases. Is that right?
We can do that, yes.
Okay. So we've got this mismatch, as you've explained it, where Congress said you can enter into these service leases to support the town center, but we don't have any obvious funding source. When I went back and looked at the early work of the Federal Advisory Committee years before I got involved, I saw that early on there was a suggestion that we ought to explore Chip-in Act funding. For those of you who don't know, the Chip-in Act was something passed by Congress about 7 years ago. And it allows projects that are on the Strategic Capital Improvement Plan to be paid for by private donors. And it's been used on just a few sites around the country, but it's been used pretty creatively, and I trust you can all see the relevance of it here. The question I have for you, Brett, is, because I know you study the SCIP probably more carefully than anyone within the agency. Could we make some of these town center activities fit within the parameters of the SCIP so that we could invite third-party funding?
The quick answer is no. And I say that because the end result of the chip-in project has to be a donation of that asset to VA, and it has to satisfy a VA requirement. So if you're going to use it for a function that VA doesn't have the authority to operate, I'm just making things up here, but a hotel. VA doesn't have the authority to operate a hotel. Even if someone donated that asset to it, it wouldn't satisfy that it meets a VA requirement to come there. So that's the challenge with it. They have to donate it, and it has to be a bona fide VA requirement that they donate.
So I need to make sure I understand this, is when Congress passes the West LA Leasing Act and says in B1, you're authorized to enter into service leases. And I think it's clear Congress is contemplating creation of a town center on this federal property. Is that not a VA requirement?
It is not. That's why it would be a service lease for the third party to do that on behalf of the veteran community, not VA.
The lawyers are going to have an argument about this, and I want to be in the room. Because because then we've got a real big mismatch that we either have to resolve or we have to go back to Congress on. So let me get to my final question for you. So you told us there's this mismatch between what Congress said we can do in terms of a town center and no funding. And I take it your preferred solution is we've got all this recent appropriation from Congress in the form of the enhanced use lease. And so the parties who have entered into enhanced use lease agreements like the principal developer, we should go ahead and partner with them. Is that your preferred course to execute the town center?
Again, no, because I don't think the town center is a thing that I can say someone any individual is going to execute. I do think that the town center concept of mixed use for the exact mismatch that you just described, funding is available to develop and renovate housing. Mixing in the services is the easy way to get the capital to do the building in and of itself. But it doesn't mean the PD is going to be the ones delivering or even responsible for some of those mixed use service offerings that exist predominantly on the ground floor of most of the buildings.
I think VA articulating how it's going to hold back some of these assets is super important to us. I think many of us who visited villages at Cabrillo were deeply impressed by what the principal developer accomplished by way of housing. But we also came away thinking that housing ought to remain their focus and that other activities that we've contemplated for the campus ought to be the subject of competitive solicitation. Are there any other questions?
Get the rest of the
Stephanie Cohen.
Stephanie Cohen. I don't have a question. I have one last comment because it would not be right of me to not make the comment, and I would lay in bed later tonight and wish that I did. This board was created for a reason, and we need to remember that between the board and the VA in these discussions. There has been not a lot of transparency around this topic, which is evident in the ULI report not being released until last week. I haven't seen it be published or posted anywhere super public for veterans to read and comment on. I only had a week to read it, and I'm on this board that is responsible for this. It's unacceptable, and this board is going to hold the VA accountable for these things. We need transparency moving forward when parcels are being released, when parcels are being scheduled, when decisions are being made between the principal development team and the VA. And we will keep making recommendations to that effect in future meetings unless we get some transparency around this process. Thank you.
Anything else? Really appreciate the discussion.
Thank you.
Okay, let's take a 15-minute break and then we'll have public comments. Everyone please be in your chairs for public comments.
I don't understand. It's when they say just saw it here, like virtual set, legal services. I don't really know. But there are a lot of. There are also plans to What's up, Mr. James? When they swear, so everybody knows there's the tour yesterday. Yeah. And they.
You could argue that.
Oh, no. Fisher House. Oh, we haven't even thought about all those times. Every year.
We're not good on that. Some of the units that.
The last thing I want to mention is, it was talked about that the PACT Act gave the West LA VA more money. And, a good friend, Sergeant Brian Alvarado, died on January 22nd. He's not gotten any of that PACT Act help, and he was a victim of the burn pits. And again, what is being accomplished in this room as veteran homelessness only increases? That's all.
Devermont. The next public comment will be from Anthony Allman, who I believe is online. Okay, we'll move on. The next public comment will be from Sal Ramadica. The next public comment will be from Earl Davenport. All right, we're going to move on. The next public comment is from Anthony Wimberly. We'll finish the list with Mark James.
Hello, everybody. My name is Mark James, and I'm a resident here on this campus. The housing here is great for the veterans, but also too, we don't have anything to do here because you put us in these houses, and that's what y'all do, just put us in the house. There's no activities, or the activities that do have is limited. It's thing with me is that the veterans here need something to do for its employment, education, things like that. You bring, and the veterans doesn't have anything to do in their housing other than watch TV in their room, or go to the community room, or watch TV, and then they get bored, and then all of a sudden, other elements come in to our building, which is not allowed. I've put in a proposal for a commissary here because the veterans here is tired of walking down that hill and up the hill, going to Ralph's Market, which is very expensive, and coming back with limited groceries because they're
are not able to walk back up that hill because a lot of us is disabled. Transportation is very vital to us out here. Transportation is limited to the veterans that's in this housing. Thing that bothers me most of all is the women veterans. There are limited programs for the women veterans here. There's housing that you're putting us in, and there's no family housing. We are been in the military with a bunch of men, and then now you're forcing us to live with a bunch of men, and I don't think that's kind of cool. Because we do have wives, girlfriends, that we would love to have come stay with us inside these apartments. But due to the rules and regulations, we are not able to. The thing is, I'm just trying to iterate to all of you guys is that think this thing out thoroughly. Because the rules that you guys are putting on these veterans here on these grounds it don't even make sense to me. 14 days, you can only have a visitor for 14 days out of a year. But we're paying rent here. And it's supposed to be independent living. And by being independent living, that we should be able to have whatever we want in our apartment, And I was asking you guys, would you do that? If you move into an apartment building and the manager tells you you can only have guests in your apartment for 14 days, what you gonna do? Also, too, you have veterans here that are homeless, that's been out here in the streets. You need programs set up to show them how to budget their money, show them how to save money, so that they can learn to be productive in society again. Thank you.
Thank you, Mr. James. Next public comment is from Ryan Thompson.
Thank you. Only two stakeholders are authorized to use this National Soldiers Home, per deeds accepted and agreed to by our federal government, as recorded by congressional acts, and any ethically legislated federal laws aligning under those deeds term, that only our federal government permanently maintain all this federal land, as only a home for disabled and homeless veterans. Veterans whom at will, when afforded, may shop anywhere within the town centers already flanking 3 sides of this National Soldiers Home. Despite this information, the National Soldiers Home's 2 stakeholders are not Montana Senator John Tester's Brentwood donors, California's Century Housing Agency converted into a publicly funded private corporation, evading full performance housing the families displaced by the 105 freeway we pay them to, and over $70 million a year Brentwood School that sued homeless veterans and maliciously lobbies to continue stealing their home, where its math teacher was serially raping a student, the University of California that lobotomized this home's disabled veteran residents for decades, Shangri-La Construction, run by UCLA football's Andy Myers ever since prior CEO Stephen Bing's hookers and blow addiction turned his focus from big campaign donations toward the Century City penthouse window he left from. The step up on second, Janice Hahn in 2019 gave $14 million of mortgage bonds to acquire, renovate, and house veterans in what they declared was an empty office building called 209 here. It was the same building they illegally acquired in 2017 that VA had already renovated in 2015 and veterans were already living in. This National Soldiers Home's 2 stakeholders are the disabled and homeless veteran plaintiffs and U.S. Department of Veterans Affairs pit against each other by University of California attorney Mark Rosenbaum in a case his University of California colleague David O'Carter presides over. The law firm of Beverly Hills Bars Public Counsel and the Inner City Law Center behind the minimum security prison of sheds without sinks and toilets it calls homes are simultaneously counsel of record to the veteran plaintiffs. And since years ago, the VA, they're deceived to sue. Thus divide and conquer is the approach to displacing veterans in VA by a HUD-VASH scheme's 20-year expiration date. So LA County and City can tax everything around 20,000 subway commuters a day would do in an illegal West Side metropolis. If Rosenbaum's new lawsuit is what Cal Matters tells California's formerly independent news agencies to publish about it, as opposed to the fraud of protecting the non-existent so-called settlement, obstructing the judgment order of homeless veterans won to evict Brentwood School and UCLA back in 2013, this would be a federal criminal case, a U.S. attorney indicting racketeers on RICO. So when that happens, don't forget the illegal enhanced use lease scheme stages developers to default mortgages into Baker's repossession. Meanwhile, we're at Booz Allen's Concourse Federal Advisory Committee meeting, responsive FOA docs credit Thomas Paine for show running. Despite feigning a dialogue between the racket you represent and homeless disabled veterans defrauded to death by it, it's really the meeting's only monologue. Amid a racket's orders, you self-censor from engaging those whom you're federally chartered to improve the lives of here. All this censorship, soft power, scripted due diligence, exploiting a pandemic to segregate and arrest the public from speaking back in June of 2022, bought off advocacies, veterans charities, and ulterior motives, and pay-to-play news. Our counterintelligence failing to manage the huge volume of lies it created, despite the multi-billion-dollar racket backing it. Given the education several of you received at our country's top defense intelligence schools, while others studied how to serve homeless veterans to get the jobs you did instead, did you forget its truth that's easy to remember and confidently communicate? Because counterintelligence requires removing truth from information. The illogic of whatever fiction replaces doesn't last and is hard to communicate in ways deceiving people as intended. When this contrast shares a room is when you're ordered to zip it amid nothing viable to say. Since learning long ago that counterintelligence sent us into Vietnam, the counterintelligence lost Vietnam, and counterintelligence inspired people to misperceive what was intelligent to spit on those who returned from Vietnam, instead of the counterintelligent people that sent them there. Why is a criminal racket high-fiving itself in 2024 like it's ingenious to pretend we're ending veteran homelessness with counterintelligence? Whether you're ignorant or aware of this racket's inevitable approach towards self-destruction, our great concern is how many more veterans will this racket kill with homelessness before that implosion day? I'm sincerely worried about you and your freedom's jailers, because no matter how many pages of fine print there are in two bills behind multi-billionaire Mark Benioff's California Proposition 1 that a bogus University of California San Francisco Institute fronts, and no matter how much progressive Senator Padilla publicly seems upon quietly submitting 118th S3165 and its HR 773 companion bill, Black people, Hispanic people, the homeless and veterans are not California's most underserved people requiring involuntary treatments. And the nearly $2 billion megamall slush fund U.S. vets Steve Peck shoved into Prop 1 is not a mental health program. Contrarily, it is truly evident, amidst your silent defiance and unremorseful witness to the systemic veteran homelessness and death caused by the racket you represent, you are among California's most underserved people who are in dire need of prompt mental health treatment by law enforcement agencies in partnership with psychiatrists, should we avoid revisiting the streets of Chancellor Hitler's Berlin, approaching the city's 1936 Summer Olympics. Thank you.
Thank you, Mr. Thompson. If Mr. Powers, Jeffrey Powers is here, we'll hear from him now. Okay, and Janelle Hoffman one last time. How about Anthony Allman on the phone? Okay, we're gonna call for Sal Grammatica one more time. Earl Davenport. And Anthony Wimberly. Okay, so we're gonna go to our standby list. Larry Laughlin. Marvin Gunn. All right, last standby, John Eaton.
I am John Eden, and I'm not a Bruin. I went to USC, proud student there, and U.S. veteran, Air Force during the Vietnam War. And I'm here because I'm concerned about the Wadsworth Chapel, and will it ever be finished? I belong to a group of ad hoc veterans who are also concerned about that particular place in our city's history, because I think that it's a place of reparative possibilities for returning veterans after wars, PTSD, people that have been injured spiritually, who need help. And I've heard a lot of things the last 2 days about homelessness and the hospital itself. And I think those are all valid issues, but I also think that there's a place for spiritualism for people that believe in something larger than themselves. And I think the Wadsworth Chapel is that symbol. And our group is comprised of veterans, and the oldest veteran is Harry Core. He was a World War II POW, Bataan Death March survivor, and he's 100, and he will be 101 May 1st this coming year. And frankly, we would like to see this finished before Harry departs this plane, and I would just like to hear that it's going to be finished, and it will be finished soon, because I think it's very important historically for LA as the oldest building on Wilshire Boulevard. But I also think it's important because it stands for something bigger than ourselves. It stands for when it was originally built for Civil War veterans to come together and build something together after the Civil War. And I think that today we have 2 different countries going on. And I think that we need to come together again and put this chapel back together as a symbol of putting our country back together so we can all function together again. And that's all I have to say. Thank you.
The last comment will be from Rob Reynolds.
So just to echo what everyone else was saying about the land use issues here, obviously that's a big issue for a lot of veterans that the VA has been leasing off this land to Brentwood School, UCLA, Brightburn Oil Company. That being said, there is a lawsuit in federal court, and Judge Carter on 3 separate occasions has asked, where is a representative from the VA that can make decisions, and why are they not there? The Department of Justice attorney never has an answer. Someone from the VA, from VA central office, should be at those court hearings and actually show that they're there to make an effort to end veteran homelessness and stop fighting everything that we're trying to do in court. Because it is a really bad look for the VA. It doesn't look good. The things that we're trying to address are income limit restrictions. That's one of them. And I see some of the representatives from Congress over here. What are you guys doing about that? I've heard a lot of talk for a long time, and I still don't see any action. There's still 100% disabled veterans that aren't able to get into housing, which is absolutely unacceptable. There's 4,000 homeless veterans in Los Angeles. There's 400 acres of land. There's plenty of room to get all the veterans off the street and housed here. And also, we need to get the CWT back, some type of compensated work therapy. I know that's here, but I don't think the program's doing that well. There's a lot of veterans in the housing that want to go back to work, that are constantly asking to go back to work. So with that said, I really hope that, again, Secretary McDonough's office takes this lawsuit seriously, gets someone to that courthouse. We'll begin mediation in 2 weeks. Thank you.
Thank you, Mr. Reynolds. So that'll conclude the public comment session. It's now 1:18. I'd ask everyone to be back at, I'm sorry, 2:18. I just want to be back at 2:25.
I like me. This is like it's actually great.
You went to the place where.
Okay, everyone, if I could have some quiet. We need to turn some time over to one of the most important actors in this enterprise, the principal developer. So I know we have some presenters online. If you could please introduce yourself and begin your presentation.
Hi, good afternoon. This is Brian DeAndrea, Senior Vice President at Century Housing. I'll be presenting first on behalf of the principal developer team, which consists of Century Housing, Thomas Safran Associates, and US Vets. As most of you know, we were selected by the VA back in 2018 to build a thriving and supportive community at the VA that upholds the promise of 1887 and does justice to our veterans. We'd like this afternoon to welcome all of the new VCOEB board members and congratulate Rob on your new chairmanship. Today, we're excited to share some of the multifaceted progress that we've made from construction to fundraising, community building, advocacy, and beyond. I know many of you had an opportunity yesterday to do a tour and have a chance firsthand to see the community that is unfolding on the North Campus, which is very exciting. Our MO is really to build a gold standard community. That's language right out of the original RFQ. We want to build a place that helps our veterans feel a sense of belonging and feel a sense of purpose. Belonging and purpose, those are two really important themes for us. And before jumping in, I want to acknowledge our partner, the VA, who has really stepped up over the past 5+ years and moved literal mountains to facilitate the parcel releases, develop the infrastructure, and work through many, many obstacles that we face in developing out this community. Next slide, please. So I'll start today with presenting a handful of Century's developments that are under construction, starting with Building 404. This is a new construction build that sits directly in front of Building 207, which you visited yesterday. It consists of 73 apartment homes. There are no specific set-asides other than these units being set aside for veterans experiencing homelessness. The property will support upwards of 5 case managers between the VASH case management and the property level case management that we're providing. The services we're providing at Building 404 include case management, mental health services, physical health coordination, substance use services, and beyond. Next slide, please. We began construction in November of 2022. Construction is proceeding at pace. Our framing is completed, the roofing is well underway, windows have been installed, drywall has been loaded, installation is underway, and the scaffolding is now up on the building. Next slide, please. We are slated for completion late next year. Next slide, please. We have one last photo here we'll share with you of Building 404. And we'll move on to the next slide, please. The next building or series of buildings is buildings 156 and 157. These buildings represent the adaptive reuse of the old tuberculosis hospital on the North Campus. They consist of 112 apartment homes. 35 of these homes are specifically set aside for veterans experiencing homelessness that are also presenting with mental illness. These buildings will support upwards of 6.5 case managers between the VASH and the property case management. The services array is consistent with that just reported out on building 404. Next slide. We began construction in June of 2023 and are slated for completion next year. The interior demolition is complete. There have been very extensive and elaborate structural retrofits that are underway and slated for completion next month. All of the roofs have been cleared of the existing Spanish tile and have been resheathed. And much of the metal stud framing for the apartments within is now complete. Next slide, please. This gives you a sense of some of the structural retrofits, some of the columns and footings that had to be repoured. There was a lot of work on this front. We are slated for completion in late spring 2025. Next slide, please. The last building I'll report out on is building, one more slide, sorry, is building 158. Building 158 is the sister building to 156, 157. It's also an adaptive reuse. It's the third wing of this hospital complex consisting of 49 apartment homes. We began construction and closed late last year. Similar to building 156, 57, other than the experience of homelessness, there are no specific veteran set-asides. This property will support upwards of 5.5 case managers. Services will largely mirror those described earlier. As mentioned, we closed in December of last year, pulled permits, and broke ground. Next slide, please. The demolition interior is well underway, and we expect to reach completion in the next couple of months. All of the interior abatement is also complete, and we have all necessary clearances in hand. And with this building, we are slated for completion in the summer of 2025. Next slide, please. This gives one last picture from the exterior. Just of note, we will be installing a gable roof on this building so it matches the two sister buildings. Right now, you see building 158 has a flat roof. So these three will look very consistent from an exterior perspective once they're complete. And I'm going to pause on my presentation now and turn it over to our next presenter. You can move forward on the next slide, please. There you go. I think this is Tyler at TSA. I don't know if he's still muted.
Okay, it says from our end that Tyler was unmuted.
Hello, can you hear me?
We can hear you.
All right. Hi, everyone. I think it's now working. I think my technical deficiencies here have been resolved. Hi, Tyler Monroe here, Thomas Saffron Associates. I'm the Senior Vice President of Development, another member of the Principal Developer team, here to report out on a couple of our buildings' progress as well. As Brian mentioned about his buildings, building 402 is also under construction, immediately adjacent to buildings 156, 157, and 158. We have 120 units of housing there, 118 for veterans, and then 2 for managers. Our on-site staff, as similar to what Brian mentioned, we started our construction in January of 2023, and we're a little over halfway through construction with a projected completion of late this year, early next year. What makes this project a bit unique, while many of the ones that we've done to date are either new construction ground up or adaptive reuse of historic buildings, this project is our first modular construction project. So all of the units were actually manufactured off-site and delivered to the project as an effort to experiment with ways to accelerate further housing development for future projects. But all of those modules have been delivered. They are all set, and we'll show you some photos here coming up. Services will include case management, mental, physical health, substance abuse, et cetera, similar as service array provided at all of the other buildings. And we have a similar case management ratio where we project having 5.5 case managers and veteran support specialists here on site. Next slide, please. Here are a few photographs on the top and obviously to the right of the building. Scaffolding is up. Waterproofing is a little bit further along today than it showed in this photo, thank goodness, given today's rain. And then there's a slide on the left of just kind of the finished rendering, kind of a similar stucco to the other buildings that will be here at campus. Next slide, please. I'll hand this off to my colleagues at US Vets to update you on 210.
Actually should be Lori Allgood. I'm not sure she's waiting. Thank you.
Hi. Can you hear me? Great.
We can hear you.
Great, thank you. This is Lori Alga with US Vets. I'm Vice President of Housing Development, and I'm pleased to introduce our Building 210 today. Building 210 is an adaptive reuse. There are 38 units including one manager's unit. The population for this development will be homeless women veteran preference and all veterans. Construction start date will be May of 2024 and construction finish December 2025. Services in this building will include VASH case management, mental and health substance abuse, as well as women veterans programming, child services partnership, support for women vets on point coordinator, and family program staff. Service staffing includes 1 full-time director of behavioral health, half-time veteran service coordinator, 1 full-time VASH clinical supervisor, and 1.5 HUD VASH case managers. Thank you.
Next slide, please. Tyler, again, I'll give a brief update on where we are on building 408. I know that this building from our prior conversations or the prior conversations earlier today, that it's been the subject of a lot of conversation. TSA and the principal developer are in preliminary planning on 408, starting with some initial concept designs and just basic due diligence in alignment with the VA and OAEM and GLA's parcel release schedule. Right now, we anticipate this being approximately 80 units of housing for homeless veterans with a construction start sometime next year. As I mentioned, we're just starting with conceptual design. That is complete, and then schematic design actually isn't quite underway, but we contemplate it being underway in a few weeks' time. Due diligence, including surveys, soils, utility infrastructure evaluation, and other due diligence is underway, just to make ready for future planning. As you can see, you have a section of kind of the initial concept design that does include robust ground floor amenity space with housing above, facing onto Pershing with parking tucked behind. And then you can see below a site plan of housing that's the 2nd, 3rd, and 4th levels. The ground floor is almost exclusively amenity space to be determined, to be programmed to provide various services and amenities that are necessary to create a thriving community here, provide things for people to do here on campus. There are obviously many residents that are here and people living, working, and so providing opportunities for things to be done there. Next slide, please. Here's my colleagues at US Vets.
If I could move the call. Hi, everybody. I am Tess Bako. I am both a representative of the Veterans Collective and US Vets. I am a Marine Corps veteran, physically disabled, experienced military sexual trauma, and also lost my husband while he was on active duty to suicide. So I'm a military widow as well. It's been my extreme honor and deep pleasure to work in 2 different arenas here at the West Los Angeles State Campus.
I, up until this point, have held two roles. So one of those was building the services community. So building the piece of, I don't like to call it a project, the community, where we look at services not only within the buildings, but also services for those veterans who are in other programs on the campus. We haven't really talked too much about it, but there's 1,200 veterans already living on this campus among the different programs, in addition to those who will be arriving with the opening of the new buildings. So as part of this role, I was able to establish US Vets West Los Angeles. As you know, there are VASH contracts in each of the different buildings where staff have been hired to provide VASH case management services to the veterans of the buildings. In addition to that, US Vets, as the lead service provider for the collective, knew just based on experience over 30 years of providing services across the country to veterans that VASH case management was one piece, but also there's that wraparound supportive services that all really helps veterans stay housed, help them stay healthy. So there are now 8 staff on the ground. Originally it was just me, so we hired and also have recently hired a program director who will then become the executive director of US Vets West Los Angeles site. There's one VASH contract that I had the joy of standing up working with SIRS and VASH to accomplish hiring that team. We've also responded to a multi-year VASH RFP, so there are other buildings that will be contracted out for VASH case management. We have applied for that, and we will know when everybody else knows how that goes. Inside the building, I know you all visited. It was really great to get some time with you all to show you around, but there's a slate of events that goes on regularly during the month. There's events, supportive offerings. There's a monthly coffee and conversation. That's the real low key. Let's talk together. And then there's also the community meeting where it's a little more structured, and we also get feedback from the residents about the things that they'd like to see and provide them with outcomes to the issues that they might have raised during the other meeting. In addition, there's a lot of groups and classes, so technology is a big one, especially because that building is 62 and over. There's arts, finance classes. We've done juicing. There's been horseback riding. We've used our 7-person ADA compliant van to be able to transport veterans off the campus, and also have done a variety of different special events. United Talent Agency is one of the sponsors of some of the programming because, as you know, we have to fundraise to be able to provide this full range of programming. And we also had a holiday party with Fox, and we are able, with some of these events, to invite veterans from other UL buildings. So trying to widen that net of the things that are available. Also, there's a temporary services center outside of Building 210. So you just heard about the makeup of Building 210. It is a triple wide trailer that we've already begun to start providing joint programming. Our first class was hopeful for the holidays with the Veteran Family Wellbeing Center, which when I first arrived on this campus 7 years ago, I stood that program up, and it's the only program on the campus specifically for veterans and their families, which is an important component of the community. Also, there's been just coordination across the VA sections and community partner services, including peer support, which is, as you know, huge. Spending time with somebody who's had some of the same experiences, that certification is also really important. And special needs resources for women veterans and different populations that might be in the minority on the campus. Next slide, please. My other role, which I'm fully stepping into now, is the Community Development Director under the Veterans Collective. As part of the Principal Developer Team's community plan, it was always envisioned that there would be a backbone organization, which we chartered. It's a 501c3 nonprofit, and it's based on the principles of collective impact. We go further together, especially with a community of this breadth and depth. It's going to require all hands on deck, working together in coordinated fashion to provide and to support veteran empowerment on the campus. So we're just really working to bridge gaps, bringing veterans, especially VA and macro community partners together. There's a lot of discussion about administration, property management best practices. So we're sharing with each other. Every 2 weeks, I convene a group where we have property managers and services teams meet together. In addition to, there's also a VASH meeting where the VASH providers meet as well. So we're all communicating. We're trying to sharpen the communication. Safety is also a key component. So recently VA held a roundtable about safety. We went through different scenarios. We were able to share what we do in each different building with each other and share resources. As I mentioned, there are joint macro events, trainings, and initiatives. So you can see off to the right, there's a little hopeful for the holidays. We're also going to have an expressive arts class coming up in the services trailer. So again, branching out from the inside of the different UO buildings and serving the wider population, the veterans that live on this campus. There's also continuous feedback loop and communications building. So in the course of my 3 years with TBC and before that, one of the things that I've always loved to do is walk around the campus and talk directly to veterans, right? Fellow veterans asking, hey, what's going on? What's on your mind? And that continues on in my role with TBC. So not only when I came on did I read all of the feedback that was in the Federal Register from the 2 iterations of the draft master plan, but I went around and I collected feedback from the veterans, asking them about community components, and yes, the loneliness, the boredom, the desire for coordinated community. These things are all themes that are repeated continuously. So we're really working, TBC is working to bring the community together and continue to collect that feedback as we look at where we're going as a community. And then finally, the 2024 annual impact report is in progress. There are previous versions of that on the WLABC website. So you can check those out as well to see what our progress has been like. Next slide, please. All right, handing it off to Lainey Kapkin.
Thank you. Lainey Kapkin, US Vets. Very pleased to continue reporting on the Veterans Promise campaign, which, as you know, was our effort to really engage the community in this vision that we all have for the campus. The campaign priorities that are outlined here, they reflect the areas that don't have other funding sources available. So our goal was really to fill in the gaps that were required to bring this campus to life. And we've listed here some of the partners that have joined on. We have much more in the works. For this particular update, I wanted to share a very large gift recently received for the Wadsworth Chapel leadership gift from the Amundsen Foundation, which will help us really begin to move forward with the restoration and repurposing of the chapel and the creation of a spiritual home on the campus. And so we're very, very excited about that. That's what reflects the variance in revenue raised to date in this report from our last report. And we continue onward. Thank you. Next slide, please.
Ryan, this may be back to you.
Yes.
There's a slide entitled, What's to Come in 2024?
Do you have them?
Thank you. I needed to be unmuted. I couldn't unmute myself. Thanks, Rob. Yeah, so just, I think you got a pretty good sense from the prior presentations this afternoon. There's a lot of construction that is underway, more than 500 units by our tally, with 37 more slated to begin when Building 210 closes in a couple of months. So, we're going to be in execution mode, bringing these projects to fruition. So that will command a lot of attention and focus. We're also in the midst of completing our final planning process for the connectivity and mobility improvements that are being funded by the state of California, nearly $20 million of ASIC and IIG funding. So working very closely with the VA on that, and that will bring those improvements to many of the communities that we're developing on the North Campus down to the west side of the campus where we connect into Brentwood. So that is well underway. As Tyler mentioned, we are squarely in pre-development in the phase 2 area of the community, starting with building 408. A lot of fundraising will continue in the year ahead, hoping to make further progress with Wadsworth, as well as a number of the other funds that are part of the Veteran Promise campaign. We're also continuing to advocate with our legislative leaders on elements of the Leasing Act, including the ability to name different areas and buildings that would support some of the fundraising that we're doing. Tess spoke to you about the backbone implementation. This is the Veterans Collective and bringing together the many stakeholders and veteran service organizations on the North Campus, especially as hundreds of additional veterans are moving in. You know, we're home to more than 1,000 veterans today across all of the different facilities and buildings. And then beginning to prepare for the lease up, right? There'll be 380 or so homes being concurrently completed and leased. And so that planning effort will pick up steam here in the months ahead. That, I think, concludes our formal presentation. You can flip to the next slide. And I think we are available for any questions that the board would like to ask of us.
Thanks. That was extremely informative. Jim Zenner, you're the first question.
Yeah. Jim Zenner, yeah, thank you for the presentation. Just wondering, we've had a lot of success with the one team out in the community. Wondering if there's any kind of one team type coordination for everything that's going on with the campus, you know, services and opportunities for veterans, but also public safety. Wondering if there's anything like that.
Hi, so I think that is part of the continued coordination that is going on, not only between the VA sections, but the additional partners that are coming onto the campus. And then, of course, planning. VA planning has been absolutely tremendous in bringing together the different UL holders and BASH insers and the services team. So the current convening that is held every 2 weeks has been kind of the budding of more coordination, increased coordination, because I think everyone certainly sees the need for it.
Anybody from education institutions on there? Any employers on there?
Yeah, so as part of US Vet Services Model, we have a career development initiative. We also do work directly with the VA's employment section. And so I think each of us works within, you know, kind of the scope of our offerings as we continue to try to coordinate, you know, a more full package. So we also pull resources from the outside. We're certainly connected to the LA Veterans Collaborative. I'm the Access and Engagement Working Group Chair there. So when we cannot find a resource, we put together a package of resources, but we cannot find one. We go out and we do outreach into the community to find the best resource to fill it. But yes, employment, education, Brentwood School has been working with the collaborative group here, and then also so has UCLA. And there have been, you know, classes and courses that are offered. There have been some certificate programs that they've been looking at that I know that they've spoken to this body about previously. So the coordination continues.
Yeah, it'd be great to see a list of everybody. And it seems like it's a special invite only. Wondering if it's possible to open it up to the community to invite to see if there's anybody from the community that would like to participate.
I think that's excellent feedback as we continue to coordinate.
Recognize the vice chair.
Lori Sutton. First of all, let me just say to Tess, thank you so much for the tour yesterday and for everything that you're doing. You know, if I had to think of inventing a backbone, you'd be the one that would come to mind. So thanks for all that you're doing. And thanks to everyone on the principal developers team who has briefed this afternoon. This is very exciting. I have three separate questions. I'll just lay them out, and whoever is appropriate to answer, that would be great. One, I know that to this point, the majority of the effort rightly has gone into the housing developments, all that we saw yesterday, and it's so exciting to see the lease ups and talk to the veterans who are involved. And I know there's also attention now that we're paying, the department's paying, and I know the principal development team is paying towards the town center concept. In reading the ULI report, I was very interested in their notion of the commons with the quad, the promenade, parade ground, and then the chapel. And by the way, great news on the fundraising for that chapel. That's very exciting. And my question here is, you know, the ULI team laid out that this town center, to bring this, to animate the town center and the commons, bring it to life, would need a number of different authorities. But my question is, they also pointed out that it could either be incorporated under the existing principal developer EUL authority or be sent out as a separate solicitation. So I would just be interested in any of the principal development team members' comments on what experience the PD team would bring to bear in terms of past developments that would be consistent with the commons and town hall concept. I'll go ahead and put the other two questions out there as well, and then look forward to your responses. Secondly, we had some feedback earlier this afternoon about service dogs and pets for our veterans. And I know we saw yesterday on the tour that there are already certainly service dogs and pets on the campus. The question is, what provision is there for, you know, dog parks or places that are convenient to the buildings for dogs to do their business? That's the second question. Third question, I was very interested in building 210 and seeing, and you mentioned some of the programming that's developing for women veterans. And I wasn't clear whether those 36, 38 units are transitional housing or is that permanent supportive housing? I'd like to get, just to understand that more, as well as to know about any future programming in terms of permanent supportive housing for women veterans with all that is entailed, including potential family members.
Sure.
That's it. Thank you.
Great. Thank you very much. Tyler Monroe here, Tom Saffer and Associates. I'll take question one and then I'll defer to my colleagues on questions 2 and 3. Brian may chime in as well on question 1. I think with respect to the ULI TAP study that was released, we've only just recently received it, much like you all have, and we're still very much digesting the details of it, trying to understand what it presents and how it aligns with what we've previously contemplated. So we don't have a formal response kind of put together yet or thought through as it relates to ULI recommends and what we've previously contemplated. A couple of the major takeaways that we did notice was that the ULI TAP does recommend a mixed use area within what either is Veteran Plaza Town Center or whatever term we want to use for that area. Mixed use, they specifically, note is, housing above ground floor amenity or service space. And that is 100% consistent with what the principal developer has contemplated as part of the community plan and is included in Master Plan 2022. So we agree with the ULI TAP wholeheartedly on the need to do mixed use in that location. And I think a lot of the sketches that they've put together for the Veteran Plaza speak to that. I think there's a lot of alignment in terms of what types of services and amenities ULI TAP suggests, specifically administrative and events, food and nutrition, social and recreation, education, employment, health and wellness, daily amenities and resources, and the like. I think those are very much aligned with what has been contemplated by the principal developer in its community plan and Master Plan 2022 as well. But again, as I mentioned, we're still continuing to evaluate the specifics and get into the details. With respect to I think the real question, which was what experience do we all have? I think there's a variety of experiences, which makes our kind of joint venture unique. Obviously, Villages at Cabrillo is an often cited example that U.S. Vets and Century Housing have worked on. I can also say that with Thomas Saffer and Associates as a developer of affordable housing has done many mixed-use projects throughout Southern California, anything as small as 2,000, 3,000 square feet of ground floor amenity space, non-residential, to 55,000 square feet of ground floor amenity, commercial, service space. In that case, it has a Target, it has a bank, it has a potential lease right now with a medical professional, and food providers, and that's actually located in the city of Inglewood. And there's a variety of examples in between. So I think the combination of the has experience in a variety of creating mixed use spaces that go well beyond just housing alone. But again, go back to what I said in the very beginning, we're still very much digesting the TAP and how it aligns with what we have contemplated.
And I would just, thank you, Tyler. I would just add that many of the abundance of the uses that we've contemplated in this Veterans Plaza or Town Center area, right? These mixed uses on the ground floor of the housing developments, the bulk of these uses are allowable under the Leasing Act. They meet the definition of community-based support services, right? Which is part of the definition of supportive housing, which is what the Leasing Act and the EUL authority under which we've been granted and leased these parcels requires. There obviously are a handful of uses where there is some gray area, and that's, those are the ones that we're working with our elected officials to generate clarity on. But I think it's informative to go back to the original RFQ under which we were selected. There are numerous citations within that RFQ document. The VA engaged us to help build a sense of community. The town center is actually referenced in the RFQ document. So it wasn't just about the housing bricks and sticks. It was about creating a holistic, thriving, supportive community. And that is the spirit of the community plan, which was almost entirely folded into Master Plan 2022. There's, wholesale consistency between those two documents. I think I'll turn it over to Tess and the US Vets team maybe to answer questions 2 and 3 about the service animals in Building 210.
Sure. And just going back to that question about models, we were honored to be asked by Dr. Joshua Brandberger to fly up to San Francisco, look at some of the other models that currently exist. So certainly, Century Villages at Cabrillo has been a starting point, right? So looking at that model, which functions there, but extrapolating from there, even to the intentional communities that Dylan works on. So looking at that model as well in New Orleans, there certainly are other models that exist that we have looked at for best practices. So Building 210, the question about women veteran services, it is permanent supportive housing for women veterans, so it's not transitional. Originally, there was, a plan to have a program. There is a program in existence on the campus, so it's New Directions Oasis for women. But US Vets does operate an advanced program down at Century Villages at Cabrillo. So that is transitional for women veterans and has had a lot of really great success, specifically because it also involves women with children, which a lot of programs leave women with children out. Unfortunately, it can be quite a challenge and very hard for women veterans in need to go in for treatment, especially being a breadwinner or a caregiver. So that's an important piece of it. But yes, Building 210 will have a range of supportive services for women veterans, including advanced. We also have a Women Vets on Point program, which provides specialized women's mental health. I have to be honest, I get my care here. I visit Women's Health pretty regularly, and I've gotten nothing but great care through that clinic here. So we are also coordinating directly with Women's Health, Dr. Batuman's team over there, and trying to bring together what already exists and continue to work from there, not reinvent the wheel. There's so many experts here on this veterans home already existing.
The next question is to Nicole.
Oh, sorry. The service animals. So service animals are allowed in the building. So the services team, the lead service provider, US Vets, we have gone through and made a list of resources for those veterans who have served animals, including food. We have some resources to be able to provide medical care because it can be quite expensive, as you know, veterinary care. So we are able to share those among developer teams and support each other for those residents who do have pets. As far as dog parks, I will defer to the principals of the team to talk a little bit more about, what might be contemplated there.
I think that's helpful feedback. I do know that we have contemplated the connectivity to the dog park up in Brentwood, and some of those amenities. I think let us take that under submission and give some thought to where that type of a use could potentially be located within the confines of the North Campus. I don't know if the VA has separately considered that, but it's good feedback.
Thank you so much.
All right, Nicole.
Thank you. So just a quick note, I used to work for quite some time with veterans, and I'm currently running a nonprofit that builds and provides the services on site supportive housing. So from one supportive housing provider to another. Couple questions. One, I didn't hear anything about security, so I would love to hear what the plans are with either the individual buildings or as community, what the security will be. And then the unit size distribution, if those charts could be, the slides could be updated to include that. It's great that there's a separate building and we're thinking about women and children, but when people move into the buildings, their demographics change. They reunify with children, they fall in love, and LA will still be a very unaffordable place for them to move if they're in a studio. So I would love to hear more about the unit sizes.
Sure.
Tess, if you'd like me, I can maybe initially speak to the security, and anyone else can weigh in, but we acknowledge that that is very important. We have separately established a community association, which is the equivalent of an HOA, or a condominium association. And those CC&Rs are being recorded against every subsequent EUL parcel or leasehold parcel. Those subsequent EULs will eventually pay into the association, and one of the primary expenditures of that association is private security that would supplement above and beyond what LA County Sheriff and or the VA PD is able to provide on site. The association effectively kicks in, I believe, once we reach 300 and I think it's 350 or 380 cumulative homes that are operating on campus. So we're not quite there at that threshold yet, but that is the intention once we reach that threshold.
Further, the principal developer team has agreed to use the same security provider. So Elite Security, which we've already involved in conversations with VA PD. I also want to give a major shout out to the VMET team. So we have Captain Harris in the back with one of his colleagues. And when there have been issues, or if there have been issues, I mean, because they certainly will arise, I think we all recognize that, they have been able to support through just tailored, supportive contact with the veterans, so very empathetic. It's an additional layer of support, especially when there might be something going on in the mental health arena with a veteran. So I just want to thank you guys and your whole team for all of the support. But yes, there's been a lot of coordination around safety and security, especially on the part of VA planning. So letting that charrette, examining everybody's different fire protocols. Principal developer team also created a joint safety white paper, which we've also shared with our colleagues in the other buildings.
Beth Sandor's next question.
All right, and I hear about the unit distribution.
We can look into adding that. So,
okay.
We've received it in previous slides, and it would be great to kind of just restore back. We got so many new board members. If we can get the breakdown of studios, 1 bedrooms, that'd be great.
Sure.
Yeah.
Noted.
That's Sandor. First, I just want to echo just how incredible the collective impact work they're doing here is. Excited to follow that, just a real model. My question, and maybe it's adding on to Nicole's, it could just be part of an inventory that gets updated, is there an inventory of the tenant eligibility criteria and funding sources for each of the projects, both those that are operational, in development and proposed?
Yes, there certainly is some. We do have a list of those and there's also a track.
Great, it'd be great to be able to see that. Thank you.
Our board members are all much smarter than me. It's going to be a challenge to keep up with this crowd. The board gets better and better every cycle. Stephanie Cohen has the next question.
Stephanie Cohen, no question, just a comment. Tess, love seeing you here. Thank you for being here. I would like to request that the rest of the PD team be here in person next time. It's really challenging to have an open dialogue about this process when you're not here physically, and not VA's fault that we have tech issues. This is like just a tech issue. But you know, the sound is in and out. Really would like to request you be here in person. It's a super important thing for us. It's the primary purpose of this board, so I would appreciate that. Thank you.
Sarah Hunter has the next question or comment.
Sarah Hunter. So, you know, as we learned earlier, from Ms. Sander, we're going to have an unprecedented concentration of high acuity veterans on this campus. We now are starting to have some lessons learned from who we have here now. I also understand there was a recommendation put forth recently about putting nurses on site, that was not approved. And my concerns are raised from a symposium we held a couple months ago among developers and supportive housing providers and case management staff around LA County. Because as we learned earlier, due to Proposition HHH, we've been building across this county at an incredible rate, and there's some, you know, challenges along the way. One of them being that LA County uses a intense case management services model that is not, you know, consistent, or it's not the same fidelity as what was tested in Housing First across the country, which uses a sort of assertive care treatment model. What that means is case management is not around 24/7, nor is there access to 24/7 psychiatric care, which is what was tested and shown to work, why Housing First works. So housing developers at our symposium a couple months ago told us that they, quote unquote, felt that they had been left holding the bag in terms of resident issues, because case management is just, you know, a roving model. They're here. They may be called 9 to 5, Monday through Friday, but they're not even on site. So my concerns are about, you know, are we going to have 24/7 supportive services here? Do we need to revisit that recommendation about having nurses on that side of the campus? And I just want to hear from, you know, property management, who've been doing this not only here, but around LA, of what's needed to help support housing stability. Thank you.
Sure. Before property management weighs in on it, I do want to say that a key component here on the campus is the VASH program and the VASH case management, and the strength of the relationships between the VASH case managers and those who may have intensive care needs. Through that relationship, when you're working with veterans within a particular building, you're able to kind of baseline and have an understanding of what a veteran might be experiencing based on your previous experiences with the veteran. So that is a huge piece of the service. So being able to have that personalized care, of course, they're all in different stages of VASH case management based on their clinical needs. They're assessed by the VASH team. And there's a lot of coordination that goes on between the teams of medical providers, HPACT, which is homeless patient care teams, that includes nursing. We have a great relationship with Building 500, so the ER down there, being able to refer down if a veteran's in need of some service or if we have a concern. And again, VMET also has a mental health component to it, where if we need assistance, we're able to reach out to them and they're that additional layer of support. So it has been a combined effort. There are not nurses in building 207, but we do readily have access to VA nursing and the VASH program.
All right, Jim Zenner's up.
I would, if I could
Go
just
ahead,
add real quick, we visited San Francisco and spent the day with Dr. Bamberger, toured a number of permanent supportive housing developments. And in the city and county of San Francisco, it's very common for the county health department to provide that basic nursing service. And we observed the value of that. And I know a number of us have in our buildings provided for stub outs, for sinks, and some of our case management offices to allow for that future functionality. We're not an organization that would provide nursing, but certainly through the VASH case management or the VA Direct, if nurses were made available, I think we would welcome that type of pairing of healthcare and housing, within each building.
And also, I'd be remiss if I didn't mention the state of California Veteran Supportive Services grant, and that is specifically for aging veterans or veterans in need of additional support. US Vets is a recipient of that grant and does use it to support veterans in building 207.
Jim?
Yeah, Jim Zenner. Just thinking about the significance of the CWT program and hearing from the gentleman who was the veteran from public comment, who was saying that he's having trouble getting connected to some kind of meaningful work or something to do. And then hearing from Mr. Reynolds about the lack of access with CWT. Appreciate Sally kind of making that connection and seeing what we can do there. The reason why it's so significant, if you don't know about the CWT program, it's compensated work therapy. And when I worked at the VA, a lot of our peer support specialists that can promote up to a GS9, which is a pretty decent wage, a lot of them came in through the CWT program. And a lot of our veterans are a great fit for the CWT program that are getting housed on the campus. CWT is part of, the employment side of it is part of the treatment team. So it's different than CDI and some of the employment groups that Tess was mentioning. I think it's very, very significant on this campus, taking the tour of the kitchen. Rob was mentioning, looking to bring some CWT veterans to work the kitchen. There's going to be a lot of work on this campus, and we can't afford to not have that program connected to our vets in housing. I would suggest that we look at, as a board, CWT utilization throughout the different units on campus as we move forward. Also, it'd be nice, is there a survey that's publicly available surveying the 233-ish veterans that are housed on the campus around what they want as far as amenities, and is it possible to do some kind of connectedness scale, like how connected our veterans are feeling to the community as they're getting housed on the campus? That might be something that we might want to look into as well. And then wondering what the impact has been on VAPD. I don't know if anybody has the data in the room, but the impact on VAPD since the 205 and 208 opened, numbers of calls, things like that.
Hi, Jim. Thanks for the question. Rob Merchant. We generally see about a 20% spike in calls for service with the opening of each new building to our VA Police Department.
Jim, we couldn't agree more about the need to survey. We've done a lot of outreach to date. We're in the process of developing a more specific survey instrument that is focused on the residents at the campus today. We know the VA is also working on an instrument. We're trying to marry these up to ensure that all of our questions are folded in, and we have one kind of global instrument that goes out to the veteran community, so we're not confusing residents with multiple instruments. But that is important data that will help to inform the types of uses that we fold into some of the flexible support and amenity space in the phase 2 area.
I think that's Tyler, right?
That's Brian that was speaking.
Oh, thanks, Brian. Yeah, that's great. I think part of the problem is we're not seeing the results of these surveys. We're not At least I'm not. I don't know if, Chair, if you've seen them or any of the board members that have been here for a while have seen anything in the way of surveys and kind of what's coming from feedback from the residents. And it's really hard for us to advise the VA on recommendations if we're not getting access to that data.
So I think duly noted. Last question, Nicole.
It's a good one. Just one last note on security, and this is actually more of a comment than a question. Women, especially who have experienced domestic violence, and I'm sure MST, and justice-involved veterans, and have an adverse reaction to uniformed police as security. So just something to think about. If you haven't, you probably have already, but if you haven't, think about an alternative model as well, in addition to regular police, to provide security for the buildings.
And again, I'll point back to VMet. So one of the things that the captain has talked about is a community policing model that isn't imposing, and it feels more like an extension of a caring community than it does uniformed police officers. So there definitely is that effort afoot. And then also, one other piece is the peer support, right? So policing their own, which is a model, part of the, certainly the US Vets model, but the collective has adopted it as well. So helping veterans be able to support other veterans, resident council work, and looking at policing in that way as well has been very important.
All right, Keith Harris, that's the absolute last comment.
Super fast. Well, somewhat fast. Comment about employment. There is no question it's an incredibly important tool in terms of homelessness prevention, quality of life, all those things. First is, I think we forget how, on average, old the veterans we are serving in Hudbash are. There are a very large number of retired veterans. There are disabled veterans. The solutions are going to need to be really nuanced, is the main point I want to make. There's also a chunk that is, I think, larger than any of us on the provider side would want it to be, who are not interested in employment, at least now. And that puts a lot of onus on the service providers and case managers and their peers to help generate more of an incentive and an interest in that. So it's not as easy as just creating enough CWT positions or other jobs in the new kitchen or doing construction on the buildings, which struck me when I heard it as a great idea. There's a lot of work to do in terms of incentivizing and targeting those to the needs and abilities both for the veterans.
Yeah, and it's an all hands on deck. I mean, Jim and the VPAN, the Veteran Care Access Network that he stood up, and then also the LA Veterans Collaborative and the one team effort, it all figures prominently into being able to coordinate together. Every month there is the LA Veterans Collaborative meeting where you've got people who will come in and say, I need to employ a veteran in the chat, and then somebody will respond back, I have a job. So it's creating that type of system and continuing again to sharpen that on again.
So Tess and all the rest of the PD team, super appreciative for the presentation. I really do want to underscore the value of, because we have so many new board members, in the next few briefings, let's go back to that routine of describing not just the unit characteristics, but also the funding characteristics. What AMI thresholds, what for chronic homelessness, for serious mental illness, because we really need to get everyone back to that same baseline. Thank you so much.
Noted. Thank you.
Okay, why don't we take a quick 5-minute break? And I will promise you, I think, a very uplifting final session, very encouraging final session. So look forward to it. Yeah.
Please, here's the slide. Let's see the next slide. Dash sheets. Push the microphones. Slide seal. Slide seal.
Welcome back, everyone. Can you hear me well? Okay, great. How's that? Okay. Thank you so much. Oh, thank you so much for inviting us here today. I'm Bruce Kagan. I'm a staff member here in psychiatry at the VA. I began in 1982. Don't do the math, I know it. I was a prodigy. I came at age 12. I did my internship here, my residency in psychiatry. I was then a fellow, career development awardee, the first chief of the inpatient PTSD unit here in Building 210, and then the outpatient, the director of the outpatient PTSD clinic in Building 256. Now I reside in Building 401, where I co-direct what's now called TRS, Trauma Recovery Services. But you'll excuse me if I continue to refer to it as PTSD. It's a hard habit to break. And I'm just thrilled about all the work that's going on the north side of campus, or the Brentwood side, as we used to call it. I really applaud all of you for your contributions. I am here today on behalf of Operation Men, and before I tell you about the program, I want to give you a little background of how it developed. And I also want to send the regards of our executive director, Dr. Jo Sornberger, who can't be with us. She's in Jacksonville meeting with our 3 partners in the Warrior Care Network, Mass General Hospital, Emory in Atlanta, and Rush University in Chicago. And you may be wondering why UCLA has a PTSD program for veterans. And that was the question that I asked myself 8 years ago when Dr. Sornberger and others invited me to join Operation Men. And in 2007, Operation Men began as a surgical program. It was really the brainchild of Ronald Katz, who's a longtime UCLA fan and donor and patient as well. And he collaborated with UCLA leadership to identify surgeons and surgical programs that couldn't be accessed through normal VA channels. And he arranged for UCLA to deliver those surgical services. So those were plastic surgeons, reconstructive surgeons, orthopedic surgeons, and others for some of the really badly damaged and afflicted veterans. You know, got some care at the VA, but couldn't get the really highly specialized care. Actually, Southern California and UCLA have an abundance of it. It took the surgeons about that length of time, about 7 years, to figure out that those physically injured patients actually had a lot of psychological needs as well. And that's how Operation Men began as a surgical program and then expanded dramatically in 2015 and 16 to become an intensive treatment program for PTSD. And we were very fortunate to join with our partners in the Warrior Care Network and to receive support from the Wounded Warrior Project. And that's where our director, Dr. Sornberger, is right now, meeting with our partners and our funders. And that experiment has really blossomed beautifully. And so I'm going to try to tell you briefly a little about what we've done. And then my colleagues are going to take over and explain how the VA partners with UCLA in this endeavor. I'm not a stranger to that, having been a slave to the bureaucracies of the VA and UCLA for the last 41 years. But I know that collaboration is possible and it's actually very fruitful. So I hope by the time we finish, you'll agree with that. Okay. Next slide, please. So Dr. Sornberger will be with us today. Here are Katie Mann and Katya Merchant, who are very involved in the VA-UCLA liaison, and also Ben Johnson from our development department. Not with us today is Dr. Walter Dunn, who is a former Marine and also directs our interventional psychiatry program here at the VA. And I'm also proud to say is one of my former resident trainees here. And is my associate medical director at Operation Med. So we handle most of the psychiatry. Next slide, please. So Operation Mend, in its surgical form, initially, devoted itself to post 9/11 veterans. Now, as somebody who grew up here treating mostly Vietnam and Korea veterans, I bristled a little at that at first, but I came to see it as an important and a population truly in need of our services. We also have had some active duty service members participate in our program. And I think one of the keys that everyone here I think knows well, but UCLA took a little more time to discover, is that it's important to make these kind of services available and acceptable. That we try to remove the shame, remove the stigma, remove difficulty, the obstacles in people's treatment. Next slide. One of the hallmarks of Operation Mend, which I thought was brilliant when we started, it wasn't my idea, but I really liked it, is to embrace the family members of our veterans. And the surgical program really did that in a beautiful format that inspired us when we started doing PTSD treatment to carry that over. And we're the only one of the Warrior Care Network that really involves our family members as full partners, full participants in the program. So they get almost all the services that the veterans get, with the exception of the specialized one-on-one PTSD therapy. But they get all the other adjunctive modalities. We focus on individualized care. We have many veterans who partake in multiple programs, surgical program, brain health program, and the PTSD intensive program. So we have different tracks, but our veterans are welcome to use whatever's most appropriate for their needs. We provide housing at Tiverton next to the UCLA campus. We provide air and ground transportation. We provide patient escorts. And think that a part of what facilitates our treatment is really the connection that we make to each veteran, that each one develops individual relationships with the staff. Next slide. So we have 4 tracks currently. We decided to let the surgeons continue with us.
they're really a wonderful bunch, and it's probably one of the only settings that I've ever been in where surgeons, neurologists, psychiatrists, nurses, and social workers all talk to each other. But that has been a wonderful experience. We have our neurologists, Chris Giza and Kevin Bickart, have developed what they call a brain health program, which is now similar to our PTSD track, but it's a track for people with suspected brain injuries or cognitive issues. And it's, even though it's not really intended as treatment per se, it's getting quite beautiful results, which I'll share with you in a moment. The heart of our program has been the PTSD track for veterans with post-traumatic stress disorder. Most of our veterans have been treated elsewhere, either at the VA or in the private sector. Some of our veterans come from areas with no access to treatment. I've learned the names of a number of very small towns in the United States that I didn't know existed. And one of our big challenges, which we'll hear about later, is connecting them to care for ongoing follow-up and treatment. Because even though what we do is very helpful for our veterans, it's not enough. PTSD is an ongoing chronic illness that requires regular follow-up and treatment. Next slide, please. Okay, I'm not really qualified to tell you much about the specialty surgical care. And unfortunately, we don't have some of the before and after pictures, but some of our veterans have really been maimed and disfigured, and our surgeons, in my view, are just brilliant. They're able to restore appearance, but they're also able to restore function. Functioning of the thumb is very important, things like that in your hand. And so we have hand surgeons, we have facial surgeons, plastic surgeons who collaborate. Some of our veterans have had more than 60 surgeries at UCLA. And as you can imagine, that takes an enormous psychological toll on the veterans and on their families. Okay. Next slide, please. So, as I said, we're very fortunate to be part of the Warrior Care Network. The 4 academic medical centers and programs share information. We pool our data. We all have slight differences in the way our programs operate and the focus, and we learn from each other. We have regular quarterly meetings. We share data, we share best practices, we share techniques. And we even share patients sometimes, sending a veteran who's more suited for one program or to another. That's been a wonderful resource. Next slide. Okay, so every veteran who comes to us gets a 5-day assessment. It's a diagnostic and educational program that the neurologists, psychiatrists, and sometimes the pain medicine specialists now join us in creating a complete assessment so that we can address all the needs of the veterans. Pain management has become a vital part of our program, even though we're considered psychiatry. So many of our veterans have this as comorbidity, that it's not just trauma, but they really have pain issues that, debilitate them on a daily basis. So we had to incorporate that just because it's that important and that common. The brain ITP, which is the program the neurologist devised for us, has also been extraordinarily successful, even though that's quite new. We share a lot of the common techniques, including group therapy, art therapy, equine therapy. Don't ask me about that one, I can't explain it. But these therapies that are complements to the intensive one-on-one treatment that's really the core PTSD treatment. Next slide, please. Okay, I think I've really covered this, that we welcome the caregivers as full-on participants. I will also show you in a minute some of the data we have from our caregivers who really respond to being. Next slide, please. Okay, this is my favorite slide, the one I've been waiting for. And I'm sorry it's so small. These are our outcomes. And the leftmost bar are symptom ratings of patients. And if you look in the upper left corner, PTSD symptoms, which are very high in our veterans when they come in. And you can see that after just 2 weeks, our veterans experience about a 50% decrease in symptoms. And you'd say, oh, 50%, that's not so great, right? There's still 50% symptomatic. But in the PTSD world where I live, these are great results. Okay, it's very hard. PTSD is one of the hardest disorders to treat. We do better than this in depression in general, but PTSD has been particularly difficult to wrangle. And so these are really good numbers. And what we've done, and our partners as well, is we've shortened the treatment time. So when I ran the inpatient unit here in the 1990s, we had veterans come for 3 months. Now our program is 2 weeks. In the outpatient department in 401, our program is 12 weeks, okay, once a week. But our completion rate is only 50%. At Operation Men, our completion rate is 95%. So making it shorter makes it easier. Makes it easier to complete, makes it easier to succeed. The other thing that I want you to take away from this slide is notice that those improvements, that we get at 2 weeks, the yellow bars, continue out to 12 months. And we're 7 years old now, so we're still working on 2-year and 3-year follow-up data. But this to me was the most exciting result because durability of treatment is quite difficult because when you have PTSD, there are lots of triggers in your environment. Crowds can be a trigger, fireworks, cars backfiring, sirens, even garbage cans, because garbage cans can hold IEDs. So daily life is filled with triggers and patients frequently relapse. See this level of symptom maintenance is really quite good. So we're very excited about that, and our partners are very excited about that. Okay, I am going to turn it over now to Katie and Katya to tell you about how the VA and UCLA work together.
Hello, we could go to the next slide, please. So working together, my name is Katie. I am the case management supervisor at UCLA Operation Mend, and I collaborate here with Katya. She is the VA liaison. She works here at the West LA VA, and really we collaborate together so that at Operation Mend, we really see ourselves as an extension of our warriors' home care team, and usually that is the VA for the majority of that. So having somebody to collaborate with, one, makes my job exponentially easier, and two, just makes it a smoother transition for our warriors as well as they go back and forth between treatment here with us at UCLA and with their home VAs. And as you can see, a lot of our warriors, they come from all over the country. So we're working with many VAs all over the country. And so CAPIA kind of oversees the military treatment referrals that us as the case management team are helping place following care here with us at UCLA. We are try to be as transparent as possible with our warriors and really want to maintain that contact. So oftentimes we might have a warrior return home, everything's been great, say like 6 months later, stuff's not going as great. They can reach out, we can connect, we can help connect them as well with the support from the VA liaison.
Hello, my name is Kathia Merchant. I am a VA employee, and we can go to the next slide, please. So some of my duties as a VA liaison working with UCLA Operation Mend and also the Wounded Warrior Care Network is that the most important thing is initially to get veterans into the Operation Mend program is they need medical records. So that was something that was a huge delay prior to me coming on board with Operation Mend. They directly give me the VA ROIs, and then I can provide the medical records that pertain to whatever treatment program that they are participating in. I also participate in the interdisciplinary teams. I meet with case management. I meet with, psychiatry and the treatment programs, and we discuss veterans and see how best we can provide our services. And we, like Katie said, we collaborate together. When the veteran comes into the program, participates, it is a 2-week program at Operation Mend, but they're going to go back home. And we want them to know that the VA is there to support that treatment that they received at Operation Mend and continue it. So that's when Operation Mend completes the referral. And then I collaborate with the home VAs, the M2VA treatments across the country to make sure that the veterans are continuing to receive treatment at their home VAs. I meet one-on-one with every veteran that is coming through the diagnostics. I meet again with them when they're coming through the interdisciplinary team. We meet jointly because we want to show the veterans that there is a collaboration and that there is, again, the transparency to the veteran. Like, there's no secrets. Sometimes veterans would come and they'd be like, my service connection is going to go down. I'm not going to get caregiver support. That is not what Operation Mend is here for. That is not what I am here for. And so we just want to make sure that we're here to support them and their needs. And so I discussed collaborate daily with Operation Mend. I do go on site on a regular basis, and then I also work with the home VAs. So Katie is the direct contact person for the veteran. She and I work together, and then I will be the direct contact to the VA, to the veterans home VAs. Next slide, please. So VA liaisons and case management meetings, we discussed VA services. Like we said, we've connected veterans with primary care. Some veterans have transitioned from one VA to another VA and they move different states. We assist with that. We go ahead and help them automatically get established into their new VAs with primary care. We connect them to the M2VA teams and case management, mental health. I meet with 90 to 95% of the veterans, and about that amount, we put in referrals for the veterans to go back into their home VAs. And also, the other thing that we facilitate is sending those medical records, if there are recommendations from UCLA, directly to the provider. So if they already have a neurologist at their home VAs, I'm emailing that medical record from UCLA directly to the neurology so that there is that continuity of care and the transition is smooth. When I meet with veterans, I open it up for them. I want them to let me know what's going on with your home VA. Obviously, they went outside of the VA for treatment. Something's going on. And I ask them to let me know, what are their concerns? What are their issues? I'm also, again, very honest with them. And I'm like, I'm not here to resolve all your issues. I cannot do anything about service connections. But other things, we can at least get answers. You know, one of the main things, my primary care is always switching. I get comfortable with one and then they switch. And the first thing that I told the veteran was like, I let them know the VA is an education medical facility. And so a lot of our providers transition out, they're fellows, they're doing their residency, they may go to a different department or a different being. And the veteran's like, I had no idea. Thank you for letting me know this. And so now I can understand why sometimes there is that turnover with providers. And so I do provide them with education with the VA. And sometimes I don't know the answer and I'll be like, I don't know, let me find out for you. Every VA has a different way of handling situations, how to switch primary cares, how to get transportation benefits. So I will go back and talk to the home VAs. We also provide education regarding My Healthy Vet. That is one of the biggest things that Katie and I always recommend is for the veteran to utilize the My Healthy Vet, send secure messages to your providers because that's another issue that is brought up. I never get callbacks. They tell me that I didn't get, my appointment. I wanted to cancel it and they didn't get that message. Utilize My Healthy Vet. It goes directly into your medical records. There is going to be no questions as to whether you tried to contact them or not. And also, I do recommend that they check their My Healthy Vet Sunday night. See if any appointments have come up because that's the other thing. They schedule appointments. Nobody tells me, okay, let's utilize My Healthy Vet to minimize any of those frustrations. Our veterans have PTSD, their fuse is very short. So we try to help them out on utilizing different types of resources. And then also we provide education on how the VA and UCLA work together and collaborate. Next slide, please.
So one of the aspects of Operation Mend is we have our Buddy Family program. This kind of came out of inception of the program back in 2007 and really is an extra layer of support to our warriors when they do come to Los Angeles. As we stated, many of them, I would say probably over 80% are coming from outside of California. So coming to Los Angeles, a really big city, as Dr. Kagan mentioned, they're coming from very small towns. And just having that level of support during their treatments. And it's non-clinical, so more social outside of the walls of our clinic spaces or their hotel room. We, try to link them up with people who have similar interests, making certain connections. And really, they do become kind of lifelong. A lot of our early patients are still very connected to their buddy families that they initially came out here, even though they're not as connected with our program because they've received the care, they're now receiving their care back home, but they continue to stay in contact with these families for that level of support and engagement. Also during, our intensive treatment programs, it's a great way for them to get out and practice the skills that they're learning, engaging in activities, just conversations, being able to socialize, not isolate. So really, it's such an amazing extra to our program that's completely optional though. So, of course, some people don't like to meet new people and can feel awkward in those situations, but we've seen a lot of great success with people participating and kind of making those connections. And especially when we have people who come back multiple times to Operation Mend. As Dr. Kagan mentioned, surgeries, we've had people come back for 10, 20 surgeries over the past, 15, 16 years. And it's just a familiar face that they get to see each time that they come to Los Angeles. Okay, next slide. I think this is where Dr. Kagan comes back.
Thank you. Okay, I will be very brief here. So what does the future hold for Operation Men? And Dr. Dunn has been particularly engaged in new interventional therapies. TMS, transcranial magnetic stimulation, is one. Adjunctive use of ketamine to facilitate psychotherapy is a second. A third, which we aren't able to do yet because it is not approved, is the use of psychedelic agents to facilitate one-on-one psychotherapy. And the leading candidate for that is MDMA, which is known in the drug world as ecstasy, but turns out to have properties that seem to facilitate trust and also seem to facilitate patients being able to approach their trauma. And as someone who's worked with these patients for a long time, getting people to talk about these things is hard because it's painful. And so the pain that the therapy creates seems to be ameliorated to a certain degree by these agents. So we're very, very excited about that. And we have proposals in process, and hopefully we'll be able to start on those soon. And so we're hoping that those will expand our ability to get really, better symptom relief and longer lasting symptoms. I think there's one more slide, please. Okay, so the other one that we actually have in progress treatment is called stellate ganglion block. Now, it's not something you want to do at home because it involves the insertion of a needle into your spinal cord in the neck. But the anesthesiologists and pain management specialists who do this are very skilled at it, and they've been using it for pain for many years. But some of them noticed that some of their chronic pain patients who had PTSD seem to have a corresponding improvement in their PTSD. So we've started doing that in collaboration with one of the pain management specialists at UCLA. And we don't have really presentable results at this point, but we're very excited about it. And we think this might be a leading edge therapy. Thank you very much for your attention. I know it's been a long day for all of you, and we really appreciate your inviting us. Thank you. And we'll take questions if anyone wants.
You've got a bunch of physicians here. You may not know that, but you're about to find out. Patricia being the first.
Oh, my question is about that part, actually. So, hello, Patricia Wajawaku. I'm actually an anesthesiologist at UCLA. So ketamine is near and dear to my heart. But just a quick question about the selection of the service members that go into this program. Is it just anyone who's wounded in combat? And I wanted to understand that. And then my second question is about the funding sources for the program.
Okay, so anyone who meets our criteria in terms of PTSD symptoms or traumatic brain injury symptoms can participate in the program, in the psychological health programs. We have some other patients who come in either for chronic pain or for surgical treatment. And the funding is, Mr. Katz assembled a group of private donors that was initially funding the surgical program, and UCLA provided in-kind funding for operating room time and things like that. PTSD intensive treatment program is funded by the Wounded Warrior Project. And we just got renewed for another 3 years.
Lori Sutton?
Another question. Oh, no, I was just gonna, I guess, follow on with that, just to make sure I understand. So in terms of the service members who are initiated or enrolled into the program, so whether it be PTSD or a surgical injury that required a surgical intervention that happens in the line of combat, any of those service members are eligible for this program? Is that correct?
That's right. And we also have some service members who've experienced trauma not in combat. They're in training exercises or through some kind of assault or sexual assault, things like that are now included.
And how do you all go about identifying and enrolling them? So is there some sort of repository where that information is held and then you all just pull them into the program, or how is that being done?
A lot of our referrals come through the Wounded Warrior Project or from our partners in the Warrior Care Network.
I'll warn you, General Sutton was an Army psychiatrist.
Dr. Kagan, it's great to have you and your entire team here. I'm really thrilled to hear about the evolution, the ongoing development of this program. Back in the dark ages, when I was still in uniform, in 2007, 2008, Dr. David Hobda invited a group of us out to UCLA, and we were briefed on the very early inception of Operation Mend, as well as we had a chance to tour the brain lab and all kinds of things, as we were really in the early stages of conceptualizing what would become the National Intrepid Center of Excellence. So UCLA, you and your team, your legacy stretches far and deep. So thank you for all you continue to do. And it's no surprise that the psychological health needs and the trauma needs of PTSD came to the fore, and I'm thrilled to hear about what you're doing. Two quick questions for you. One is, I didn't see anything about sleep. And you mentioned the physical pain. What are you seeing in your warriors who come with PTSD with respect to sleep disruption?
So over 95% of our warriors have a sleep disturbance of some kind. What's astonishing to me is that I don't have the number because we haven't looked at that part of the data, but it's well over 50% actually have obstructive sleep apnea. And there is a connection clearly between sleep apnea and PTSD, but it's a mystery as far as I can see from the literature. There's only a handful of papers on it. We try very much to get them sleep evaluations, sleep studies if necessary, and get them fitted with the right CPAP, because that, if you're an anxious person, putting all that equipment on as you go to sleep is not fun. So we work with them, and I'd like to have a sleep specialist on our staff. I haven't convinced anyone yet, but I'm hoping.
Good luck with that. That sounds great. Second question is, given the outcomes that you're experiencing with your PTSD, the intensive program, what level or what plans do you have, or maybe you're already doing it, in terms of collaborating with the VA treatment team that is working with other eras of veterans who are experiencing PTSD? Are there things that you're able to transfer in terms of best practices or things that you're doing that might be of help to other eras of veterans?
Yes, I mean, I think one of the areas that we're most excited about is that so the one-on-one therapy that we use to treat PTSD, it's an individualized therapy, is called CPT, cognitive processing therapy. And that's been around more than 20 years, and it's been kind of the gold standard in it. But it's usually done over 12 weeks. And there's some papers on doing it in 6 weeks. We go twice a week. We've done it in 2 weeks. where people get a session every single day. And when they first proposed this to me, I said, no way, patients are going to flip out. It's going to be too intense. And I was wrong. You can do it. And I think the secret sauce is the intensity of the relationship you build with them. So you're building with a program. And this I think we learned from NICO, which is if you have a staff that's really involved in each individual veteran and trying to make a relationship with them, and you have several of these visits each day, form a very strong bond. I think that's what really facilitates the rapidity of the treatment.
Bravo to all of you. Thank you so much.
Hi. Hi, Lieutenant.
Here we go. Hi, Dylan Tat from New Orleans, a brand new board member. Thanks for being here. I just want to call out one distinction. I think this is still true about the Warrior Care Network. To be eligible, you have to be a post 9/11 veteran. I think that's still true, right? Yeah. Okay. I'm also a student at the California Institute of Integral Studies. I'm in the psychedelic therapy program, and I was curious if you could expound more on your funding proposals for the MDMA study. Are you having conversations with Warrior Project about this? That's exciting. And if you could say kind of where California is on rescheduling things.
Okay, so we are involved in discussions with Wounded Warrior Project on funding this. We also are applying through the VA system to study MDMA. That's actually a study that will go on here, but may include some Operation medications. And one of my other colleagues, Dr. Mark Barad here at the VA, and I are applying for funding to study DMT, which is another psychedelic that's much shorter acting. And I think might be a more practical way to deliver this. You know, MDMA, it's a 6 or 8 hour session. And it's hard to find therapists to do that. So I think a shorter acting one might provide as good a quality experience, but much shorter.
And where is California right now on rescheduling?
Well, as I understand it, the rescheduling has to come through the federal government. So, I mean,
I didn't know if they were jumping ahead or not.
Yeah, I mean, you know, California can do things like decriminalizing these substances, and making it, you know, not a crime here, but they're still Schedule I substances, so they have no valid medical use. And you know, MAPS was really the pioneer in thinking that some of these substances might have medical uses. That was just very farsighted on their part.
Thank you. Sam Holmes.
Sam Holmes. Thank you so much for the presentation. I'm glad Dylan asked or clarified the population you're serving. So when we think about barriers to care for veterans with PTSD, you touched on one of the primary ones, Doctor, just the fact that the implementation of a treatment plan oftentimes is drug out over 16 weeks, you know, and the ability for somebody to complete care, especially VA, is really difficult. And you mentioned the 50% completion. It also strikes me that, you know, we have, we're here advising VA on the development of a campus for veterans with other complex traumas, some of them combat-related traumas, but most of them not post 9/11 veterans, but also located right across the highway from UCLA and from your clinical services. Can you just confirm, and I do believe this to be true, that the restriction on serving post 9/11 is from your participation in the Warrior Care Network, and that's being the primary funding for your PTSD intensive services?
I believe that's the case, because that was the case from the time I joined.
And just with the capacity that you have as a program, have you explored potentially opening up those services with new funding perhaps for the veterans that are with complex traumas here on the campus? 'Cause I think that can be a really good benefit for those who may not want to go into inpatient services, and for those that have had some potentially troubling experiences like those veterans you serve now in traditional VA medical care.
Yes, I'm particularly interested in that because I learned everything I know from Vietnam veterans. Those are my peeps, but I'm not the lead on negotiations that go on with the Warrior Care Network and Wounded Warrior Project on personal injuries, but I certainly put my 2 cents in about trying to expand because the striking thing, one of the striking things about PTSD is that it is a chronic disease. And if you survey Vietnam vets now in their 60s and 70s, the rates are very high, 15, 20%, have it 50 years after the end of the war. It's staggering.
Thank you, Doctor, and I appreciate that perspective. You know, I hate saying these words. It strikes me that oftentimes this distinction between post 9/11, pre 9/11, can be coded for things like the deserving, all volunteer force versus the pre 9/11 force that may not be as deserving in some people's minds. It also strikes me that restrictions on post 9/11, oftentimes, those services are, those resources for those veterans, because of that quote unquote potential, deserving all volunteer force, may be more accessible. So there's a health equity, I think, perspective, I think what you touched on exactly, for those veterans who've been living with these complex traumas for a very long time, and especially with the experience of homelessness, as you no doubt know, exacerbate and create comorbid, mental health issues on top of that. So I'm glad that you're exploring that, and I'd love to hear any updates if you're able to get past that barrier with your current model.
Absolutely.
Patricia?
Patricia Wajwaku again. So this is a follow-up to what you were saying about the number of veterans that are struggling with with OSA. And of course, I would imagine having difficulty using a CPAP, as you mentioned. So are you all aware of the Inspire device? And is that something that Operation Mend is now funding within within this cohort? And for people who don't know what Inspire is, so essentially it's an implantable device that eliminates the need for a person with OSA, sleep apnea, to have to wear a mask. So it's an implantable device that you turn on when you're asleep, and it essentially moves the tongue from the back of the airway so that the person can breathe, right? So and the data is captured within they have a whole system where that data is captured, and they're able to assess the person's sleep, quality of sleep, et cetera, and how much that's being interrupted. So I would imagine that's something that would be beneficial in this population, and then also would allow for further research on how maybe improved sleep will benefit this population, especially if they're not using the CPAP.
Yes, I think the Inspire is very exciting and interesting. And I know Dr. Dunn has had some conversations with them about, piloting that in our population. So I'm hopeful that'll happen.
I want to thank you for the presentation, and I want to encourage all the board members who have not done so to look at the website. for Operation Men. It's really an extraordinary organization, and I think their outcomes are extraordinary. And as a bit of historical perspective, about 2 years ago, the board really audited all of the performance of the leaseholders on this campus. So it included UCLA because UCLA has the baseball diamond. And I have to tell you, we didn't hear nearly enough about Operation Men. And I think it was because UCLA felt like the way that it would explain to this board its contributions was to say, specific to this campus, what are we doing? In other words, we have for example, a legal services clinic for veterans, and here's how we help them out. And I really think that this is an example of a partnership between two very big and powerful organizations that's not only terrific right now, but can really be taken even further. So I would suggest that over time, this board get periodic briefings from you on the exact types of work you're doing in each of these areas, because I think it's perhaps the best example we have on the campus of collaboration between a leaseholder and an agency. So thank you again.
Thank you.
If I may, real quick, thank you for inviting us. My name is Ben Johnson. I am the Director of Development for Operation Mend. I've had the pleasure of working at UCLA for over 10 years now. Most recently in this role with Operation Mend for the last 6 months. So while we're on the note of updates, I do have a newly refined donor kit, which is outward facing for all of our constituents, both donors, prospects, board members, you name it. So if I may, I'd be happy to pass these around. We're a little short-handed today, if that's okay. So if there's someone next to you, my business cards are in here. We're getting literally a new set printed this week of 500 plus, as we're embarking on an ambitious 3-year campaign for leadership gifts for Operation Mend to raise over $15 million. So I'm happy to pass these out. And if that's okay, I'll start over here and pass them to your left, please. Thank you.
Thank you. Okay, so we are going to wrap up for the day. Before I make a couple remarks, and before General Sutton makes a couple remarks, I know Eugene wants to cover a few administrative details.
Yeah, just a couple of administrative details. As you all know, we have a monthly VCOEB GLA information exchange. It's usually normally the second Tuesday of every month. And I'm sorry, the first Tuesday of every month. That's going to be canceled for the 6th of February. That particular meeting will be canceled. I guess Rob's going to pass out, or we'll email out a suspense with your subcommittee selection, so we can start standing up those subcommittees as he talked about earlier. Everyone who traveled, I ask you to get your receipts in so we can get the travel voucher process as soon as possible. You guys, if you haven't met Joe Friddle, he's back here in the back. He's the one who got you here, and he's the one who's going to help you get your travel documentation squared away as well. Other than that, Rob, you want to talk about the projected next meeting and any final comments?
So traditionally, the board has met 4 times a year, 2 days apiece. And I became convinced that even though we all bring a lot of energy to this, that was a lot of time to ask. And so I'm going to, as chairman, reduce the number of in-person meetings we have for the time being to 3 meetings a year, 2 days in person. And if we're able to make extraordinary progress, we might even reduce that further. But my ask is going to be that everyone show up for these reduced number of days and show up ready. I think we might also do or reserve the ability to do half-day or one-day meetings by video. We did it during COVID, and I think sometimes it's a great way to address an issue that's percolating up and that we want to give advice to the agency and to the executive leadership on. So I think we ought to be open to that possibility as well. Right now, we're looking at the next meeting being the April-May timeframe. Very sensitive to the fact that once summer comes on, a lot of people have travel plans, and for those of us with kids, it becomes one of our big times of the year to catch up with our children and spend a lot of time with them. Anything else administrative? Okay, so I want to share with the group what I would call my big three, which are what I'm going to suggest are agendas for work for our committee. Each of you is going to have the opportunity to come up with your own, but I want to share with you mine that I think are good aiming points for us. I've shared them with the VA's leadership, and they haven't told me I'm crazy yet. So now I'm going to share them with you. The first is this voucher utilization issue. You heard from the two housing authorities today how low voucher utilization is in LA on these HUD-VASH vouchers. So it's low on an absolute basis relative or compared to regular Section 8 housing. And it's a lot of vouchers. And I think the West LA team has been doing incredibly focused work in this area for the last 2 years. I think our board should try to find ways to assist them with what I would call higher level agency intervention. So whether it's positions we want to take about how the secretary approaches HUD and his counterparts at HUD, or whether it's about process improvement we want to suggest might not have been considered, we really want our team to find a way to support the West LA leadership and take it even further. It's obviously a very material number when we're looking at that number of unused vouchers. That's the number one priority. Second priority is the next master plan revision. So the VA leadership has told us that they would like to have another master plan by 2025. So again, the cycle was 2016, 2022, and 2025. I think it's a really sensible choice. There's no clear interval specified in the original plan. So I think VA is just doing it as it thinks it's necessary. And I think as they're, it's like drawing or painting, they're filling in more of the campus and they feel like now's the time for the next iteration. And I think our board has a big role. In fact, we know Congress said we should have a big role in what that master planning process should look like. And I think there's two key things we have to focus on. What's the target size for the residential population? We know it's 1,200 right now, and we need to be asking the right questions about whether that target should move. And then I think the second major question that we ought to explore and offer advice and recommendations on is the concept of the town center. You heard my explanation, and it's very brief, and I encourage you all to go back and look at the reports yourself. But when I read the 2016 master plan, I thought it had a pretty broad and ambitious agenda for the town center. And when we got to 2022, I thought it was really pared back a bit. Then we sent it out to a third party, ULI, to study this question and try to give us some ideas and some feedback. I think all those things have to be digested and talked about in order to help provide the agency advice and recommendations. And then the final area may seem superficial or not that weighty, but I think it's a real important issue of perception, and it's the question of access to the campus. So the campus for a very long time has been a hospital, which for access reasons should be for official use only or for government business only. In other words, we don't want any interlopers in a medical area who are not supposed to be there, especially when it's a large medical area with lots of people and lots of needs. But I don't think we want to necessarily let that notion of access spill over into other parts of the campus. And I think we as a board have to offer some recommendations from a land use perspective and from a understanding of just human nature, what might be good recommendations regarding access. We've begun the conversation with an information exchange, and Rob Merchant, as director, has a lot of authority under VA regulations to decide the access he wants to establish for this. And I think we ought to be in a position to lead some discussions and offer advice to Rob about how we ought to think about access. So those are my big three. I'm open over time to suggestions about all of them. I'm open to suggestions about others. But for now, that's an area where I really want us to focus. Pass it over to you, Joe.
Thanks so much, Rob. I'll tell you, the last 2 days, I don't know about any of you who are here, but I just feel like this meeting, with all of its participation, the contributions, the tour, the preparation, the involvement, engagement from VA central office representing the secretary, and, you know, John, I have to say, it's so clear, your remarks on the first day about how you very carefully thought through who needed to join this board at this particular point. And it's obvious. I mean, you know, my fellow new members that we've just come on board, I just have to say to the enduring members, learning from what you have done and knowing that with our combined expertise, we really are in a position to support the VA as it continues to embark on this journey. And, you know, this is truly, it's work worth doing. And, you know, to make something look effortless really takes a lot of work. And I just have to give a shout out to our note takers here, to our coordinators over there, making all the travel arrangements. That's you, Joe Friddle, and people who have, you know, contributed over these last 2 days, who have come, members of the public, stakeholders. It's really, I didn't know what to expect coming to this meeting. I knew it would be memorable, but I'll end with you, Rob. The thoughtfulness, the leadership that you have put into preparing us to really just hit the ground running, from the listing of all past recommendations, but your commentary, your observations, your way of giving us insights to what's come before, not trying to coerce or shape or unduly influence our opinions, but just to give us some context. I don't know how over these last 2 days we could be better prepared as a board to truly march forward, build on the progress that's gone before us, and it doesn't happen by accident. So big round of applause, shout out for Rob and your leadership. Thank you so much.
That's a very nice compliment, and all I can say is it is work worth doing. And I think we all know that there are times that can't say no to the work because the work is that important. All right, so Meg, thoughts?
I certainly, on behalf of the secretary and all of us here who work in different roles in central office, thank you all for your dedication, your focus. It's not easy to stop everything else that you have to do and focus in on a couple of days on one particularly meaty topic. Really enjoyed all the discussion, all the questions. You know, I'm here to support you and provide you with whatever information it is that you all need. So if there are topics, if there are things that you want to learn more about, hear about, I can really reach into any area of the organization and get that set for you to be a part of either, you know, an online meeting or or just some information to send out or a presentation, whatever makes the most sense. I'm happy to do that because there are a lot of different topics today that really fall outside of the healthcare arena, right? Obviously, a lot of what we're doing here is around the fact that we're in a health setting here in the hospital, but certainly can provide some more insight into work we're doing with other than honorable and some other populations that would go outside of what we do within healthcare and VA. So happy to do any of that. I'm thrilled to continue to be a part of this and really look forward to the next discussions in the next meeting.
We're going to be needing to recruit new members once again later this year, as Rob mentioned yesterday. So start thinking about candidates. Welcome to the board. Welcome aboard. We're really excited to have y'all, and to our existing members, thank y'all for your continued service, and to the chair and the vice chair. I think this is the best meeting we've had, and I think we got a good compliment from one of our stakeholders earlier about the progress not only made by the fact of by Rob Merchant and then the incredible GLA team, Sally and John, and even Steve, Braverman, too, so. The last thing I'll say before handing over to Keith for a last word is like, this room was used during COVID as the vaccination site, and I got my first booster shot, like probably where Brett is over there in like a cubicle with a physician or a nurse. And it's incredible to think about how far we've come in the last 3 or 4 years as a people, but just hats off again to Rob and Steve and your incredible staff who led this community through a very difficult time. And it's really nice to be in person without masks on, because our first few meetings were virtual and with masks on. So really, really great to be with y'all.
Keith Harris, I want to echo everything so far. I think that I really thought a lot during the tour yesterday about how much has been accomplished. Those of you who are new to this, had we done that tour a year ago, you wouldn't believe the difference. The number of new units going up right now is astounding. And that's major kudos to the team here, both on the planning side and the services side, but also to all the development teams that are working on this. I think they deserve a tremendous credit. And then I just want to say, I am so optimistic and excited about this iteration of the board. I had the privilege of being part of that selection process, and seeing you all move from paper to real life here the last 2 days is just a really exciting thing. I couldn't be more excited about where we're headed.
The expression is even better.
There you go. Indeed.
I think with that, we're adjourned. See you.
Oh. Are you flying back tonight? All right, well, talk soon. Thanks for something. Yeah. How's going on?
No problem. And to meet you.